Good morning, everyone. Are you able to hear me okay? Perfect. So good morning and welcome to the 4th Annual Mental Health Symposium hosted by Homewood Health Center. We're delighted to have you here with us here today, whether you're attending in person or joining us virtually from across the country. I'd like to take a moment to acknowledge that in addition to all the folks that are here today in person, we actually have quite a contingent joining online from across the country, from every province and territory across Canada, with a particularly strong contingent from Newfoundland. So to our East Coasters, welcome. Thank you for joining. If any of you would like to unmute and say hello from anywhere across the country, you have a moment to do so now. Okay. Welcome. It is. I do encourage you, for those that are attending virtually, please do your best to keep your camera on if you can. It just helps us feel more connected and engaged here as a community during the talk today. Sorry, I'm just trying to sort out my notes here. There you go. So again, apologies. It's a privilege here to serve as today's moderator as we hear from an engaging and diverse group of speakers, including a Canadian Olympic athlete, alongside expert clinicians, researchers, and a mental health advocate. I'd like to extend my sincere thanks to our planning and steering committees, as well as to our presenters, for generously contributing their expertise and lived experience. At this time, we will take a moment to respectfully acknowledge the lands on which we are privileged to gather. Homewood Health Center is situated on the ancestral homelands of the Attawandaron, Haudenosaunee, and Anishinaabeg peoples on the treaty lands of the territory of the Mississaugas of the Credit. We recognize that we are settlers on this land where we live, work, and learn, and we acknowledge this is a gathering place. This gathering place is home to many past, present, and future First Nations, Inuit, and Métis people. Homewood Health Center respects spiritual, cultural, and historical significance of this land, and we support the Truth and Reconciliation Commission of Canada's call to action. As an organization, we commit to a path of continued learning, reflection, and ongoing efforts to strengthen our relationship with Indigenous peoples. We honor the wisdom of First Nations communities whose teachings remind us that healing is rooted in the integration of spiritual and cultural traditions, a profound connection to the natural world, and the strength of community. Across all of Homewood Health, we are committed to embedding these principles within our care. We do so with humility, recognizing that this is an ongoing journey, one in which we continue to listen, learn, and grow. For those who don't know me, I think I know most of you, at least in the room. Certainly, I don't know you all across the country. So to introduce myself briefly, my name is Dr. Carlos Lalonde, and I serve as President and Chief of Staff at Homewood Health Center here in Guelph, as well as Executive Vice President, Medical Services for Homewood nationally. I'm a psychiatrist with a background in acute care, and I live and practice here in Guelph. I'm a proud graduate of McMaster University and remain actively engaged in medical education as an associate clinical professor and faculty member at McMaster. Advancing learning and supporting the educational needs and the development of healthcare professionals continues to be a passion of mine. It's truly an honor to be here today to host our annual Mental Health Symposium, where we have an opportunity to connect with primary care providers and other mental health professionals from the local community and across the country. Under this year's theme, Advancing Mental Health Through Knowledge Translation and Connection. Your presence reflects a shared commitment to strengthening how we support our patients across the full continuum of care. This year's program was designed in response to the growing complexity of mental health needs. Throughout the day, you'll hear practical, evidence-informed insights that can be applied to your clinical practice, alongside perspectives that remind us of the human experience behind every diagnosis. A defining element of today's symposium is the integration of lived experience. We are honored to hear from Cynthia Appiah, Canadian Olympic bobsleigh athlete, and Adrienne Patterson, whose stories offer powerful perspectives on resilience, recovery, and the importance of compassionate, patient-centered care. You'll also hear from a distinguished panel of clinical experts exploring topics ranging from alcohol use disorder and eating disorders to trauma, emerging technologies, and innovative treatment approaches. At Homewood, we believe that meaningful progress in mental health care comes from bringing together clinical expertise, lived experience, and collaboration across disciplines. Today is an opportunity to learn from each other, challenge our thinking, and ultimately strengthen the connection that will benefit the patients that we serve. Thank you again for joining us. I hope you find today's discussions both valuable and inspiring. I'd like to take a moment to say special thanks to Dr. Lisa Friars-Blitt, as well as Doug Friars, who I saw earlier, but I know he's here somewhere. But thank you very much for your guidance in shaping today's agenda. This event is accredited for 6 main pro credits. Katrina, is it 6 or 5.5? 5.5. 5.5 main point credits. If you're interested in touring our facilities, please feel free to connect with any of our treatment consultants that are here with us today. And just wanted to highlight, as in previous years, the centerpieces that are on all of your tables are created by either patients or staff in our horticultural therapy program at the health center. During breaks, I'd encourage you to pop by the booths in the hall if you have a moment and say hello to our team. And again, thank you to the steering committee and to all of you, and that your feedback is vital in shaping future educational events. This is a disclosure sign, slide, it's not a sign. I am a paid employee of Homewood Health. As you know, Homewood does offer some voluntary treatment programs across the country, some of which are paid. And at the health center here, we run a number of different programs between regional services and elective subspecialty programs. Homewood Health offers services, obviously, that may be discussed in the presentations today. All of the information that's going to be provided today is based on published peer-reviewed scientific literature and research, and we're within clinical practice guidelines. If there's anything that's being recommended off-label, it'll be identified. And in terms of learning objectives today, our hope is that at the end of the sessions today, that participants will be able to evaluate prevalent mental health issues observed with distinct patient groups in primary care and other community mental health settings. You'll be able to formulate an inclusive treatment strategy, including employing a biopsychosocial framework, employ current clinical practice guidelines tailored to addressing mental health challenges across different stages, different life stages and settings, and identify times when you might want to refer on to a specialist if you have access to that. Just a brief program overview. We'll be starting off the day with Dr. Kristen Weersink speaking about alcohol use disorder in family practice. Moving on to hearing from our Olympic athlete, Cynthia. And we'll also be learning more about eating disorders, patient perspective, trauma, and rTMS at the end of the day. I encourage you all to please ask questions. There'll be a Q&A session at the end of every session. For those in the room, I'll be passing around the microphone to ensure that people online can also hear the questions and answers. And for those online, please feel free to ask your questions either directly through unmuting your microphone or through entering your question into the Q&A section. And please provide your feedback after each session. It's really important for us to hear from you as to what's going well, what else you might want to hear about, because it really does shape future events. And it was really based on your feedback that we put together the agenda that we have for today. So without further ado, it's my pleasure to introduce Dr. Kristen Weersink, who will be speaking on the topic of managing alcohol use disorder in family practice. Dr. Weersink is an emergency and addiction medicine physician and assistant professor at the University of Toronto and McMaster University. She completed her MD at the University of Ottawa and her emergency medicine residency at Queen's, along with a fellowship in addiction medicine at CAMH. Sorry, I apologize. I apologize about. I only read half of your intro. Her work focuses on substance use disorders, harm reduction, and integrating addiction care into acute and primary care settings. She is also part of the addiction medicine program at Homewood Health Center. Please join me in welcoming Dr. Kristen Weersink.
Can you hear me okay? Oh, thanks. How's that? That's all right. Okay. Good morning, everybody. Thank you for coming. My name is Dr. Weersink, Kristen. As I was so kindly introduced twice, thank you for the double clap. Sorry about the premature entry. So I'm going to talk to you about alcohol use disorder today, and I've called it hidden in plain sight because what we know is that it's underreported and under-recognized in many settings, and what we're talking about today is primary care. My disclosures, I work for the Homewood, and as Dr. Lalonde had mentioned, my practice is primarily in acute care settings, so I'm emergency physician. I do outpatient addiction medicine and have since 2020 in Toronto, and then now at the Homewood at our inpatient rehab center. And so I'm speaking about primary care, but recognizing you guys are the experts in primary care, and I don't often actually work in that setting. I don't have any other financial disclosures other than Homewood Health. And as Dr. Lalonde alluded to, we're trying to mitigate potential bias. Please let us know if you find something that we are overlooking. These are my learning objectives for today. We're going to keep them pretty broad and go into a little bit of detail. And I think that I put too many slides in. I was too excited. So I'm going to skip over a few of them to really try to keep to the time of 45 minutes so that we have 15 minutes at the end to get those questions that are relevant to you. So as we know, this slide just tells us alcohol is prevalent. It's a reminder that it's part of our everyday life. It's embedded in our culture, and it's the most commonly used substance in Canada, becoming more and more available now in grocery stores, convenience stores. I think that things are changing. You can bring your own alcohol different places now. And so these pictures are just from a Google Images search of wedding, alcohol, dinner with friends, alcohol, sporting events, alcohol, vacation, alcohol, barbecue, alcohol. And so it's everywhere. And I think this is important to reflect on because patients also don't always recognize when they're drinking in a risky way because it is so commonplace to do. According to the 2023 Canadian Substance Use Costs and Harms Report and the Canadian Community Health Survey in 2022, approximately 18% of Canadians aged 15 years and older met criteria for alcohol use disorder at some point in their lives. I thought that was a pretty high stat, so we're thinking about maybe 1 in 5 in your practice meeting criteria for alcohol use disorder at some point. About 3 to 4% of those are experiencing that in the past year, and the highest prevalence was seen in young adults aged 18 to 34, and specifically in males. Recent Canadian data suggests that 4 to 7% of adults seen in primary care have alcohol use disorder, with higher rates of hazardous drinking. However, routine screening is infrequent, and the true prevalence may be higher than documented in EMRs. The way that this data was pulled was just from looking at EMRs, and there's not a lot of formal screening that is done, or at least documented as done in these studies. So this number is probably higher than this, but even still, that's a pretty decent number to be in your practice with alcohol use disorder. Oops. Okay, sorry. This first study I just thought was important to highlight. because I thought it was interesting, published in 2020 by a few folks in downtown Toronto at UHN, primarily in the Emerge. And so what they were looking at was mortality rate amongst patients who present with alcohol-related visits in the Emerge. All comers for alcohol-related visits. And they found that all-cause one-year mortality rate was 5.4% overall. That is high. 5% of people who come to the Emerge for an alcohol-related thing will die in that year. That's if we think about what we care about in terms of percentage that we're okay missing in terms of PE, how much we do for the query TIAs with a numb hand, to try to prevent that outcome. This is an important opportunity, I think, for potential intervention. I'm not sure how to get the other. Okay, that's okay. There was just another report saying that polysubstance use is common. Oh. Okay, I'm gonna. Whoa. Are you helping me over there? Okay. Sorry, everybody. Okay, this is Margaret. We're gonna skip to Margaret. So I thought we'd frame this in a case. I just have two cases that we're gonna go through together, and I'm hopeful that this is a patient that you may see fairly commonly. Margaret T, she's a 74-year-old retired school teacher who presents to your family practice for routine follow-up of hypertension and type 2 diabetes. She lives alone since her husband passed away 18 months ago. Her daughter accompanies her today and privately mentions that her mother has seemed more forgetful and has had 2 falls in the past 2 months. Her past medical history is just significant for hypertension, diabetes, osteoporosis, and mild anxiety, which she's not on any treatment for. And her medications are listed there. This is from your chart review and your EMR. And Margaret appears pretty well groomed, but she's mildly anxious. And the only thing that she is reporting to you is that she has occasional insomnia for which she sometimes has a glass of wine to help her drink. Is this a common patient in your practice? Many things to think about here, right? She's in this geriatric population. Is she driving? Do we need to formally review cognition? Have we reviewed cognition before? What about her blood pressure control? Is there polypharmacy going on? Are these meds accurate? Is she taking anything else at home? And how many with this story would ask about her substance use? In this alcohol use disorder talk, you should. And so you get a little bit more information from your visit. Her blood pressure is 180/75, previously was very well controlled. So this is a surprise number for you. You make sure that your nurse is repeating it. She's in a quiet room, all of that stuff, and it stays high. Her heart rate is 95, SpO2 is okay. And other than appearing mildly anxious, her physical exam is normal. And you had done blood work prior to her coming in, and what you see is a mildly elevated AST, normal ALT, her GGT is a bit up, her MCV is a bit up, her platelets are a bit low, and her HbA1c is more out of control than it was previously. And so there's a few clinical clues that alcohol could be playing a role. Many other things could be going on, right? You've just got a little bit of history. The point with this is that she's got recurrent falls and new cognitive complaints, worsening glycemic control without clear explanation when you dig down in it, elevated blood pressure despite previously having good control, and her lab pattern can fit with alcohol use, and a recent bereavement, which also increases our risk of using substances to cope. This is Ryan. He's the next patient you see. He's 28 years old. He's an unemployed software developer who presents just for a refill of his sertraline that he's been on for a long time. It's been the same dose. He takes it daily for depression, and he's also requesting a new medication for sleep. He describes worsening insomnia over the past 2 months, low motivation, difficulty concentrating, intermittent epigastric pain with nausea. And he kind of attributes all of this to stress after losing his job 3 months ago. His past medical history is significant for MDD, GAD. He had one previous short hospitalization at 24 years old for suicidal ideation, no attempts, nothing else. And he's just on that search really. You note in your chart, you also have a history that includes a family history of alcohol use disorder. His father deceased at 52 years old from cirrhosis, and his mother also had depression. You astutely ask about substance use, and his answer is occasionally cannabis, no illicit drug use, and I drink socially, nothing crazy. His vital signs are there, pretty okay. A heart rate of 98 is a little bit high in this young guy, but within normal. And you notice his eyes look a little bit yellow. You do a more pertinent physical exam with his nausea and epigastric pain, and you also think that you feel hepatomegaly. It's a bit tender. He's got mild bilateral pulmonary erythema, and he has a fine resting tremor when you notice him doing things and when you're doing your physical exam. No asterexics, no ascites. And you had done labs prior to him coming in on a routine basis, and you see that his liver enzymes are a little bit out of whack. His AST is high, his ALT is high, GGT, Billy, MCV, and his platelets are a little bit low. And so several features in his presentations should raise some suspicion beyond the stated reason for the visit. Physical exam findings are suggestive of alcohol-related liver disease. His laboratory pattern, the AST to ALT ratio of more than 2:1, in combination with the other findings here, can raise our suspicion again. And then he's got a few things that put him at risk. He lost his job. That often leads to an escalation in substance use or a trigger for substance use, maybe worsening depression and insomnia despite antidepressive therapy that was previously stable. Is that something that happened in his life? Is our substances contributing? So you probe a little bit further and you decide to ask, how many times in the past year have you had more than 5 drinks a day? And this is an NIAA single question screen. If you want to use one question to screen your patients, you can use this one. Brian pauses. He says, maybe a few times a month. And on further exploration using motivational interviewing, he reveals he's been drinking about 10 to 15 standard drinks daily for the past 8 months, escalating after his job loss. He drinks primarily alone at home, starts in the early afternoon, but he has experienced morning shakes before. And he had a blackout-related fall a few weeks ago. His roommate has expressed concern that Ryan has been dismissive about. So we'll come back to those. And first, we'll just go through how to diagnose alcohol use disorder, how to treat, and then we'll come back to those 2 cases. Hoping that you could just, in the meantime, reflect on what you might do. Do you have a system where you practice, where you have a screening that you use for most patients? Do you refer on? Do you personally take these patients on? And hopefully we'll feel a little bit more comfortable by the end of this talk. Alcohol use disorders in the DSM-5, there's 11 criteria, similar to all substance use disorders, just substitute alcohol with the other substance. And the more criteria you meet, the more severe your use disorder is. And so all you need are 2 criteria to get mild, and that includes tolerance and withdrawal. Important to note, if it's a prescription medication that develops tolerance and withdrawal, that doesn't count for alcohol. It's rarely prescribed. I have seen it prescribed for a tremor once by a neurologist, but I wouldn't advocate for that. And so these 11 criteria can all be boiled down to a loss of control, compulsion to use, cravings, and use despite negative consequences. And just a quick plug to note that we often think of alcoholics or patients with alcohol use disorder as those who drink every day, but there's also a binge pattern of drinking that can be equally detrimental and dangerous and impactful on the patient's life. And so a definition of a binge is more than 5 drinks in one setting for men and more than 4 drinks in one setting for women. And this is because this number for most people will lead to legal impairment and increased risk factors for death from any cause. So there's alcohol use disorder, and then there's at-risk heavy drinkers, probably more common, and I would guess very, very frequent in our society. These are people who are drinking above low-risk guidelines. They're moderate drinking. They haven't had the serious consequences yet. They don't have withdrawal when they stop. And these people really benefit from early intervention. And education, I think, is always beneficial. And especially at this stage, education is key. People know they're not supposed to drink too much, but when you ask them, why aren't you supposed to drink too much? What can it do? Most people don't have a specific answer. One of the ways that you can start to intervene is by using screening, brief intervention, and referral to treatment, or SBIRT, which is a fairly broad category, but it just means asking the question, and if something comes up, referring to treatment. This has been shown to decrease heavy drinking, increase motivation, and increase connection to care. And on the right there, I just have the wheel of change, the stages of change. And so your intervention, how you approach a person depends on where they're at. And that would be a good important thing to start with. Are they pre-contemplative? Then maybe education is the piece that you're going to start with. Are they ready for change? Then we're going to be a little bit more aggressive and upfront in what we recommend to our patients. Motivational interviewing is a technique you can use. I didn't learn any of this in my residency until I did my addiction fellowship. And now I try to use it almost every day in the Emerge and in my practice. It's not a counseling technique. I'm not a counselor. I don't think I should be doing that. But MI is a collaborative, goal-oriented style of communication with particular attention to the language of change. It's designed to strengthen personal motivation for and commitment to the specific goal by eliciting and exploring the person's own reasons for change within an atmosphere of acceptance and compassion. A little bit of a push-pull. It's a way of structuring conversations so that clients and patients are more likely to hear themselves talk about a desire and a need to make important changes to meet their goals. So starting by identifying a goal, connecting it to how substance use is impacting that goal, and kind of trying to guide them so that they come up with the solutions and they come up with the motivation to evoke that change talk. You can incorporate it into any visit, not a dedicated counseling session per se, and it should be quick. So it shouldn't take extra time. These are some of the steps to do motivational interviewing. First, build rapport, explore the pros and cons. Makes a big difference if you already have a rapport with the patient and they trust that you are looking out for them. And so most patients that you'll see, you'll have a relationship with them already, and hopefully we'll already have this rapport. Exploring the pros and cons with them, and more than just saying, here are the pros, here are the cons, getting them to try to tell you what the pros and cons are. Provide feedback, explore readiness for change, and then start to negotiate an action plan. And that action plan may be, can I give you information? Can I ask about this again? And that's our action plan moving forward. We're going to slowly move you on that spectrum of change. Principles: express empathy, develop discrepancy, roll with resistance, and support self-efficacy. It doesn't work too well when somebody's really resistant to fight them or come up with it often elucidates defense, and people are mostly ready to defend what they're doing. And when you ask things in a different non-judgmental way, they actually open up quite a bit, even if the first thing that they say is, I know, I'm not supposed to drink. You're like, no, I just wanted to ask, what does it do for you? Okay, interesting. What else could we do? Does anything else do that for you as well? You know, it helps me sleep. What else helps you sleep? It makes me feel relaxed. Is there anything else in your life that you do that makes you feel relaxed? Is there a healthy coping strategy we can develop that will take that place, fill that need? So we'll go into the medicine again of alcohol withdrawal, and then we'll come back to the cases at the end. Or alcohol use disorder, sorry. Speaking about alcohol withdrawal, when people are drinking regularly, daily, there's an inhibitory stimulus all the time, you take that away and you get alcohol withdrawal, which is an neuroexcitatory state. It's a fairly predictable course when compared to other substances. Starts within 6 hours of cessation or significant reduction. So it's important to note that, this is one of the learning points we learn in our acute care is you can measure an alcohol level, but that alcohol level doesn't matter. It's the patient in front of you. If they've reduced their alcohol and that alcohol level would be legally impairing, but they are in withdrawal, you treat their withdrawal. You don't wait till it's at 0, right? Sweating, tachycardia, tremor is one of the most reliable and objective signs of withdrawal, but it's not going to be present in everybody. This is a bilateral intention tremor. It shouldn't be very different from one side to the other, but you kind of have a little bit of asymmetry. And the other thing I wanted to touch on here is at the end, complicated withdrawal is seizure, death. This is what we're worried about. Delirium tremens, a little bit more delayed. If the seizure happens outside of 48 hours, maybe we need to do a little bit more digging into why that seizure happened. And alcoholic hallucinosis is something that's pretty interesting that happens early on, different than delirium tremens. Most of the time, the patients that I've seen who've been experiencing this are calm, and they're just talking about, one guy I remember was talking about at St. Mike's in the Emerge, he was talking about an elf in the corner, and he's like, do you see that? No, I don't see that. Okay, I'm going to increase your benzodiazepines, and then we got a bit more on top of it. He was calm. He wasn't overtly delirious yet, but he had some hallucinations that were happening. So the people in your office aren't usually going to come in acute withdrawal. They will usually go to the emergency department right away or take care of it at home. This is something that is, this is a JAMA article published in 2018 that looked at this question, who will develop alcohol withdrawal? And they looked at a hospitalized population, but I think it's still pertinent to the outpatient setting. This review lists a few different methods and screening tools that you could use. The most common, the most well-validated with a high sensitivity and specificity would be the Prediction of Alcohol Withdrawal Severity Scale, or the PAWS. This is small. I know you can't really read it. That's not the point to read it. The point is to know it's there and to look it up if you need. If the patient scores more than 4 on this, and this should be clinician administered, then they are high risk for complicated withdrawal. That helps you decide who you are able to treat as an outpatient in your office, at home, in an outpatient non-medically supervised detox versus who you're going to recommend going to the hospital or having a medically supervised plan. The American Society of Addiction Medicine recommends this set of criteria for outpatient management. In general, patients who've been drinking at least 5 to 6 drinks daily for more than a week are at risk of going through withdrawal. And if you can remember one question from that previous, or most important question to ask a patient is, have they had a history of complicated withdrawal in the past? That is the best predictor of future complicated withdrawal, and complicated withdrawal being delirium tremens or seizures. This table was based on some guidelines from Medify, which is a great website if you haven't looked at it. It has a lot of resources for emergency and primary care. And none of this is super groundbreaking, but the more medically complex, the more substances involved, the less social supports, pregnancy, suicide risk, you're not going to treat those people in your office. You're going to send them into a medically supervised setting. A lot of addiction medicine is gray, though. There's not a ton of black and white. So just to know, sometimes what I'm recommending is different than what you'll see in practice and what you'll do practically, because, patients also have a choice and they will only do they don't always do what you tell them to do. So before starting to treat, we're going to tell them, okay, if we're choosing office-based management, which I'm not sure how feasible that is in most of your practice settings, but we'll talk about it just in case. Before treatment, we're going to say, okay, take your last drink the night before and then show up to our family health practice, and we will assess you and watch you throughout the day. If the patient comes back to you and they are intoxicated, reschedule or consider a different management plan. Use a validated withdrawal scale. I'm just going to talk about 2 briefly. The CWA is the one that we most commonly refer to. The SHOT is a short one. That's essentially a truncated CWA scale that was validated in the ED in Toronto at St. Joe's and St. Mike's. And the medications we're going to use is generally benzodiazepines. So we'll get a little bit more into detail about that. Benzos are first line. They act at the GABA A receptor. and they are the standard of care. All are equally efficacious. We just use different ones because of their pharmacological properties. Diazepam is generally the fastest onset. It can be given in many different modes. In your setting, you're going to be giving it orally. It has a long half-life, which we like because it can kind of auto taper out, but something to be concerned about if patients have liver dysfunction, because it is metabolized through the liver using our CYP enzymes. And so the other choice I would choose is lorazepam if we have an elderly, more complex, multiple other sedative medications on board, or somebody who has some liver dysfunction because of its different metabolism and because of its, it won't accumulate the same way diazepam will. Both of them have fast onset, diazepam 2 to 5 minutes and lorazepam 15 to 20 minutes. These are good because they both prevent withdrawal symptoms and seizures and treat seizures. So, you know, if things go south in your office, you can still give that benzo and then send them into the hospital. This is the SHOT scale. So it was made by 2 Emerge docs in consultation with addiction docs, and they dropped 4 items on the CWAS scale. The SHOT is an acronym. It stands for sweating, hallucinations, orientation, and tremor. If the patient scores more than 2, it indicates a need for treatment with benzos. Discontinue treatment when the score is less than 2 on 2 consecutive occasions. The CWA is just longer. It takes about 5 minutes to do, but much more frequent, and most practice settings are comfortable with this. This is what we use most often. This is what we use at the Homewood. This is what we use at GGH. And when you meet criteria, then you're going to treat with benzos. When you are scoring less than 8 times 2, you can start to think about, okay, we've treated this, we're safe. Symptom triggered is preferred over a prescribed time. And this kind of just makes sense. It's individualized treatment. The studies that I've looked at have mostly been in acute care. And what it shows is that you use less benzos overall, less complications from that. And so if you have this ability, symptom triggered is, I think I went through most of these. And then the main thing is when to know your treatment has failed. If you are trying and this patient is in your office, you've been doing the CWAR shot every 1 hour, you've been giving them diazepam, and now you've given them a total of 60 milligrams of diazepam, or you've given 3 to 4 doses and you are not seeing any improvement, either there's something else going on or they need an escalation in therapy, and you should send them to Emerge or back off and take a different approach. You know, this underlying comorbid illness complications arise, if they get an arrhythmia, if their vital signs become unstable, but you won't really know fluid imbalance or electrolyte imbalance in your office, so I should take that out. And then the follow-up piece. This is a really important piece, and I don't want you to forget about this when you're treating withdrawal. You've treated the withdrawal, the medical risk is over. Now this is a great time to start an anti-craving medication. Advise some community support, some follow-up, and check in, close follow-up 1 to 2 days later. This could be a virtual follow-up. This could be one of your nurses, whatever it is. If you think that they're still feeling significant symptoms, but they're safe from a withdrawal management point of view, then you can give them some benzos to go home as well, to take as an as-needed basis, and just give them the warning, you know, take these. If you drink, do not take these. Home-based management is the other more common option. I would say if the patient is safe for office-based management, they're likely safe for home-based management. Best when they're uncomplicated, not elderly, and have somebody with them who can watch them and supervise and pull the trigger if things are not going the right way. Again, same kind of thing, prep them the same way, have your last drink the night before you're going to start this, and have a support person at home to help them decide when they're going to take their benzodiazepines. Gabapentin is a really good option in this patient population who've had mild to moderate withdrawal, nothing severe, they're otherwise uncomplicated, they have a support person. You can use gabapentin, and what I usually do is, in the emergency department anyways, I will give them a few doses of benzos if they need, or if they're not in withdrawal yet, they want to, and my assessment is that they're mild, and I think that my clinical judgment is that they'll be okay. I give them a prescription for 300 milligrams of gabapentin TID for 7 days. And I say, if you end up drinking, don't take this. If you get too sleepy, skip a dose. And most people tolerate this really well. Or you can do diazepam. And I just put what I usually do for diazepam. I know I talked about symptom triggered is a bit better when we look at acute care and evidence-based, but when I'm doing outpatient management, I will give a 10 milligram diazepam QID for one day, and then TID, and then BID, and then daily. And there's lots of these kind of protocols that you can look up. I really like Medify as a resource if you want to choose one. And then follow up. Always make sure that you're following up the next few days. A bit more about gabapentin. It's a GABA analog. We don't understand a ton about how it exactly works, but it does help us within our inhibitory tone. And what I prescribe is 300 TID for 7 days. And I don't usually taper afterwards. People are fine. You can use this as a withdrawal management strategy. You can also use this to continue treatment for those protracted withdrawal symptoms and increase the dose to 600 TID, which is the anti-craving dose for gabapentin. So it's a nice medication for people who also have a lot of concurrent anxiety. Pregabalin would be the FDA approved, first line for anxiety. Gabapentin is its cousin. We can extrapolate that a little bit. And I find people who have a lot of anxiety as their primary withdrawal symptoms do well with gabapentin. Don't forget about the adjuncts. Just prescribe it everybody thiamine. We don't have to worry about it as much. If you're worried about Wernicke's, they should be in the hospital. They should be getting parenteral, IM, or IV thiamine. It's water soluble alcohol, both for several reasons with decreased PO intake, only drinking alcohol, and also its impact on the metabolism of thiamine and glucose causes a deficiency, and it has less oral absorption when you have a chronic alcoholic. So just something to think about and don't forget about. This is why we care about thiamine, because we don't want Wernicke's encephalopathy to happen. It's a reversible syndrome characterized by confusion, ataxia, and ophthalmoplegia. Interestingly, only 16 to 20% of cases will have this whole triad. So if you get one of those, be cautious, send them in, and it's easy to give. And you cannot overshoot thiamine, in my opinion. Failing to treat with thiamine appropriately can lead to 20% mortality, and 85% could develop Korsakoff syndrome. Rare syndrome, I've seen it twice, and they are super, super, super difficult to treat in subsequent care visits because you don't know what's going on. It's an irreversible syndrome characterized by confabulations. Detox, medical versus non-medical detox. In Ontario, what I know of is we have medical detox at CAMH that you have to plan for. We have medical detox at Homewood that you have to plan for. In the moment, if the patient is ready right now, they either need, if they need medically supervised treatment, the easiest answer and really the only answer is the emergency department. If you have the ability to plan around this and your patient is willing to engage and has the resources, then you can do a medically supervised otherwise. Guelph doesn't have any non-medically supervised detox, but there's quite a few places in the surrounding area. And we have a list of resources. I think we have a booth with the treatment team that you could go to afterwards if you need some, if you're looking for some more resources for this. Other options, you say the patient doesn't want to stop right away, or you don't want them to stop right away. They don't want to go into, you're worried about the risk to their health when they do stop right away. You can talk about a taper. And these are some tips to talk about a taper. First, you need a baseline about how much they're drinking. So that'd be the first step. And then try to reduce by no more than 10% every 2 to 3 days. Set a goal. This makes it more successful. Record intake. Limit time at trigger events in people. Eat food when you're drinking. Avoid trigger beverages. Pace the drinking, sip it, and alternate with non-alcoholic beverages. This is one of the things that I would try to get the patient to give you these ideas and to how they're going to do this. I'm gonna slow down, I'm gonna stop. I've decided I'm gonna stop. Common thing for people to say, to really think out a plan is not as easy. And so sitting down with them, taking this time is what I would recommend if you decide that a taper is the best option. So anti-craving medication. Naltrexone is first line. It has the best evidence to reduce heavy drinking, but also has really good evidence for cessation. It's an opioid antagonist, so we're not going to give it to anybody who's on opioid agonist therapy or uses chronic opioids or has a pain condition where they often need opioids for pain. It acts by attenuating the mesolimbic response to alcohol-associated cues, and you can initiate as a harm reduction strategy or to reduce heavy drinking, or if patient's goal is abstinence. There's no good evidence for this approach, but this is how I learned, and this is what I find seems to work best for patients, is start with a half dose for 4 days and then increase to the full dose. The full dose is 50 milligrams. There is some evidence for an increased dose at 100 milligrams. So if you have somebody who's getting partial benefit on 50 milligrams, worth a try to increase it up to 100 milligrams. You can also use naltrexone as a pill-in-pocket approach. Like this is called the Sinclair method. And this is for people who don't want a daily medication. Works, I think, pretty well for those with the binge type patterns with predictable triggers. And so what you can do is say it's somebody who drinks on the weekends and is always getting into trouble with their drinking. It's out of control as soon as they start, but can keep it under control and does not drink during the week while they're at work. This can be something they take every Friday, Saturday, Sunday. I usually advocate for daily use, but if the patient's really resistant, this is a way that you can use it, and it has some evidence, some good evidence to say it also reduces heavy drinking. And then always, all of these medications are best if used in combination with some counseling techniques and some more support. NNT is 9 to 12. Just to put it in context, because NNT for me doesn't mean a whole lot. That's a low number, but NNT for ASA in secondary prevention is 250 to 300 and something. I'm sorry, I can't see. Can you scroll down to my notes? Or, and 50, no, sorry, is 50 for secondary prevention of any major cardiac event, and between 250 to 361 as a primary prevention for a heart attack. And how often are we prescribing aspirin? So just to put it in context, these do work well. They're well tolerated. Most of the time, the side effects that I hear about are dyspepsia, some nausea, diarrhea is not super common, headache, and more lately, for some reason, I've been hearing a lot about a little bit of sedation. So sometimes I just switch it to nighttime dosing, and that's enough for people, and that's tolerable. Again, only contraindication really is opioid use. You can see a hepatitis, a reversible hepatitis with this. And so what you want to do is measure liver enzymes. You don't have to measure them before you start, but around the baseline, and then measure them after, say, 3 weeks of treatment, just to make sure that you're not getting a bump. And if they're bumping up AST, ALT 3 times normal, then I would take them off of it and consider an alternative. If they have known cirrhosis, depending on the patient, if they're really complicated, I wouldn't start them, but I would talk to their hepatologist before doing anything. It's pregnancy category C. So I put in brackets, use if benefits outweigh risk. There's some animal studies that show some preterm labor. There's not really much data to say it's very detrimental in humans, and we know that alcohol is a teratogen, so it's all about risk benefit in this population, and maybe best to do in consultation with an addiction specialist. And it's cheap, and it's covered by ODB. Acamprosate is also first line. I use naltrexone more just because it's a once-a-day medication, but acamprosate is equally good. It acts on our glutamate receptors, our NMDA receptors, and can help with some of the post-acute withdrawal syndrome. The best evidence is to start it a few days after stopping alcohol, but I don't wait. You take the opportunity that you have, and I still find it can be really helpful. Again, I started as 333 TID, and then for 4 days and increase it to 666 TID, which is the effective dose. Do a little bit of renally dosing. If the creatinine clearance is between 30 and 50, you're going to keep them at that lower dose. And that's the main thing to think about in terms of contraindications. If that creatinine clearance is less than 30, I would avoid it. And it's a pregnancy category C with less data than naltrexone. So just a risk benefit discussion with your patient. And the main side effect is diarrhea, which if it happens, it doesn't usually get better with time. So if it's an intolerable side effect, it's enough to switch for me. It's also cheap, and the NNT is 11. Gabapentin is second line. It's not FDA approved, but I don't know that it will ever get FDA approval. Naltrexone and acamprosate and disulfiram are FDA approved. GABA indirectly modulates, gabapentin indirectly modulates GABA, and it can be used, as we talked about a little bit earlier, for withdrawal management and as an anti-craving medication, especially with those with concurrent anxiety. I sometimes will use naltrexone, and then if anxiety is a really prominent symptom and they're still having a lot of cravings and having trouble with their alcohol, then I'll add gabapentin and see where we get with that before moving on to something else. An NT is good, 8 for abstinence, 5 for no heavy drinking. Side effects, dizziness, drowsiness, fatigue, headache, and then contraindications, careful with renal dysfunction, third trimester pregnancy, and caution in those who are older, go slower, maybe don't titrate up to the max of, or to the standard of 600 TID, and with concurrent opioids and benzos, that increases our risk as well. Disulfiram, this is what can be referred to as antabuse, and the mechanism is that it inhibits the metabolism of alcohol, and so it causes a marked rise in our blood acetaldehyde, causing unpleasant effects, flushing, nausea, vomiting, headache when alcohol is consumed. Feels terrible if a patient has this and drinks. They only really do it once if they're experimenting. It promotes abstinence, and the dose is 250 daily. The evidence is best for supervised administration, because if you don't take it, then it doesn't work, right? Contraindications, cirrhosis, pregnancy, unstable cardiovascular disease. This speaks to the reaction if they do drink, and the body's ability to take that sympathetic surge. Side effects are minimal if not drinking, and then again, if you drink, then this. I've seen this very few times, and one patient recently who's admitted to the Homewood used it in combination, was on naltrexone for anti-craving at baseline, and then used disulfiram, had it at home, because when his wife went away, that was a really tricky time for him to avoid drinking, and his impulse control was a difficult thing. So he would take it when his wife was away and know that he cannot drink in these times. And so that's how he used it. You can be creative with how you use it if this is something that your patients are looking for. Topiramate is also would be considered a second line medication. I've used it more frequently recently than I had in the past. I found people just didn't tolerate it before, and for whatever reason, the patients I'm seeing now tolerate it a bit better. It also moderates our GABA function and acts on the mesolimbic pathway. You start at 25 daily and then slowly increase to 300 daily. This dose range can vary a little bit more than the other medications, and usually you're doing it in a BID pattern once you're increased above 25. Side effects, paresthesia, taste perversion, concentration, attention, word finding difficulty. I find this sedation, this central effect, is the piece that people don't like most, and contraindicated in pregnancy. It's a known teratogen. So if you're prescribing this to your young fertile women or old fertile women, then you want to make sure that you've got contraception on board as well, okay? Or at least talk about it. So back to Margaret. You screen using the Audit C, which is a standardized screening that you could use in your office, and realize that Margaret meets criteria for moderate alcohol use disorder. She's receptive to your concerns. She's eager to reduce overall risk and maintain her independence, which is the goal that you used to start to have her come around to change, and keep her driver's license. You work with her daughter to develop a safe home-based withdrawal management plan with phone call follow-ups at day 2 and 3. You discuss and start naltrexone concurrent with a 7-day course of gabapentin, and the patient does well. 12 months later, her BP is well controlled. You haven't changed any other meds. Her HbA1c is in target, and her anxiety is significantly improved. Ryan declines your suggestion to go to the ED for withdrawal management. He met a lot of the criteria on the pause. He was drinking heavily, getting withdrawal symptoms before he had his next drink, and he decided to taper on his own. He decided to follow up with you the next week. You said, okay, this is my suggestion. You talked through that. And he's actually been able to reduce his drinking. His repeat liver enzymes have improved. He's set up with outpatient addiction counseling with concurrent CBT for his anxiety and depression. and he agrees to a camp crusade and tolerates it very well. When he returns next, you've ordered the ultrasound and the fiber scan. It's negative for cirrhosis. His liver synthetic function is improved, and he is now alcohol-free. So great job with Ryan and Margaret. The take-home points from my talk today, essentially, we'll summarize. Patients with high-risk drinking often go unrecognized and without treatment. And the Canadian guidelines would say we should screen everybody in our practice. Triggers are everywhere. Anti-craving medications are safe, efficacious, affordable. They're easy to prescribe. There's not many interactions. And think about safe drinking, withdrawal management, craving management, and the Ministry of Transportation reporting too, as some motivators for patients and some education pieces for them. Now, I'm going to skip through some of these because I think you can get that information out with the treatment. And say thank you. Oh, I think I got too excited again. And that's all I have for you. So I'm happy to answer any questions, open it up for discussion. Thank you.
Sorry. Hello, there you go. Thanks very much, Kristen, for a very an outstanding presentation and this for some practical advice on how to manage alcohol use disorder in primary care. We have a few questions. I'm going to hand off here.
One, I guess, quick question that a couple people could different answer, but you said if there's planning foresight for the withdrawal, like at Homewood, for example, do you know a timeline? Like how long?
Question. It's a good question. I don't have a great answer for you. I'm looking at my chief over there. I know our wait list is actually good right now, but it depends on coverage. And so we have a few OHIP beds that are generally longer wait list. If they have coverage through work benefits or private pay, then it's shorter. You can check in with the treatment team and they may have a better answer for you. But right now it's actually pretty good.
And you mentioned, like you said, you can't really overshoot the thiamine. Do you tend to adjust the dose based on how they're presenting, or is there just sort of like a specific dose that you tend to tell people to
I
get?
think in the outpatient setting, I would just do 100 PO daily. And if you need more than that, they should be going in to get it somewhere else. Yeah.
Beautiful. Thanks.
Thank you. I'm wondering, you mentioned earlier in your talk about that patients will commonly say, I know this is bad for me. And I'm just wondering what your sort of spiel is on what you offer people for information on the health effects of drinking.
There's so many, right? And I think I try to cover the big ones. Most people know it's not good for your liver. They don't really know what that means. And so I try to cater it to the patient and what I think they're going to care most about or what's happened to them already. So often there's like a little bit of they feel a bit nauseous. And they say, you know how you feel this way, it can cause inflammation of your pancreas and that can make you really sick and unable to eat. And that can happen in one sitting. The long-term effects, it can affect your heart. It's associated with 7 different types of cancer. It can cause liver disease that at some point is reversible, but when we get too far, it's fibrosis, it's scarred, and we can't go back from that. And that's a really dangerous place to be. It makes a lot of things really difficult. And so I kind of start there, and then usually they're like, what, cancer? Like they don't really know about cancer. They don't really know about the heart disease that can happen with it. I didn't talk about this, but the low-risk drinking guidelines they've changed, it's to 2023, and they don't differentiate between male and female anymore. It's all about a continuum of risk, and now we know that no alcohol is the safe level. Males have a higher risk in terms of per occasion drinking with violence, accidental injuries, it seems, and females are actually more affected long-term by higher alcohol. So they just kind of decided that it was all continuum and differentiate, but they are affected in different ways. I don't know if that would be something you'd want to say, but Yeah, I don't know if that helps. It's hard. I feel like actually in preparing for this talk, I realized there's a lot more that I could cover if patients asked for it and wanted education about it. Public Health Ontario has a lot of resources if you want to point a patient to do some reading on their own.
Thank you for an excellent talk, Dr. Weersink. This is really timely. I was just attending a conference, McMaster conference on hospital medicine last week. We had a really excellent presentation on alcohol use with disorder and withdrawal by Dr. Lambda from Mount Sinai Health. During that conversation, he was quite enthusiastic about introducing phenobarbital for withdrawal. And I noticed there's an audience here from Newfoundland. This was an international conference, so we had lots of folks from the States, from the Maritimes, and actually from the territories in both Yukon and Northwest Territories where this is commonly used. I looked into it a bit more, and it even seems to be, there are some protocols from ASEP, American College of Emergency Physicians, for the use of it, and not just in an inpatient setting, but also in an outpatient setting. It seems to be actually superior in terms of safety, time to resolution of symptoms, so people feel better quicker, and wondered if you are doing that either at Homewood, or is there research going on, or are there plans for this, or do you have any comments?
Sorry, thank you for the question. I left phenobarbital out because I think about it more in and maybe it's best to say in our culture, in our setting, as an inpatient medication. However, there is more and more practice. I worked with I worked with somebody who practiced in the States in the emergency medicine. She used phenobarbital all the time, and they had protocols to use in the emerge and then send home. And the nice thing about it is that it's a super long half-life. You get control quickly, and then it auto tapers, which is wonderful, but it's also got a narrow therapeutic window. And so that's what we're so cautious about. You know, in the 60s and 70s, we used it a lot more often. Then we switched to benzodiazepines, and now it does feel like the pendulum is starting to switch back. I don't know of many places, and I don't know of, I say many, but I don't know of any places that are doing planned outpatient phenobarbital tapers. We don't use it a lot at Homewood, but it's something that we're interested in, and I've been interested to talk about how we can develop a protocol. In the medical withdrawal unit at KMH, when I was in my fellowship, they had one for specifically GHB benzo-resistant withdrawal. So it's really good for patients who either are on concurrent long-term benzos, have a sedative use disorder, and so their benzo receptors are flooded, and they don't respond that well to our benzodiazepines because they just need crazy high doses. Phenobarbital acts in a different way. It can bypass that, so it's good for those benzo-resistant withdrawal. My experience is in the acute care setting, and I'm trying to use it more so that I get more familiar with it and more comfortable, but I don't think we're there yet in terms of outpatient practice, and it's just because we're not as comfortable with it, and it has a narrow therapeutic window. But it's interesting because in the States, they are a lot more pro-phenobarb and more aggressive with it. And you're right, the findings are maybe making us feel like we are more scared than we need to be. I don't know if that helped at all. But.
Thanks, Kristen. And we have Dr. Parent here to share his perspective as well.
Fantastic question, Dr. Zlatkovsky. So yeah, I mean, as Kristen says, we don't use it as part of a protocol standard first-line therapy for alcohol withdrawal at Homewood. We tend to use it for those that are benzo-resistant. If gabapentin's not appropriate, then we'll try phenobarbital. In acute care, we'll do it in context of somebody who is resistant to benzos in the context of seizures, and we'll load them with phenobarbital. So interesting that you bring this up, because one of the mandates that we have moving forward for the addiction medicine program, as well as all of our concurrent programs at Homewood this year, is to take a look at what are the tools that we're using, and should there be a modification to our standard protocols? Phenobarbital is on the list of things for us to be considering. So great question. Kristen, I was going to say as well, for the last question around resources and how do you educate your patients on the risks of alcohol, you mentioned before the Medify website, phenomenal resource. If those here haven't reviewed that site, There's fantastic information there in PDF form. It's useful information for clinicians, but also for patients. The other really good source of patient information I've found before is UpToDate. There is great patient handouts, puts information in patients' terms to help them understand the consequences of ongoing use. Thanks.
And just to spell, it's METAPHI. So if you Google Medify, they do have that. Thank you. That's probably where I would start. They've got a lot of patient handouts. There's a section just for patients. There's a section for clinicians. There's a section for ED. They've expanded a lot, and I find their website a little more difficult to navigate than it used to be, but there's lots there.
Great. So we have one more question in the room, and then we got a couple questions online. So Ken.
Thanks very much, Kristen. I did see a couple of questions. So I have two questions, and I saw them popping up. So first question is, I saw for the acute withdrawal management use of diazepam or lorazepam. Previously, I've used chlordiazepoxide, and I thought that that is the first line, just given its very short half-life. When do you use that?
Well, long half-life with
Longer half-life than
chlordiazepam. Yes. And that's a good thing. Like that's kind of why there's pluses and minuses. It's risky if the half-life is too long and you're worried about it. That's why we would choose to use lorazepam. But to their point about phenobarbital, that's one of the nice features about it because it really treats withdrawal after you dose it, and then it just slowly comes out of the system. More common in the States, not a wrong answer at all. There's no, when I did a more in-depth literature review a few years ago, there's no good evidence to say one benzodiazepine is better than another one. We just use it based on the properties of half-life and ease of use and our familiarity with it. So diazepams kind of took over because it's fast on, it's a long-acting one. And lorazepams are alternative because it's not metabolized by the liver. It's shorter acting if we're worried about that accumulation. But that's a really good medication too, chlordiazepoxide. I just don't use it very often. I'm not that familiar with it.
Okay.
No good reason.
Thanks very much. Second question is, you mentioned acute management. I don't often have these types of patients or with this concern coming in acute withdrawal management, maybe a few times a year. So one, you're saying, well, if their CWA is kind of lower, more reassuring, then maybe you could manage them as an outpatient and just bring them in for or check in with them for very close follow-up. And then more higher concerning scores, more acute presentation to the emerge. Where does the RAM clinic fit into this?
I think the RAM clinic's a really good resource. They could, so I think that you could use them in this case too. I think if they're severe, too severe, they're getting really uncomfortable, the hospital is the fastest way to get their treatment done, taken care of. They'll go through the RAM clinic. Depends on the day, really, right? Because I think we'll have to double check these hours because they're changing a little bit. But what I remember is that the RAM clinic in Guelph is Wednesday, Friday, and then there's a virtual option more frequently throughout the day. So if they have the capacity and the ability to do that, to get there, those logistics, I think is the important part. Like referring back to what I referred to earlier is there's a lot of gray in addiction medicine, and it's a lot about the patient in front of you. Do they have the resources to get there? These are like some of the more important questions rather than the medicine piece.
Hey, do you want this?
Totally impacts how you treat them.
No.
So the RAM clinic's a really great resource. I'm sorry I didn't mention it, but you're right. The RAM clinic, you just walk in, you don't need a referral, but it takes time for that process. And so it's about the patient's ability to tolerate the distress that they're in my opinion, more than anything else. The right and wrong, the black and white answers are fairly easy. When they're super severe, you're going to send them to the hospital. That. If there's nothing, then they have some time, or you can say, okay, there's some. Hospital is not an enjoyable place to be in general, right?
Sure.
So if patients are really resistant to it, then maybe backing up and say, there's a sense of urgency here that we don't need. We can plan for this, and tomorrow the RAM clinic's open, they can plan with you, and I think it's a really good resource to use.
Thank you. So if we send them into the emerge and you're finding that it's not so severe as to require an inpatient detox, like admitting them, would you refer them to the RAM clinic or to the Homewood from the emerge?
Yeah, the way it works, so I'll speak to Guelph in general. Guelph General Hospital, because that's the context that I know. We have an addictions worker during the day, not nighttime hours, but during the day, and they are really good at connecting to those pieces. We will, in general, what we'll do is we'll manage their medical withdrawal. If they come in withdrawal, we'll treat their withdrawal till they're out of withdrawal and they're safe to be discharged. Or we get to the point where you need escalation in therapy. Phenobarbital often means step up in our setting, kind of regardless. And so either they're escalating or we're discharging them home. And while they're there, we try to get our addictions workers to talk to them, and they can set them up with either detox or going home. And most of the time what's happening is if the patients are in a stable housing environment and have the resources, they're going home, and then we're providing those resources. There's the RAM clinic. There's also True North, which is usually virtual, but they don't just do opioids. They also would assess for alcohol use disorder. The CHC, or the Heart Hub, is also a place they can walk into, and the Homewood with a little bit more planning. But yeah, we can refer to our CADS support, which can get them into Homewood too, and patients can self-refer. Did you have anything to add, Marcel, before? Oh, Rocket Doctor is another online one, yeah.
We have one more question in the room, but I just want to make sure we get to the couple of online questions. One of them, I think, was covered, asking about Librium versus Diazepam or other options. So I think we answered that question. The other one is, do you have any stats related to relapse for home/office treatment versus inpatient?
I don't. That's a really good question. I don't have stats. In general, from what I have seen, we're lacking in those kinds of statistics. Most of the evidence is for reduced drinking and the follow-up. When I talked about the screening, brief intervention, and referral to treatment, Public Health Ontario talked about a systematic review where they looked at, and it's super varied in approaches, and what they saw in general was a reduction in heavy drinking that seemed to wean with time. But I don't have a good answer for you. I don't know if anybody else in the room has numbers or a study that they've, no. Sorry.
Yeah, I was just wondering if there was a particular reason why you recommended in the acute withdrawal with treatment of gabapentin to have the 300 milligrams TID for 5 to 7 days when the anti-craving dose is 1800. Like, are you concerned about uptapering too quickly, or is there a reason for that?
Yeah, that's the study dose. I usually use either 300 or 400, but if you have a patient who has tolerance, a lot of patients will tolerate higher, but those patients who will tolerate higher, they'll tolerate higher, are usually more severe, and I'm generally using benzos for those. And so, yeah, it's just about I don't want to go too far, and that feels safe, and I've used it a lot, and I haven't seen many side effects with that dose. It just seems to work well for those withdrawal symptoms, and those people who have mild withdrawal aren't so severe. Does that answer your question? It's not a very scientific one, but yeah.
Thanks again, Kristen.
Okay, thank you.
Good. Okay. All right, folks. I'm very pleased to introduce our next speaker. Cynthia Appiah is a Canadian Olympic bobsleigh athlete whose journey is defined not just by speed, but by setbacks, reinvention, and mental strength under pressure. From narrowly missing Olympic competition to rebuilding her career as a pilot, her story offers a powerful and practical lens on mental health, performance, and personal agency. She brings a rare combination of elite sport credibility and emotional honesty about her mental health journey, making her a compelling example of true, actionable resilience. Please join me in welcoming Cynthia Appiah.
Morning, everyone. My name is Cynthia Appiah, and I am a two-time Olympian in the sport of bobsleigh. I'm going to spend this morning giving you a little bit of insight into my story growing up in Toronto and to where I am right now, having just come off of my second Olympic Games this past February. So as I mentioned, I was born in Toronto. I was the daughter of two immigrant parents from Ghana who came in the 80s and came to Canada to establish a life for their kids for better opportunities. With that, though, meant not having a lot of money. They moved to Canada with very little in their pocket, which also meant that we as kids didn't really have a lot of the resources that some of my classmates had. Growing up, I really loved playing sports at recess. And when one of my classmates mentioned that they had a rec soccer game later that evening, I ran home and told my parents, I want to do that too. Only to be met with the disappointment when they said, we don't have the money for that. I grew up in Toronto community housing, and while I never felt like we were without, we always had a roof over our head, we had food on the table. There were some things that were quite apparent that I was not like my teammates or my classmates. And sport was one of those things. Not having access to competitive, controlled, and organized sport was a bit of an upsetting moment in my childhood. But hearing that no wasn't the definitive answer for me. I learned early on in my childhood that that no is just a no in that moment, but not the no forever. And so I was determined to figure out one way or another how I was going to come across sport. And lucky for me, that came in the form of a program that the Toronto Blue Jays had with Toronto Community Housing, where over the summer, they would round up all the kids and take them down to Riverdale Park on the eastern side of Toronto and play baseball for the day. And that was my first introduction into competitive organized sport. And I knew right away I loved it. What I also learned was I have some of the worst hand-eye coordination known to man, because every time that ball came across the plate, I would look at it and then swing once it passed. But that didn't matter. I was in an environment that encouraged learning and growth, and most importantly, fun. I channeled those learnings into elementary school and into high school, where I picked up track and field, which I would say is my first true love in sport. I was a shot putter all throughout my high school career, and that opened up so many doors for me. And one of those first doors that opened was an athletic scholarship to York University. I was going to be able to parlay my athletic love, or my love for sports, and my love for academics. Growing up in an immigrant household, my parents always drove home the importance of school, and I was not going to let that up. But I also wasn't going to let up the opportunity to play sports. So over the 5 years that I was at York University, I learned a lot and I went through a lot. I wanted so much to embody everything that came with the university experience that I almost stretched myself too thin, saying yes to everything. And partway through my university experience was when I had my first mental health crisis. During my third year of university, I was diagnosed with depression at a time when mental health wasn't really at the forefront of the conversation as it is now, where it's been somewhat destigmatized. And begrudgingly and almost embarrassingly, I took the advice of a coach who saw an athlete in crisis and took his advice to see a mental health therapist. that therapist really helped me come to terms with what I was going through, helped me understand what I was going through, and that I wasn't alone, and that there were resources and tools to help me get out of what I was going through. That was my first lesson, realizing that I had a support network. And sometimes we don't realize that when we're in the throes of life and things are being thrown at us and we're being pulled in so many different directions, that there are people there who are walking this path in life alongside us, who are there to support us and make sure that we don't stumble and fall. And if we do, they're there to help pick us right back up and lead us along the right way. I do thank that coach. At the time, I didn't see it, but I thank him so much for helping shape me to be the person that I am right now, inside and outside of sport. Outside of that experience, though, I finished out my university career and then was presented with a great opportunity to try a new sport. And that sport was bobsleigh. I had heard of it, during the movie Cool Runnings. Some of you may have heard of it. Yeah. Just so you know, there's so many things I could tell you about what was real and what was made for the movie, but we'll leave that for later. But I came across a fork in the road. I could continue on with my throwing career as a shot putter and as a hammer thrower, which was a second event I had picked up while at university. Or I could leave what was comfortable and go into the unknown. And boy, was it scary what that unknown was. It meant leaving the sport that I had spent the better part of 9 years, when you include what I did in high school and elementary school, and going into a sport that was completely different from what I had done. I was moving from a summer sport where, you're working out in 30-degree weather on a good day. On a bad day, you're dealing with the rain. And I was potentially putting myself in a sport where you're hurtling down an icy track at minus 10 degrees, 140 kilometers an hour in nothing but a Lycra suit. And I thought, yeah, you know what? That sounds like a great idea. And I forged ahead. As easy as it was to say yes, there were the hurdles that inevitably come up in sport. I was a shot putter. And if you have an image of what a shot putter is, we tend to be a little bigger. And so that meant having to work through some of my, I wouldn't say eating disorders, but reestablishing a relationship with food that I had never been met with, to lose the weight that I need to lose to get into the sport of bobsleigh. That took over 2 years, working with a dietitian, working with a sport nutritionist to really understand my relationship with food was now going to change, but to do it in a healthy way. One of the untold stories, at least when it comes to bobsleigh, is how much our eating can become disordered if it's not progressed, or if it's not captured in a progressive way. And I'm very thankful that I had that opportunity to be met with someone who could provide me the pathway to eat healthy, fuel for sport, and be as dynamic as I was in bobsleigh. So moving into bobsleigh, we're now working in the time frame of 2015. My first year on the team, I'm super excited, and I hit the ground running. My first 4 races, I won a gold medal with the pilot that I was driving, or that I was sliding with at the time, and everything was fun, everything was new, everything was great. And I had built up a reputation for myself as a brakeman that you could rely on. You put sin on the back of your sled, you're gonna get a fast start, and at that point as a pilot, that's on you, but you're gonna get a consistently fast start. And I'd been building up my sport resume to make sure that I was on that list when the coaches decided who would be named for the Olympic team. Fast forward to 2018 or to 2017, and I'm building up that resume and I'm putting in the work. I moved from Toronto to Calgary because I was so determined on making this Olympic team. I was not going to leave any stone unturned. I was not going to allow myself to look back and think, did I sell myself short? Did I not do everything I needed to do to make sure I made this Olympic team? And I kept trucking along and trucking along. And then about 2 weeks before the Olympic Games in 2018, I get pulled aside by one of my coaches, and he says, "We're going to be naming you as the alternate for these Olympic Games. I'm sorry." And I just remember a flood of emotions coming through, just tears, wondering why. Can you tell me why? What's going on? I never really got that why. But looking back, I don't think it mattered, because it wasn't going to help me get through that moment. And that's where I feel like I went through my second mental health crisis. I don't think it was diagnosed at that time, but I do, looking back, feel like I went through another bout of depression. I felt my whole world just crashing in on me. Everything I knew about myself was boxed into this image of who I was as an athlete. I only knew myself in that moment as a bobsledder. And in that moment of being told I was going to be an alternate, I thought that my career was over. Unlike in hockey, where the goalie who dresses up and maybe plays like 2 minutes and the team goes on to win a medal gets also a medal, or in track and field, if you are part of the prelims in the 4x1 or the 4x4 relay, and the team that runs the relay ends up winning a medal, you also get a medal. Such a thing does not exist in bobsleigh. So going into these 2018 Olympic Games, I was saddled with doing all the training runs, which you use to qualify for the race going at the games, making sure that I stayed up late to help polish the runners, woke up early to make sure that everything that needed to be set for that day's race or that day's training was done. Do all the work and be a bobsledder, but not get to be named an Olympian. I remember crying every single night for the 2 weeks I was there in Korea, and determined to never look back on this moment again and move forward with life. Sport for me and my image and my identity as an athlete at that moment was over. And so I did my dues, and I was the best teammate that one could be. But I knew once that plane landed back in Toronto that I was going to be back into the real world and finding a job, because my love for sport had pretty much been over. On my way home to the games, though, or just before going home to the games, I was pulled aside by 2 people. One of them was a teammate of mine, Neville Wright, who I consider my mentor to this day. And he said, "I don't think your time is over in sport. I recognize the hurt that you're going through. I know you don't think this is fair. I don't think this is fair. But there's something more to you, and I would be remiss if you ended your career now." A coach also pulled me aside, and he said the exact same thing. "You're too talented to let yourself, walk away from the sport. I know it hurts right now, but there's so much more to you, and there's so much more to give in this sport." And looking back on it now, that was my support network coming back to support me in a moment of crisis. They saw the hurt, they saw the pain, and they were doing their best with the tools that they had available to help a wounded teammate get back up. Those 2 people are critical for the decision that I made moving forward. Had I not had those conversations, had they not pulled me in, I don't think I'd be here right now as an athlete, as a bobsledder, as a 2-time Olympian. I went home with those thoughts in mind and really thought it over. What do I do now? I can't come back as a brakeman. That saga's over. I don't want to put myself in that moment of pain again. If I put in another 4 years of hard work and determination and every dollar spent going into the sport just to have the same result. And so one more person came through, and this was Shelly Ann Brown. And for those of you who don't know her, she was the brakeman on the silver medal winning team at the 2010 Vancouver Olympic Games for women's bobsleigh. She was also, at the time, one of the few Black women in the sport, and she competed for Canada. She reached out of the blue while I was at home and asked if I could join her for lunch one day. And we talked about her time in the sport and some of the ups and the downs that she went through. And she said one of her biggest regrets was not taking the opportunity when it was presented to her to try her hand at driving. And so after that lunch, I went home and I thought about it, and I was like, well, I don't know if I want to drive. It's kind of scary. You see where you're going. Whereas when you're a brakeman, you're sitting down and your head's literally tucked between your knees, and you kind of are just like out of sight, out of mind, just hoping that the driver doesn't crash you. And so when I thought about it, an email came through from one of our coaches saying, "There's an opportunity to go down to Lake Placid, New York, which is about 6 hours away from here, to try your hand at driving." I initially ignored that email, and I was like, I don't know. This sport has really taken a lot out of me, and I don't know if I can go back into this environment anymore. But I thought about it, and reluctantly, I emailed the coaches back and said, "Sign me up. I want to try it." And so a few weeks later, I went down to Lake Placid. still upset about my experience at the Olympic Games in Korea, and was met with other people who had been in similar instances, not named to the team, named as alternates, having qualified for the Olympic Games, but then their country decided not to submit them for the Games. So we were basically a ragtag crew of hurt emotions and feelings. But what I learned during those 3 weeks in Lake Placid was that through the pain, you can work together and band together to find something new and find a new identity. We were there in an environment that was low stress and back to a moment of where we first started, which is learning the sport for what it was, which was to have fun. And boy, did I have fun. I crashed more than I've ever crashed in my entire life at that point. But every single time I crashed, there was someone at the bottom to help pick me back up and cheer me on. Hey, it's all right. You just made this mistake. Get back up and get right up there again. And I did the same for my friends that I now consider my really good friends that also were in the same position. They had crashed, but then got right back up because they had the support network around them. They didn't realize at the time was their support network, but we were there to help each other up. I now fast forward into my career as a driver, having made the decision to stick through with the sport and be a pilot. And the determination and the hard work and the perseverance that I had learned through my years as an athlete, I channeled into this next chapter of my life. When you're a pilot in bobsleigh, as I mentioned before, you're going to crash, and you're going to crash a lot, and you have to come to terms with the fact that you're going to crash a lot. But also learn that that's part of the learning curve of our sport, and that every time you get back in the sled is another opportunity to strike while the iron is hot and make the best of that run. You get 60 seconds every single time you're in a sled to try and navigate a difficult course, memorizing all the curves and the turns, and hoping to put the best run down possible. And sometimes you make it right, and sometimes you don't. But that's life, is it not? Sometimes you'll get on the course of life and things will go right perfectly in line, and sometimes you'll have a hiccup. But those hiccups aren't the end of the world. You just pick yourself back right up and start at the start line and try again. I then fast forward to 2022, where I finally make my first Olympic team officially as an Olympian. And I get to stand at the pinnacle of sport, getting to represent this great nation called Canada. I've never been more prouder of the journey that I've been on, and for the people that were there along with me to get me to that point. I still rely on that support network to this day, whether it's through a friendly chat or catching up, or sometimes just having a moment to sit down and chat with each other. But through sport, I've learned that life is with its curves, bumps and turns, but at the end of the day, you'll always get to that finish line. Thank you for listening to my story this morning.
Thank you so much, Cynthia, for sharing so openly and honestly, and for sharing your story of resilience and perseverance. Any questions at all for Cynthia in the room or online?
Wow, that was fabulous. Thank you. I've never understood the mentality of bobsleigh and either seeing where you're going or not seeing where you're going. But my question, for two parts. One is, it doesn't sound like the actual Olympic group really supported you through a lot of this transition. And the second part is, how do you go from a high school hammer thrower, shot putter to somebody saying, hey, come try bobsleigh? Who did that and how did that come about?
So I'll answer your first question. Going into 2018, I had a little support. I didn't really spend too much time on it, but that one teammate, Neville, was a member of that Olympic team, and he was probably the biggest reason why I still stuck through with the sport. At the time that bobsleigh was at, it was, I'm not gonna, sugarcoat it. It was quite a toxic culture that we were in, where it felt like it was a dog-eat-dog world. So I'm not surprised that I didn't get as much support going through that moment, because everyone's really in it for themselves, unfortunately. Now where the sport is, I would say it's quite night and day. We are a much better, closer knit group on the team, on the Canadian team, as well as internationally, our sport's quite niche and it's very small. I would on an average year, there's maybe 400 people in the world that are competing in the sport, whether recreationally or competitively. But the sport has grown closer, I would say. And so there are more support networks available to help you through moments. I look to my friends that I've made through the Australian and the Austrian bobsleigh team that I can turn to at a moment's notice if I need someone to chat with. And in terms of how did I get into bobsleigh, honestly, it was by a fluke. The Ontario bobsleigh team was running tryouts at York University, and I happened to see the poster, and I said, well, I'm going to be on campus anyway, so why don't I try it out? And that seems to be a little bit of how my life kind of goes, where I see an opportunity, I'm like, might as well try that, see what it's like. One of the lessons actually, like I mentioned in my story, when I was talking with Shelly Ann, was she always felt like not taking the opportunity to take that driving school was one of her biggest regrets. And I kind of took that as never wanting to live with regret. And so anytime an opportunity has come through, I always try my best to utilize it without obviously stretching myself thin, because I've learned that lesson as well. But yeah, I was one of the random ones that kind of just saw a poster. I didn't really get targeted for bobsleigh. Thank you.
Great. Oh, question here in the back.
Thanks, Cynthia. That was a great presentation. Thank you for being so open and honest about your journey with depression as well. I wondered if you could share a bit about what you do maybe now in your everyday life when you may feel your mental health slipping or dipping, and just being hyper aware that you have this diagnosis, and sort of how you manage that now, maybe while you're practicing the sport and out as well.
Yes, this is something I should have addressed more so in my presentation, and I kind of do regret that. But now with a lot of the services that are available to national team athletes, Game Plan is one of the biggest programs that we have access to, which I believe Homewood is a sponsor of. And that allows athletes to have access to either a mental performance coach or a mental health practitioner, paid through the COC and through Game Plan, where we can talk to a medical professional, whether it is, and there's two streams with the mental health side, where there's I believe a 24-hour crisis line that if you need someone to talk to right now, there's a number you can call to. And then there's also the more scheduled side, where you have a dedicated therapist that you can talk to. I have one, and we meet about once a month just to go through life or just sport, and how to, build up the tool belt to get through those moments. Very much a proactive side of therapy instead of reactive, for me at least. And then I also have a mental performance coach, and have really utilized that resource since the 2022 Olympic Games. I leaned on my coach, who at the time was actually my teammate, and he said one of the things that he used in his quest to win his first Olympic medal was to hire a mental performance coach. He knew he had all the tools. He was strong enough. He was one of the best drivers. He had all the equipment, but so does everyone else that you're competing against. And he knew that what he needed to do to make himself, step above the rest of his competitors was the mental side of sport, which is something that doesn't really get talked about enough, I think, in sport. We talk about mental health, but not to the extent of being proactive. It's almost spoken in a reactive way. And so using a mental performance coach, I think, is probably one of the biggest tools that I still use right now.
Awesome. Cynthia, for such an inspiring talk.
Thank you.
So I think this is we got about 15 minutes. We're going to, I think, reconvene at 10:45. We're going to take a short break here. And please don't forget to complete your evaluations. Better to do it after each talk rather than saving it till the end of the day. Thanks. I'm happy to introduce my friend and colleague, Dr. J.D. Vanderkooy. Medical Director of the Eating Disorders Program at Homewood Health Center, where he provides clinical leadership for a specialized inpatient service, supporting adolescents and adults with complex eating disorders. Dr. Vanderkooy is a psychiatrist with extensive experience in acute care, child and adolescent mental health, and the development of interdisciplinary hospital-based programs. He completed his medical training at Queen's University, followed by psychiatry and subspecialty training at McMaster, where I know JD from, where he also holds an active faculty position as an assistant clinical professor. Today, he'll be presenting on effectively navigating eating disorders in primary care. Please join me in welcoming Dr. Vanderkooy.
Good morning. Okay, I want to talk about, everybody can hear me okay? Sounds like I get quieter and louder. Okay. Okay, so, okay, we know that. All right, I'll yell. Okay, disclosure, I work at Homewood. Okay, no drug companies. Okay, where's the first? Okay, learning objectives. Basically, I want to talk about eating disorders in primary care. In other words, I'm going to try and make this as useful as possible and leave some time for questions so that if there's questions that aren't addressed in any of the slides, that you have an opportunity to ask those. As well, you can also request the slide deck because there's some information that I certainly don't want you to scribble down because that'll take too long. What we're going to do this morning, we're going to talk about eating disorders. First of all, we're going to kind of talk about the diagnostic criteria and how we stratify eating disorders. We're going to talk about factors involved in their presentation and development. We're going to talk about how to assess, what to look for. Hopefully there's some clinical pearls in there. And what can we do? What are the interventions, both medication, non-medication? Oh yeah, I can look at the, how much time have we got? I don't necessarily want to go through all of this. I kind of put, if you can have a quick scan or a quick read. It's a lot of things kind of packed into this one little vignette that we see commonly in terms of the patients that are coming into our eating disorders program. What we see a lot of is young adults or adults that began struggling with body image and disordered eating in their teens, in their early teens, often in response to bullying, not always. There's a lot of factors that can contribute. And we're an inpatient program, so we are often receiving referrals from people that have been through a lot of treatment, and there's a lot of despair and hope, but a very, very challenging population. So I'll try to quickly go through the DSM categories for eating disorders, focusing on really the more challenging eating disorders, anorexia and bulimia. Anorexia nervosa, basically we're talking about four things. We're talking about restriction of energy intake relative to energy requirements. So this doesn't even necessarily mean just not eating. It can mean not eating enough to meet energy requirements. Significantly low weight or a weight that is less than minimally normal, or for developing youth, you're not seeing the trajectory of growth as you would expect to. There's an intense fear of gaining weight and often an intense fear of eating related to that, of course. And then there's a disturbance in body image. There's a dysmorphia. There's I like the way it's described there's a disturbance in the way body weight or shape is experienced. With anorexia, there's basically two main types. There's restricting type, and then there's binge binge eating purging type, which bugs me because the binge eating purge type also includes laxatives, diuretics, other compensatory mechanisms as a way of not gaining weight. Whereas the restricting type doesn't include any of those compensatory mechanisms, although it often does include exercise. Okay, lifetime prevalence of anorexia. First of all, the incidence is increasing in youth under the age of 15. 4% of females and 0.3% of males. I think the take-home message I want to communicate from that is it's not just females. And it's very common for us to have at least one male on patient unit. Median age of onset is 12 to 15, which is consistent with what we see. 85% of cases develop between the ages of 13 and 18. Mortality is 5 times greater than the general population. This is a very dangerous disorder from a mortality perspective. And 5% will die from complications over a 10-year period. Bulimia, this is a combination of recurrent episodes of binge eating, and a binge is defined as a quantity of food that is definitely larger than what we would consider a normal amount, and a sense of a lack of control while eating. Then the other side of it is the recurrent compensatory behaviors, which I talked about a little bit with the anorexia binge purge type. Then we have an arbitrary definition. It has to happen a certain frequency, so once a week for 3 months. Again, self-evaluation, the way body image is experienced is disturbed. And then, of course, there isn't the features of anorexia nervosa, which would categorize it under that, under anorexia binge purge type. Lifetime prevalence incidence is declining, and here we see 3% of females and fewer than 1% of males. Risk is highest in the transition, so later adolescence. So in the transition from adolescence to adulthood, and the mortality is similar to anorexia, is 5 times greater than in the general population. A few additional points about anorexia and bulimia. LGBTQ plus individuals are also more likely to have lifetime eating disorder diagnosis than cisgender heterosexual individuals. Eating disorder diagnosis is more frequent among transgender non-binary individuals than in cisgender individuals. Eating disorder diagnosis is associated with the highest mortality of any psychiatric disorder. So this is really what we're looking at, and it's challenging to treat, and of course, more challenging to experience. The mortality of anorexia can be up to 20% in some studies. 80% of that can be due to medical complications, and 20% due to suicide. Binge eating disorder, I'll kind of move through this a little more quickly. This is recurrent binging without the compensatory purging or laxatives or diuretics. The binge eating episodes are associated with, again, this DSM can be kind of arbitrary, I think, at times, but it's a way of defining it so that we can study it. Binge eating disorder is much more challenging to treat. Certainly it's not, there aren't inpatient programs specifically that address that, that I'm aware of. Then the kind of catch-all category is OSFED, otherwise specified feeding or eating disorder. And this is where you don't quite meet the criteria for anorexia, or you don't quite meet the criteria for bulimia, such as with anorexia, weight is normal or not underweight, or with bulimia, the frequency isn't enough to meet the criteria for. There's also a binge eating disorder, purging disorder, and night eating syndrome. Okay, so what factors are involved? Excuse me. So there's a number of factors involved in the development of an eating disorder and the presentation of an eating disorder. I want to talk about medical complications. I want to talk about co-occurring psychiatric disorders. I want to talk a little bit about identity, sense of self, as well as family and interpersonal relationships, and some developmental factors. So first of all, so medical complications, we're just going to go through these one at a time. Electrolyte abnormalities. There are no lab tests that indicate the presence or severity of disordered eating behaviors. So you can't do a lab test and say, oh, that's really high, so it's disorder must be very severe. Very important, stability. A lot of times patients seem to think that, hey, I'm doing fine. Yes, I'm underweight. Yes, I'm restricting, but I can still walk for an hour or two a day. And there's an expectation that, you know, there's going to be warnings. I'm going to know if I'm deteriorating. But stability tends to be more like a cliff than a slope. The body works very hard to maintain what it needs to, homeostasis, until it just can't anymore. And then there can be a crash. And this is one of the things that makes it very dangerous. And we have to be very careful about making sure we're aware of some of the signs that are present. Even in severe starvation, severe restriction, often the electrolytes are normal. There are exceptions to that I'll talk about, such as purging behaviors. Changes in electrolytes, especially low potassium, is typically a sign of purging. And if the potassium, if the potassium is low, really it doesn't suggest there's purging every now and then. It suggests there's purging daily. Electrolyte abnormalities without explanation warrant further screening. And we're looking at low potassium, low sodium, and refeeding syndrome are definitely concerns in this population. So the electrolyte abnormalities, hyponatremia, hypokalemia, refeeding syndrome I mentioned. Hyponatremia, low sodium, can result from dehydration due to vomiting, due to laxative use, diuretics. And diuretics, we're talking about Lasix, furosemide, thiazides, caffeine, Midol PMS, and then there's herbal extracts. And I know a patient earlier this week showed me a bottle that she's been using and never heard of it. Got to do some reading. Hyponatremia can also result from water loading. And water loading is one of the tricks that a patient may do as a way of increasing their weight for a weight so that they seem like their weight is higher than it is. So they're going in for an appointment to get weighed, and they'll have a half a liter or a liter of water. Or they'll put pennies in their shoes or their pockets. Often people are very crafty, which is a particular challenge, of course. Okay, so if you've got low potassium, low chloride, and especially if you have signs of metabolic alkalosis like elevated carbon dioxide, consider purging. In fact, it's pretty much a given. Hypokalemia, as I mentioned, is usually a sign of frequent purging. Usually it's caused by purging behaviors in this population. It's not due to a dietary deficiency. Most frequently, we see it in individuals that are underweight that are also purging or using laxatives. As I said before, it suggests purging is daily. Individuals that are only restricting and not purging or using laxatives, it's unusual for their potassium to be low. So if you're seeing that, that's a huge flag. Refeeding syndrome is something we have patients that are coming in for treatment. They've been restricting substantially for a period of time. And our concern, this is certainly a concern because it's dangerous and we have to monitor for it. And there have been situations where we've had to refer for medical treatment. Effectively, we're talking about metabolic changes or shifts in fluid and electrolytes during refeeding, when nutrition is restarted, which can be caused by an increased glucose load and following insulin surge. The insulin surge stimulates protein synthesis and movement of everything, potassium, magnesium, phosphorus, into the cells. So of course it's low in the blood work. Clinical signs, we're looking at muscle weakness, edema, gastrointestinal symptoms, delirium, cardiac failure, respiratory failure, and occasionally death. And then lab findings, everything is low. Refeeding risk corresponds directly with, so this is an indicator. The risk of refeeding is higher depending on how severe the restricting has been. Cardiovascular complications, bradycardia is common. Low heart rate, we've seen heart rates as low as 45. Rarely lower because if we're seeing someone coming in with profoundly low heart rate, we're sending them for medical treatment. Hypotension, so orthostatic changes. So, you know, getting up from lying down or sitting down and they're feeling faint or syncopal. Very much a concern. So we're checking postural vitals regularly with patients, especially when they're first coming in. There's other risks. Cardiac risks include left ventricular atrophy, occasionally mitral valve prolapse, myocardial fibrosis. These are serious consequences of the eating disorder. QTC prolongation, I'm going to talk about as well, because this is related to low potassium, of course, low magnesium. But then it can be exacerbated by certain medications. A lot of psychiatric medications can impact the QT interval on the EKG. This is just a list of some of the medications that we see patients are commonly on that can contribute to a prolonged QT. So once a person is on one or two of these medications and their electrolytes are abnormal, it's certainly definitely a concern. And we've had some patients come in that we've medical treatment. This also includes motility agents like domperidone, metoclopramide. And often these medications are prescribed for gut motility because they're constipated, because they've got gastroparesis, because they've been restricting, and they're talking about every time they eat, they experience this intense abdominal pain. Medications sometimes can help with that. There's not tons of evidence supporting their regular use. I know a lot of times patients come in on these medications, and the QT interval is one of the reasons that we get concerned. And Benadryl was on that list as well. So gastrointestinal complications, as I was just alluding to. Fear of GI symptoms, just the fear of bloating, of that feeling of fullness can be extremely distressing. So the fear of that is going to have an effect on their restricting. Another example, two examples, one of them is emetophobia. I got to tell you a story. I had an 11-year-old patient a number of years ago who had emetophobia. She stopped eating because she was terrified of throwing up. I think the numbers are 1 in 5. People have a fear of vomiting or of hearing someone vomiting. My ex-wife didn't like to go to the hospital because there was a possibility she might hear someone throwing up. Anyway, this little girl had pretty severe emetophobia, and I started medication, but I referred them to a psychologist friend of mine who began a course of some cognitive behavioral therapy. The part that still kind of I love to share is one of the first things that she did in therapy, of course, was externalize the anxiety. So give the anxiety a name so that the child and the parents can talk about the anxiety as if it's an entity, an external thing that the child's experiencing, not them. And the psychologist encouraged this little girl to come up with the name herself, of course. My favorite thing is the name she gave it was Ralph. I don't know, I just thought that was really creative. The other thing is ARFID, avoidant restricted food intake disorder, often associated with autistic spectrum disorder. These are sensory hypersensitivities or hyposensitivities. I've had patients that cannot stand even the thought of cheese. I wasn't even allowed to say the word cheese. Things like chickpeas are common, hummus, there's a texture and some flavors. This is very challenging because in eating disorders program, we're also trying to target treatment to fear foods. So certainly there's foods that patients are just very anxious about, and we're not going to take those out of the diet. The goal is to reintroduce them and expose them. So ARFID can be a real challenge, especially when it's combined with restricting because of anorexia. Gastroparesis resolves with nutrition restoration. As nutrition is restored, the gut begins to, it's not kind of a linear, smooth transition back to smooth working order. Quite the opposite. It can be very difficult. It can take weeks, but eventually that regular nutrition will restore the gut to normal functioning. There's a few other things I think I talk about in terms of laxatives that I'll come back to. GERD, gastroesophageal reflux, often presents a lot of complaints of heartburn, a lot of complaints of bloating, and of course this is exacerbated by the gastroparesis or the purging. Now, this is what I was going to talk about. Use of stimulant laxatives. Some patients come in on a lot of Dulcolax or a lot of Senecot because they just keep increasing the stimulant laxative, not as a way of compensating so much as trying to treat the constipation. Of course, there's also overlap. There are patients that have celiac disease. There are patients that say they have celiac disease so that they don't have to go near carbs. Or inflammatory bowel disease. Endocrine complications. So these are a little bit more complex. Thankfully, we don't see, it's not so much of an imminent concern as hypokalemia, for example. But we're talking about a disturbance of gluconeogenesis can lead to hypoglycemia. This, of course, is a concern. And we do have patients that are restricting that will come in and their blood sugar will be concerningly low. So we'll of course, monitor that. Hypoglycemia in anorexia has been associated with sudden death. So it's definitely something to be aware of. As well, there can be thyroid abnormalities with a normal TSH. So there's abnormalities in T3 or T4. Restricting can also lead to hypothalamic dysfunction and interruption in gonadotropin releasing hormone. We see changes that can contribute to amenorrhea or so loss of menses or irregular menses. So irregular periods are common with bulimia and binge eating. Again, we're talking about the metabolic changes, the endocrine changes. Anorexia can cause increased serum cortisol levels due to decreased clearance. We're seeing changes in bone resorption. We can see, especially in developmental years, like in adolescence, we're seeing bone development affected, which sometimes recovers and sometimes doesn't. Same thing with linear growth. There's a decrease in linear growth, and they don't always catch up if they start eating again. As well, same thing with pubertal development and reproductive organs. There are windows of development, and if restricting is decreasing nutrition, then sometimes they'll miss those windows. Neuropsychiatric complications. So these are, as you'd often expect, depression, anxiety, OCD is common. Sometimes it's really difficult to distinguish OCD from the eating disorder. So I just kind of hang in there. And then when nutrition is restored, it's easier to get a feel for what symptoms they're experiencing that aren't due to the eating disorder. Depression is a major one of those. A lot of times, once their nutrition is restored and their weight is restored, the depression goes away without treatment. Or I get to have the fun job of stopping an antidepressant. Yeah, I said that. Anybody ever heard of the Minnesota starvation study in the 50s? Where they took people volunteered for this study where they just didn't eat. And they developed a lot of the symptoms that we see in anorexia, such as depressed mood, social isolation, and food noise. And food noise, our patients talk about constantly being preoccupied with food. They can't stop thinking about food. It's always on their mind. And weight, so the other thing, we can see cognitive changes, and they did see that in the Minnesota study. Cognitive changes can be due to brain volume loss, and this is gray matter and white matter. The white matter will return to normal, but the gray matter volume changes sometimes don't return to normal, so you can have long-term cognitive dysfunction. Okay, so there's some screening tools. I think it's worthwhile to, if you're interested in these, they're on the slide. And some have some strengths more than others, depending on the clinical situation. SCOFF questionnaire, do you make yourself sick because you feel uncomfortably full? Do you worry you've lost control over how much you eat? Have you lost 1 stone, 15 pounds over the past 3 months? Do you believe that you are fat when others say you're too thin? Would you say that food dominates your life? Just kind of a quick 5-question screening questionnaire. Okay, medical evaluation. As you'd expect, given what I've been talking about in terms of the changes that restricting, binging, and purging can cause, there's a bunch of things to look for. So when patients are coming in, we're kind of doing the gamut. And this is available on the slide, so I don't need to go back into those. Okay, then a psychiatric evaluation, same thing. I will say our program is 16 weeks long, so I'm really focused on the eating disorder in terms of my initial assessment, and then we'll come back and look for symptoms of other depression, anxiety, post-traumatic stress disorder, panic disorder through the course of the admission. ADHD is really common. What's also common is patients coming in that have been restricting, and they're on a stimulant medication for ADHD, which of course suppresses appetite, or they're on Wellbutrin, which suppresses appetite, and by the way is contraindicated if they're purging because it concerns an electrolyte changes and decrease in the seizure threshold. Of course, always assess for safety. I tell my med students, you haven't finished assessing for safety until you've used the words kill and die. But a lot of times, we want to avoid the topic. And do you ever feel like you don't want to be here? And it's important to make sure that you have a good understanding of whether they risk or not. Anorexia has been described as a slow suicide, which is harsh, but has elements where it feels sometimes like that, where there's a slow trajectory of decline. In terms of the history, we often ask, really the next couple of slides are questions that we're asking so that we can get a thorough understanding of kind of what the history of the eating disorder is, really as a way of kind of having an understanding of how pervasive and how much the eating disorder has really disrupted their lives. Small utensils, small utensils I found interesting when I started working with the program. They like to use, often they'll use like kids' spoons and forks and plates so that it feels like they're getting more than they are. And they have, often people have a lot of food rules. So I don't eat until 4 p.m., or I don't eat this food or that food, or I don't eat in this situation or otherwise. And that, of course, is related to fear foods. There's some foods that cause substantial anxiety, often carbohydrates or fat. Purging, as I mentioned before, involves not just inducing vomiting, but also use of diet pills, water pills, laxatives, and stimulant medications are suppressing appetite. Ask about dizziness, fatigue, vertigo. A lot of these questions, and sometimes they won't have the insight. A lot of times you'll get a feel I'll be interviewing a patient that has just come in, and it can take weeks before it's like something inside them kind of wakes up, and suddenly you're not fighting with them anymore. They're an ally. It's almost like the eating disorder was a parasite that had taken over. So physical evaluation, again, I think I'll just leave this. Really, it's trying to be as thorough as possible with respect to the assessment. And it can take some time to cover all of this, but it really helps you to get a good understanding of what they've been struggling with. Okay, comorbidities. Of course, there are other things that can cause these symptoms, and sometimes it's important to rule out things like brain tumors. We've had a patient with pituitary adenoma. It's important to kind of have suspicion for these possibilities. Other things like inflammatory bowel disease or irritable bowel syndrome, disorders of gastrointestinal absorption, thyroid disease. Prader-Willi, I haven't really seen a lot of Prader-Willi, but I put it in as a way of communicating that there are disorders that can cause a substantial increase in appetite. Prader-Willi is one of them. Lab blood work is important. Recent lab blood work is important. Sometimes these changes can happen in the course of a couple of weeks, especially if they're already substantially underweight. And then medications. Always ask about medications. And some of them, often, they won't tell you unless you specifically ask. And this doesn't just mean that they're not always prescribed these medications, especially when we're talking about some of the diet pills that are available over the counter or in the natural drug section. And then also screen, of course, for substance use disorders. A lot of times they're using things that are suppressing appetite and stimulating activity, giving them energy. Walking, running is common. Anybody know what the most important medication is? This is a bit of a loaded question. Most important thing for them is food. And nutrition often can restore a lot of these symptoms. So really want to kind of hold off on making major medication changes until nutrition is being restored. So next question, when do you recommend inpatient treatment versus outpatient treatment? Of course, you're going to try outpatient treatment first. But sometimes the disorder is quite severe, substantial, and it just outstrips the ability of an outpatient program to compete with the eating disorder. A lot of outpatient programs will have a BMI limit, so below a certain body mass index, they don't accept referrals, and they're recommending inpatient treatment. When to consider inpatient treatment: unstable lab results, low resting heart rate, hypotension, orthostatic changes, body mass index that's less than 75%. I think some programs will say less than 17 or 18 body mass index, and they won't accept a referral to outpatient treatment. Electrolyte disturbances. The trajectory is important. So even if their levels aren't so concerning, but they're declining over time, the expectation is that decline is going to continue. So it's important to be aware of the trajectory. Goals of intervention: nutrition and weight restoration, removal of some of the complicating factors, behavioral change. I mean, this is in large part a behavioral disorder. So certainly focusing on behavioral change and behavioral therapy is important. Restoration of agency and autonomy. I hear a lot patients talking about the eating disorder gives them control, which is so ironic because the eating disorder takes the control from them. And when you ask them about this, they acknowledge it. But there's a feeling that they have it is something of a high when they're able to restrict or exercise. It's interesting because when patients are first coming in, it's almost like we're fighting the eating disorder and the patient is kind of alongside the eating disorder. And as nutrition is restored, they begin to see it. And then they themselves are realizing the fight against the eating disorder more. A lot of patients actually identify with the eating disorder as something they're good at. They're extremely competitive in this respect. A lot of patients on our unit are constantly comparing themselves to other patients. We're trying to encourage them not to because it's part of the disorder. But that sense of, you know, if I don't have this, what do I have? This is something I'm really good at. And of course, empowerment and enablement of support such as family, outpatient supports. This is just a quick note in terms of inpatient treatment. Ideally, involves a multidisciplinary team. My team, I feel very, very blessed because we're well resourced. We're not a medical hospital, so I can't start an IV. I can't send a patient to a medical ward if I need to. And of course, that creates some challenges. But otherwise, we are able to provide medical intervention. Otherwise, we have a nurse practitioner, myself, nursing staff, a dietitian team, psychotherapist, social worker, and an occupational therapist. And of course, we have trainees as well. And we seek to involve the family and other interpersonal supports as much as possible when the patients will allow us to. We have a weekly virtual support group that family members can sign up with if the patient is agreeable and provide support that way. And of course, we can schedule family meetings. Medications, symptom management, restoration of electrolyte imbalances, multivitamins. All of our patients are on a multivitamin, calcium, vitamin D. And symptom management with respect to GI symptoms, with the exception of stimulant laxatives, which we avoid like the plague, but we will use things like lactulose or Laxaday, Oval, simethicone for bloating symptoms. Often they can be helpful. Often they're not helpful enough while their gut is returning to normal functioning. Of course, as I said before, we want to avoid medications that complicate, especially with respect to prolonged QT, appetite suppression. I know it's a common practice to prescribe like olanzapine as a way of increasing anxiety. I've had a lot of patients over a number of years of treatment that are on olanzapine. They have an eating disorder they're restricting, and they don't know that a side effect is that it stimulates appetite. I'm thinking, wait a second, you were started on this to stimulate appetite. You're not aware of that side effect. And it, of course, the patient becomes very frustrated because they didn't consent effectively to being put on the medication. So if I'm suggesting, sometimes rarely they can be helpful medication, I want to negotiate that with the patient as well. If a patient is restricting and suddenly their appetite increases, it causes a lot of anxiety, which can exacerbate the other symptoms. Food. Okay, so just a few more slides about behavior change and symptom management. The kind of primary interventions are cognitive behavioral therapy, CBT-E, enhanced CBT, DBT, and motivational interviewing. Remember that cognitive interventions require cognitive capacity, and that's very difficult when someone's been restricting and they're malnourished. Behavioral interventions require agreement. So you really want to negotiate and serve more as a consultant. I used to work with a supervisor in residency, who always said, no pep talks, JD. Pep talk is your energy. They get to decide if they want to do this or not. Okay, so first of all, CBT-E. It's a process. There are stages with CBT-E. Can be very helpful. We kind of steal a lot of features from CBT-E, and kind of therapeutic approach is a bit of a dog's breakfast. We want to take motivational interviewing and a lot of DBT. One of the keys about CBT is that joint formulation, partnering with the patient and negotiating a way forward. DBT, of course, much of the challenge that they're facing is emotion regulation. And the restricting, the binging, purging, the symptoms are a way of responding to the emotion dysregulation. But then in the end, they cause more emotion dysregulation because of the disruption of their emotions and cognition and other physical symptoms. DBT, dialectical behavioral therapy. I took a course with Marcia Linehan, and she was talking about, everyone wants to know where this name came from. And she's like, she kind of looked something up because she had to give it a name, and this sounded kind of technical. But ultimately, it's about shades of gray and finding the synthesis between opposing viewpoints or views, identifying cognitive distortions, and then the idea of radical acceptance, mindfulness, a lot of strategies and skills that patients actually find to be very helpful, especially in the inpatient context. Motivational interviewing. Oh no, we're still on DBT. Mindfulness. Distress tolerance is a major feature of what we want to focus on, so that they can feel and tolerate the emotions rather than responding to the emotions with the disordered eating behaviors. So motivational interviewing, I like this approach. It maintains a boundary with patients that are often wanting to offload and wanting you to manage their emotions for them. You're expressing empathy so that you're communicating, wow, this situation is very difficult. What you're describing to me is very difficult. Identifying what they've tried, what has worked, what hasn't worked. Avoiding arguments, which is difficult to do with eating disorders because they want to engage you in the argument. Ultimately, the eating disorder wants to make you feel useless and purposeless so that the patient can devalue the treatment and say, forget this, I'm out of here. The eating disorder, especially in the first few weeks of treatment on our inpatient program, is working very hard to find any reason to justify leaving. Rolling with resistance, recognizing when it's resistance to avoid getting pulled into an argument about symptoms. And of course, in the end, supporting self-efficacy and fostering resilience. Okay, so hopefully we addressed a lot of what an eating disorder is, what factors are involved in their presentation, their development, ways to assess, and suggestions for intervention. And again, the assessment, I didn't go through all of those slides mainly because hopefully if there's something that you find valuable, you can get, I think you have copies of the slides. And then there's also some resources and some articles listed in the slides. Okay, and we got about 17 minutes for questions.
Thanks very much, Dr. Vanderkooy, for sharing your expertise on a common and complicated disorder. Questions in the room? I saw hands up here and then online as well.
Thank you. One of the things you mentioned to rule out was a brain tumor. Does every patient who has an eating disorder need an MRI or CT of their head, or what's your strategy there?
Good question. No, but if we're seeing changes and you know, if we're seeing changes in, well, now I'm remembering a lecture from med school, flat pig, FSH, LH, ACTH. There's a number of hormones that can be changed when there's a disturbance with the pituitary, like pituitary adenoma or otherwise. So I think if there's changes, the important thing is to remember, wait a sec, this may not be just due to the sort of co-occurring.
Part of the physical exam, do you typically do like a basic neuro exam to see if there's any focal signs or anything along those lines, or?
Yeah.
Or not necessarily?
Yeah. Our nurse practitioner is extremely thorough. Continue to be very impressed with the level of thoroughness, and yeah, neurological, kind of a quick neurological assessment can be very helpful. And challenging, of course, because sometimes the cognitive changes with the restricting can be profound.
What are your thoughts about using Vyvanse for binge eating disorder, like given the risks that you've highlighted?
Yeah, I mean, I don't treat binge eating disorders so much in the inpatient setting. It's not indicated. I'm aware there is some research associating Vyvanse with binge eating disorder, and I think some effectiveness. I can't tell you the numbers because I'm not immersed and kind of refreshed my memory on those things. But the idea behind Vyvanse, it's a stimulant medication that's used to treat ADHD, and it suppresses appetite and can be helpful, I think, in terms of decreasing the frequency and severity of binging.
Katie, you mentioned ADHD medications and some of the challenges with appetite suppression in folks with anorexia nervosa. Do you have any recommendations for folks in the community for supporting patients that do have very clear and sometimes moderate to severe ADHD and then a significant eating disorder in terms of medication management or choices?
Absolutely. Eating disorders are more common. ADHD is more common in individuals with eating disorders, which is challenging because sometimes the impulsivity is due to ADHD, sometimes the impulsivity is due to malnutrition. And then approaching an eating disorder in terms of treating it in an individual that's restricting, ADHD is not going to kill you, but restricting can. So I really want to hold off on messing with appetite either way, stimulating or suppressing, but especially I want to hold off on recommending stimulant medications. The predominant treatment for ADHD, if you're not familiar, are stimulant medications. And basically there's two, Ritalin and Dexedrine. Both of them are about the same age, and sometimes either or both are effective. Sometimes neither is effective, but often a patient will find benefit from one. They'll have kind of the medication that they like. Most of the medications for ADHD are formulations of those two stimulants that last longer. So they're not just lasting 3 or 4 hours as the medications are, but they're prolonging that action. Oftentimes, patients that are restricting want to suppress their appetite with these medications. There is an ADHD medication called atomoxetine or Strattera that has shown benefit with ADHD. In my almost 20 years of practicing child and adolescent psychiatry, I've seen a few patients that responded to it. I don't love that medication, but sometimes it can be effective. It's just never as effective for ADHD as the stimulant medications are. When I'm talking to a patient with ADHD or I'm suspecting ADHD, I feel like the most important intervention is knowledge, is for them to read more about ADHD. There's a great book by Ned Hallowell and John Rady called ADHD 2.0. It's the follow-up to Driven to Distraction, which is a paperback about ADHD, adult ADHD that Hallowell and Rady wrote like 25 years ago. I like ADHD 2.0 because it's like 150 pages. They don't have to read it cover to cover. A lot of times they will read it and be like, oh my gosh, how did you know? So it's really helpful in terms of not only helping them to recognize some of the symptoms that they may or might not have, but it can be extremely validating and teach them ways of managing that don't involve medications. A lot of other resources that can teach non-medication ways of managing ADHD, and I certainly want to emphasize those with these patients.
Thanks, Hygge. We do have at least one other question in the room, but I just want to address the question from the chat. Has there been an appreciable increase in the incidence of eating disorders with the rise of semaglutides like Ozempic being used as a weight loss drug? Are there any long-term effects being seen as a result of the use of these medications?
Great question. As I understand, there's a fair bit of research that's looking into this currently. I'm not familiar with, any strong conclusions from that research as of yet, but the concern is that, effectively, the Ozempic or Wegovy or these medications are causing weight loss. And when there's weight loss, especially if there's dramatic weight loss, there's an increased risk of developing anorexia or restricting diet or binging and purging. So it's absolutely a concern. I don't know the numbers, but there's definitely been observed an association.
Can you just briefly outline what an inpatient program for anorexia looks like? Like, what do the various weeks look like?
Yeah, be happy to. First of all, excuse me. First of all, there's a lot of heterogeneity. Excuse me. A lot of heterogeneity. So there isn't like one standard program or treatment approach that every program uses. The program at Toronto General, I think, is a 4-week program, which is targets medical stabilization, weight restoration, and then an outpatient program for 12 weeks after that. There's a program I was reading about in Scotland where there's no prescribed length of time that people are being treated. They kind of are looking for certain markers, and then they measured the length of stay, and they can look at, what correlates with a longer length of stay, shorter length of stay. I can tell you our program consists of mainly 2 phases. There's an assessment phase, and then there's a treatment phase. The assessment phase is at least 2 weeks long, where we are focused on symptom interruption. I think the single most important intervention that we're able to offer in an inpatient program is that meals and snacks are supervised. There's an expectation that they eat. It's a voluntary program, so if they don't want to eat, they don't have to stay. But if they want to stay, they have to eat. So, of course, we support them through that process. We don't expect them to be finishing absolutely everything we put in front of them the first day. That'd be silly. But then they're not able to progress into the treatment phase until they're completing meals. And sometimes that takes 2 or 3 weeks. Sometimes people are coming in and they're medically very unwell, and we'll have them on bed rest, and we'll be restricting any energy expenditure. We'll move them in a wheelchair if necessary, which they hate, understandably. But that's really the assessment phase. And then we kind of transition into the treatment phase, where they're participating in more one-to-one therapy, group therapy. We have a schedule of different groups. We offer, horticultural therapy, mindful movement classes. It's just a lot of resources at Homewood that they can take advantage of. When it comes to activities and passes off of the unit, first of all, when they first come in, they can't leave. They're not allowed to leave. When they can leave, they just can't come back. And then as we're planning for increased activity with our recreation therapist, we're allowing them to go on the grounds outside. We actually have an outdoor courtyard as well, which can be really helpful for people. But basically, we're trying to reintroduce them to these aspects of life in a way that provides support so that the eating disorder can't use them or can't kind of grab hold again. And yeah, we often have patients that are climbing stairs on passes, always find out, and we're always trying to figure out how to provide support. But the remainder of the assessment phase is 2 weeks at its shortest, and then the treatment phase is 14 weeks at its longest. Did that answer your question?
Yeah. And JD, I think in the assessment phase, of course, people typically get comprehensive baseline blood work, other investigations of their own medical evaluation. Daily blood work?
Yeah, we're doing blood work daily for the first 3 days, and then I think day 5, 7, day 14. Of course, we're going to be doing it more frequently in individuals where we have concerns about their medical well-being, individuals that are coming in more medically stable. We still follow a protocol, but we're less concerned about making sure their the potassium is.
And I think the rationale behind the 16 weeks is that people typically come in very undernourished, very underweight, and oftentimes with a very low BMI, and to kind of refeed them safely and to go through the programming. Because are we still targeting trying to, I should know the answer to this, but are we still targeting trying to get people back to a BMI of 20?
Yes.
Okay.
Yeah, that's really kind of what we're looking at. The dietitians are negotiating menus and providing support that way. Along the course of treatment, they're choosing challenge snacks, challenge meals, family involvement, going on passes. We've had people going to the mall to go clothes shopping, grocery shopping. We have a kitchen, we have cooking classes that the dietitians are leading. So there's a lot of components to really help people return to their lives and develop a routine that doesn't involve the eating disorder.
Hi, thanks. I work at the University of Guelph, so we see like a lot of students that will have eating disorders, and I'm just like looking back at like inpatient versus outpatient. And a lot of the students that we'll see will have some of those really pronounced like orthostatic changes, but oftentimes it's like, I'm in the middle of my studies, I don't want to do inpatient treatment, that kind of thing. And so oftentimes our clinic protocol would be like, okay, you're more at risk, you need to go to the ER, something like that. They'll go to the ER, they'll get some fluids, and then they leave. So then oftentimes we're seeing them, they still have these orthostatic changes. They don't want to go to the ER because they're just going to wait there, get fluids, and leave. So then they're not doing anything at all. Do you have any recommendations in that setting of what to do, how to manage these students?
I think this is one of the biggest challenges about these disorders is the level of insight. And the eating disorder, much like a psychosis, takes away the insight. And there's this thought that, and actually it's similar to an addiction in a lot of ways, where there's just there's a pre-contemplation, I'm not that person. I don't have that difficulty. Sure, I'm still able to go to the classes. A lot of the patients that we have that were in university had to take time off because their brains just weren't functioning anymore. And they were failing courses, their memory wasn't working, and the family, of course, was concerned. I think the biggest challenge with eating disorder treatment is access. So there are a number of beds in Ontario that are funded inpatient treatment beds, and the wait time for those is substantial. Our wait time for OHIP funded beds is substantial as well, but we do have the other opportunity. Insurance, et cetera. Sorry, yep. Okay, maybe I should just hold on to it. Tough to answer because they don't want treatment. They don't want you talking to their family to bring them in. And then it comes down to how do you develop a contract with someone who's not willing to participate in treatment? Yeah, I don't know. That's a challenge. And a lot of times we have patients that will come to our program, excuse me, and they'll leave after a couple days, a couple weeks, sometimes a month, and they may need to come back 2 or 3. We have a patient on the ward, this is her 4th time, and she's made it further with this admission than she has with any of the previous ones, and crossing her fingers and trying to provide support. But it's challenging because you objectively can see what the eating disorder is doing and the arguments that it's making, and they have like a partial understanding of that.
You kind of already answered it, I think, which was, does the Homewood program have any OHIP beds? And if yes, what is the wait time?
I think we're at 2 to 3 years for those beds, which is maddening. So I won't talk more about it.
We have been advocating for
Absolutely.
for more funding for more fully funded ward beds. Technically, we have 2 only. Given the wait list, we've kind of made the decision to at least temporarily bump it up to 4, even though we don't have the funding for it, just because there's such a need. For those folks, we're hoping that there'll be some funding coming in the hopefully coming months, but we don't know that for certain. We'll continue to advocate for it. The other beds do require essentially coverage. I'd say 90% of people that are in the other kind of semi-private or private beds have accommodation insurance through their employer or otherwise. So if they do have accommodation insurance, the treatment, of course, is covered. The accommodation portion is not. So most people have that coverage through their insurance plan. So the question is, how much is it if somebody doesn't have coverage? I have to double check, but I think it's around somewhere between $400 and $500 for a semi-private accommodation per day. So it's a lot. Yeah.
We have a number of patients from out of province. Other provinces will send patients if they don't have adequate access, or if they do have, well, they don't have adequate access, or the access that they have is, the wait time is prohibitive. And yep, absolutely.
Yes.
Absolutely. You're preaching to the choir.
Yeah, so we've been bringing up these points with OH, with the ministry, and trying to advocate for more.
Mhm.
Yeah, it doesn't.
Yep.
Yeah,
it's challenging.
Sometimes folks also, in terms of people that have coverage, may forget that if they have a child that is kind of university age. Somebody from UOG was talking earlier that many of those folks might have coverage either through the university or through their parents. If they're living at home, if they're under 25, still in school, they probably still have coverage through their parents. I have one more question online. I think somebody else had their hand up in the room. Does their voluntary choice to leave, say if they don't, sorry. Sorry, I'm just trying to understand this. Does their voluntary choice to leave, say if they don't eat, ever get overridden by safety? Okay.
Sorry, say again.
In terms of the voluntary choice to leave or stay, if they don't eat, at what point do things does that choice get overridden by safety? I think is what the question is really.
Great question. And I'll summarize safety by talking about self-harm and suicidal thoughts or urges, or medical complications. Medical complications, if a patient is refusing to eat often before they're coming to increased risk of medical complications, we're communicating with them, we're wanting to establish that risk. And if they're just not participating, then we encourage them to follow up with their outpatient resources, and of course be closer to home if they require medical treatment at that time. Often a larger concern is if we're talking about discharge with some patients and it increases their suicidal risk. Of course, we're a voluntary program. We don't have a locked door that we can close. And if we're putting someone on a form, we need to transfer them to an intensive care area within the hospital. And we have some facility for that, but it's quite limited. So again, if the treatment is causing so much distress that they're at increased risk of self-harm or suicide, they can't continue the treatment. So at that time, we're wanting to look into repatriation, return home, and then come back hopefully in the future when they're better able to benefit from the intervention.
Hi, thank you. Just wondering if you can comment on genetics in anorexia.
Oh, I can't.
No.
I can't. I just don't have the numbers on the tip of my tongue. I mean, I think what it speaks to it, in the sense of genetics and specific numbers, I mean, we're also looking at generational challenges where a lot of our patients have a parent, one or both parents struggle with eating disorders themselves. It is something that we're seeing in families. In terms of specific genes, I can't tell you. I don't know what we've discovered or haven't yet discovered. But that familial preponderance is definitely something that we see, and very challenging, especially when we're doing family level interventions. Any other questions?
Great, I think that's
Okay,
it.
Thank you very much.
Okay. JD, I think are these your glasses, JD? Thanks very much for a great presentation, Dr. Vanderkooy. I just thought of one other thing that in terms of the advocacy we've been doing for enhanced eating disorder support, it is a provincial priority, and I do think there's going to be more funding coming. I'm hoping there's some more funding coming for those more severe cases that need the inpatient stay, but I do think there's going to be more funding coming for kind of more intensive outpatient eating disorders programs, and whether that goes through the local CMHA or other organizations, that's the piece that I don't know yet, but I do think there's some additional options that are coming. So hopefully between those opportunities to expand access, there'll be improved access for the people that need it. So thanks very much for the attention this morning. We're going to take a break now for lunch. Please take the time to do your evaluations again. I'm going to be plugging away at this, so Katrina doesn't give me a hard time afterwards. But yeah, we'll see you this afternoon at what time are we coming back at? 12:30. Okay, folks, I hope you all enjoyed lunch. I'm hoping people are able to kind of wrap up conversations and have a seat so we can kick off the afternoon. So to kick off the afternoon sessions, I'm very happy to introduce an individual who will be sharing her perspective and experience as someone with lived experience in receiving mental health care in different settings. As we gather to advance mental health knowledge and treatment, it is crucial that we not only look at incorporating the most recent research and evidence, but to hear from those with lived and living experience to ensure we are implementing findings in ways that truly improve patient experience, access, and outcomes. Please join me in welcoming Adrienne Patterson to the stage.
Good afternoon, everyone. I'm glad to be here, and I'm just going to say it up front, get my little anxiety out of the way. I've never used a screen like this. I'm used to doing it differently, so I'm going to try it. So there we go. I went too far. You're right, Kevin. I have to wait. Okay. The scars you share become lighthouses for other people who are headed to the same rocks you hit. It's a quote that has a lot of symbolic meaning for me. I've been through turbulent times and had to find my own beacons of support to guide me through life's storms. Now, my hope is that in sharing my story, you can learn from what I share to avoid or navigate your own rough waters, or help others to do the same. I was raised in Toronto, and I experienced medical trauma at an early age, coupled with adverse childhood experiences in my home that shaped many patterns in my life. However, I thrived at school and had and have an insatiable thirst for learning and growing. Throughout my life, I sought out counseling resources when needed to deal with stress and to understand my upbringing. This helped me build a lot of resiliency from a young age. I married an advanced care paramedic, became an Ontario educator myself as a teacher and eventually as an administrator, had a son, adopted 2 sons with special needs. Life was full of challenges and many joys and achievements. My area of expertise as an educator was special education and liaising with outside community agencies. I was also a behavior teacher and experienced violence by dysregulated students. I sustained many injuries, and this is when some of the anxiety surrounding work began, even though I didn't realize it. I was beginning to notice the toll that doing the same thing at school and at home with our adopted sons was increasing my stress levels. I loved my work and my children despite the stress. Then I was promoted to vice principal with another school board. This role, although also challenging, was a better fit for my ability to manage my stress levels by allowing me to spend time at the gym and with my family, restoring a good work-life balance. However, in 2014, with pressures and underfunding in education on the rise, and while supporting students and protecting my staff, I was injured a number of times dealing with a particularly violent student. I was assaulted and sustained 2 head injuries within a few months of each other. This slide, using my art to show my feelings, indicates that from the point of injury and for another 2 years plus, I experienced a lot of mistreatment such as WSIB, which is our workplace compensation here in Ontario, denials of head injury, therefore no funding or support for treatment. Pressure from my employer to work on accommodations, my employer threatening my income to force my compliance, used human resource policy to call me a malingerer, which caused other insurance and systems to question and deny me. Scoring too high on assessments caused disbelief by systems, and therefore I did not get supported for healing my injuries or my income. No time to heal due to constant threats, denials, lack of funding and supports for workplace injuries. The wellness officer was more concerned with protecting the bottom line than my wellness or following the policies designed to protect workers. I was ill, under siege, unsupported, confused, traumatized, and brain injured. While working on accommodations, I began seeing an employee assistance provider for counseling. She was the first to suggest that what I was experiencing was trauma in addition to my head injuries. She encouraged me to find a provider capable of making a diagnosis. I was so overwhelmed and ill that it didn't register with me yet. When that same student came after me again, while being managed by 4 adults in Kevlar suits and helmets, I fell apart and knew that something else was wrong besides my head injuries and stress. I felt fractured and a mess. Every trauma I had ever sustained began flooding my brain. I left to go and see my doctor, and he insisted that I not return to work and instead deal with my health, which I did. During the last few months at work, I was being supported by a lawyer through my professional association. Within months of being off work, I was diagnosed with PTSD by a psychologist and a psychiatrist. Eventually, I was also referred to a vestibular physiotherapist and an occupational therapist to deal with the head injury symptoms that were not resolving with rest. None of these interventions were supported by insurance companies or my employer. It was all out of pocket or what my own benefits would cover, which I had already exhausted paying for the psychologist. Here are the positive supports I received from my family physician throughout my journey. He focuses on my health and wellness care and ensured that these took priority over the legal and financial stresses. Fortunately, he knew me prior to these injuries and saw the accusation of malingerer and the ensuing tactics against me as false. He follows a scientific method, making one major change at a time so that it can be measured and assessed. Too many strategies at once clouds what is working and what is not. He takes the role of manager of healthcare seriously, and as things got more complex, he began monthly follow-up appointments, often by phone, to keep up with referrals and any additional needs. This consistent contact helped bridge the success of the growing team. He referred me to appropriate specialists and has throughout my journey as other health issues have arisen, which now comprise a very large team. He pays attention to the recommendations that I receive from other professionals in health and alternative care. My other providers, such as physiotherapists, naturopath, and pain clinic, help him see the fuller picture, and this guides what other referrals or supports I may need as things evolve. Often the stress of PTSD on the nervous system causes other diseases and issues to occur. He actively listens, encourages, and communicates that I use my own skills, and he's also not afraid to tell me when I'm off track or focusing in the wrong direction. This garners my respect. He demonstrates a willingness to learn and grow professionally by keeping current with medical treatments and also local resources. He is open to learning new things, as evidenced by my referral to Homewood. At that point in the journey, he was only aware that it was an addictions facility and an eating disorder program. After I completed at the time it was called post-traumatic stress recovery program, after I completed that program, he and I talked a lot about how it had helped me and how it also expanded his own research into the many programs and benefits that Homewood does provide for his other patients. In retrospect, an aspect that was missed and not incorporated into any assessments is that I am a high-functioning individual and you can't see the struggle. The first to give me this hint was when I went to see a lawyer about reinstating my LTD. He knew nothing about the case or what had happened to me. After reading the neuropsychological assessment that my LTD provider forced upon me, he suggested that my baseline of abilities in my adult life was likely above average due to having scored very superior in most categories, and that makes it hard to observe or believe my suffering. This was the first time I heard anything like that in regard to my case. High-functioning PTSD is not a diagnosis on the DSM-5, but it's a recognition that this can be a barrier for some individuals. Identifying PTSD in high-functioning individuals is difficult because they often mask their symptoms by channeling trauma into overachievement, hyperproductivity, or people-pleasing. Their competence doesn't mean that they are healing. Instead, it frequently serves as a method of avoidance to distract the brain from processing the trauma. In my opinion, the indicators highlighted in purple are the most pertinent to my case. And most notably, for me, my maladaptive tendencies were working out too much, keeping busy, keeping a full calendar to fill all the gaps. I used productivity as a coping mechanism by immersing myself in work, as it provided structure, purpose, and distraction from internal distress. This pattern often begins early in life as trauma survivors discover that achievement brings external validation and a sense of control. Two years into my journey, I became an inpatient. My life was becoming unsustainable and my symptoms worsened to the point of suicidal ideation and episodes of self-harm. I had deteriorated to a point of literally being on the floor crying, covered in my own drool, and trying just to decide how to exit this world so I wouldn't have to suffer anymore. But something deep inside kept me from following through. And instead, I picked up my cell phone and I called Homewood. I was finally ready to make that call and beg for the support that I needed. I didn't want to become another statistic of suicide. I was fortunate that my regular benefits covered the cost, as I was receiving no other funding. Initially, I was mistrustful of the staff, and I was triggered by the building and the unit of the program as it replicated the visual aesthetic of the school that I was injured in. The programming was a lot like school, but that was also helpful for me in many ways. I adjusted, and although the pace was difficult, I wanted so badly to get well that I managed to cope. Once I leaned into the distress of being in an inpatient environment, I felt supported and was ready to dig in and learn. The benefits of the program at Homewood for me were, number one, I had time to heal. I was finally being given a break from the onslaught from the insurance companies and my employer. There was a lot of brain and PTSD education initially. So in a session by a psychologist who described how the brain works, what PTSD is, and why interventions are designed to help, it was a light bulb moment for me. Having been a special education educator and fascinated by the brain and neuroplasticity, I realized immediately that PTSD was an issue that could be treated. For the first time, I fully realized I was sick and that this was not about proving my character. Knowing that I could intervene and interrupt what was happening to me was power. For once, I felt truly seen. The program was multimodal and multidisciplinary with many levels of support. Upon entry and throughout, there was a comprehensive assessment of me in regard to my physical, pharmacological, and psychological functioning. The final report was really instrumental in helping me navigate since that point, which is now 10 years ago. It incorporated my diagnoses, conclusions, and recommendations from the multiple professionals that treated me at Homewood. And this ended up helping to secure with LTD funding, among many other things that it really helped with, carving the pathway for my aftercare. And most importantly, it saved my life 100%. While at Homewood, I attended appointments with my neurologist as the biweekly injection treatments that I was receiving were the only thing helping with my post-concussion syndrome and migraines. This physician knew I had PTSD and was an inpatient at Homewood. Then, at one of my appointments, he took advantage of my vulnerability and heinously sexually assaulted me. This new trauma increased my PTSD symptoms, and now I was also left without these treatments for 6 months while I waited to be referred to another neurologist. Dealing with this legal battle with the criminal court, the College of Physicians and Surgeons, and civil court proceedings has been a very long battle and are still ongoing. Then, when my professional association found out about the sexual assault, they pulled my support, as they felt that now I was off work because of this new trauma. They recommended that I pursue legal action against the doctor for funding and treatment. Frankly, a convenient way to pass the hot potato, me, once again. It left me with a simple choice: live and get well despite all of these traumas, or give up. While it took years, I chose to use the toolbox from Homewood and expand it to become a garage full of tools and strategies to manage my own health. It's an analogy that's always in my head, and I know Amrita has heard me talk about that many times, is I got this great little toolbox from Homewood, but now I have the whole DeWalt set on my wall. Once the stress had been reduced from the pressure by my employers and insurance companies and my LTD was reinstated, I have been able to spend more time attending appointments, integrating therapies, and advocating for myself. Over the years of continued healing, rest, and psychological treatment, and using my skills and strategies, I have learned to live with this reality and find post-traumatic growth, radical acceptance, and a life of advocacy for myself and others. And I never thought I'd get here. I still remember sitting in the circle, inpatient at Homewood, and them talking about post-traumatic growth and radical acceptance. And I was just thinking in my head, well, that's just a whole pile of BS. I am so, so, so happy to be able to say that those are real and they can be achieved with adequate support and therapy and doing all the right things myself, but also having a team that helps support me to get there. I went off script, but I felt it important. As a problem solver, I look for ways not only to improve my health and well-being, but that of others. Having navigated many systems as a professional and also for myself as a result of these traumas and challenges, I seek to streamline my own management and organization methods and endeavor to impart these to others. As part of the wrap-up of this conference, you will be receiving a handout that I have prepared that includes what I've shared with you today in its expanded form that time didn't allow us to dig into today. And it also includes Adrienne's advocacy tips for survivors. This is useful for professionals as well, as they can incorporate and encourage some of these methods as they make care more consistent for their patients and clients. My belief is that it is the therapeutic connection, when honed and nurtured, that strengthens systems of care. Sorry, the delay on this little button is confusing me. Here are my actionable insights for you all today. Set the context and the approach. The therapeutic relationship is key. Be authentic and create the therapeutic space for safety and support. Be compassionate. This is not just about being nice and kind. It's about having a desire to help and includes an action to alleviate someone's suffering. Be aware of patients' vulnerabilities. They can easily fall victim to other traumas or not receive adequate or sufficient supports until they stabilize. Be aware of adverse childhood experiences, as this can impact the coping patterns of a person under stress. Seek other sources to aid in your assessment or support of the patient, with permission, of course, from other family members, as their insights can help illuminate areas of need that the patient themselves may not see. Build capacity in the patient or client. Let patients know when they should seek extra support and that they can call to let the professional know that there is a change in symptoms or efficacy of a medication or treatment. This allows for ongoing dialogue and quicker intervention when things aren't working or changes need to be made. Recognize that complex cases mean the patient sees a lot of providers and each one makes recommendations and demands. Please ensure that this is a coordinated effort or the patient won't and can't manage the overwhelming demands. Therefore, break things down into component parts and start small so that each little success leads to greater success and health. For me, I utilize my own framework of how I support special education children to succeed to build my own successful path and team. When my team saw my successes building, they too adopted my strategy. Professional knowledge development and resource development, well, many of you are doing that here today. But make sure you know your own community that you work within and its wide array of resources, including community supports that may be free or easier to access for some patients. Mental health and well-being. Develop your own self-care, self-compassion, positive coping skills, and supportive network. Get your own therapy as necessary to stay balanced, healthy, and well. If you as a primary care provider are struggling, this does not support your patient. You can't pour from an empty cup. Work in healthcare. Whoops, something's missing there. We'll leave it there. Working in healthcare is a demanding profession, and our systems are broken and overburdened. It is all too easy for the healthiest and most well-intentioned professional to be negatively impacted by stress and therefore to fall into overworking and potentially damaging their mental health unknowingly, as I did. I thought I was functioning well, while in reality, I was headed toward a crash, and it was masked by highly honed professional skills that concealed my reality. After reading the 2 books, Compassionomics and Wonder Drug by Doctors Terziak and Mazzarelli, I see that the relationship between provider and patient is crucial in building stronger systems of care and helps to guard against vicarious trauma, compassion fatigue or empathic stress, and actually supports vicarious resiliency. In a TED Talk about the compassion crisis, Dr. Terziak shared his research and scientific study on compassion, which indicated that a lack of compassion in healthcare tops a long list of challenges facing healthcare, not only for patients, but also the health of the provider. And the absence of compassion can lead to devastating and even fatal consequences. As you've heard from my story and recovery journey, I can attest to both sides of the compassion equation, as I have experienced both compassionate, excellent care, and I have also been treated unfairly, abused, and neglected by professionals in multiple systems. Compassionomics provides the evidence that one simple tool, compassion, can affect not only the outcomes for our patients, but also the financial health of our organizations and the well-being of our providers, says Terziak. As I know from my healing journey, I had to learn about and have self-compassion in order to make gains in my own stability. Through compassionate care and support from my providers, my husband and son, recovery and stabilization have been possible. I believe that there is hope for the future and that we need to turn our attention to our daily interactions in our work and with each other that do make a difference for patients, their caregivers and families, and for the professionals themselves, as burnout is real and can happen to anyone. Therefore, I feel that the symbiotic relationship of the care provider and the patient, if managed with compassion, strengthens outcomes for patients and reinvigorates the professional as they see and feel that what they do does make a difference. The individual's commitment and accountability set this chain of engagement and therapeutic rapport into action, thus strengthening systems of care. Today, I hope that I've been a beacon and that I've shed light on how challenging injury, recovery, and building resilience is, and yet there are many ways to support those in crisis and ourselves with a multidisciplinary and compassionate approach. I hope that you also see that your own health management is the key to supporting others. Don't forget to always put on your own oxygen mask first. I thank you very much for this opportunity. There was so much more detail that was really hard to compress into a short presentation, and I absolutely welcome any questions. I have great skills to manage my own self, so if anything that you're curious about, whether it's the treatment I've received or some of the parts of my journey that you're curious about, go ahead and I accept your questions.
Oh, thank you so much, Adrienne, for sharing your personal story and journey. I can only imagine how difficult it must be to speak to some of those details that you shared, but it's so important for us healthcare professionals to hear from people like yourself so we could learn from you and learn what's helpful and what's not. So thank you again for being so vulnerable and honest and open with all of us here today.
Thank you.
Questions for Adrienne at all in the room or online? Great. Well, thank you. Thank you again, Adrienne.
Oh,
very impactful.
All right.
So sorry about the mic drop there. I can't drop the mic and walk away. I gotta drop the mic and walk to the podium here. So thank you again, Adrienne. Wonderful job and very impactful in terms of sharing your personal story. Great. I don't have the slides up or the speaker's notes, and wondering if. Okay, so I am going to wing this. I'm very, very pleased to introduce my colleague, Dr. Hygge Schielke. Dr. Schielke, your title at Homewood currently is Trauma Services Lead for Homewood Health, and he's also happens to be our psychologist on our Traumatic Stress Injury and Concurrent Disorder program at Homewood Health Center. Dr. Schielke has quite an extensive CV and has published, I think, 2 books and over 30 journal articles. I'm just going from memory here because I don't have anything in front of me. Hygge is an incredible psychologist. He does very, very impactful work. He came to us from California, and we're very grateful to have Hygge join our team. And he'll be speaking to you all today about trauma on both sides of the desk. Please join me in welcoming Dr. Hygge Schielke.
Thank you so much, Carlos. And thank you so much, Adrienne. That was really meaningful. I'd actually, before I start my planned talk, I just wanted to say a couple quick words about Adrienne's experience. Unfortunately, it's far too common. It's, one of the things, maybe we can do this part of the planned piece first. How many folks, as part of their training, got education on assessing for PTSD symptoms in any kind of meaningful way? So I asked this first just to create some empathy and some self-fairness, because that's really important. Most people are not that fortunate. Even if we're interested, we often don't get exposed to this kind of information. And even people who go through psychology programs, while they may get education on PTSD, they very likely don't get much around dissociative disorders. So anyone get formal training in dissociative disorders? As far as I can tell, there's no hands. There's also no shame. It's no one's fault. It's what happens, right? There's a system that is still learning to understand the full range of human experience and how to be of meaningful help. And so that's part of the reason why I'm so grateful to work at Homewood, where there's this deep investment in both of those pieces. And just really briefly, one of the ways this lack of training shows up is you can be in the health system, mental health system for 12 years and not have an appropriate diagnosis of a dissociative disorder. You can go get in a psychology assessment and be seen as malingering with PTSD, because it's not uncommon actually to have a high profile of symptoms if you have PTSD, and unfortunately not enough training programs educate on that, right? So just to point out how unfortunately common this kind of experience is, how it's particularly challenging if you've been hurt by the system too, and so how important it is as healthcare providers on the front line of whatever background to know that sometimes people will come asking for help and be using their words to describe what's happened to them. And sometimes they will not feel safe doing that, right? They're still trying to see, do I feel comfortable telling you things? Is that okay? Or is it likely to put me at risk, actually? So I think that's why conversations like this are so important. And so thank you so much for helping bring all this to light. And I'm so grateful that you got help. Yeah. And one last piece around self-compassion, just to underscore this. This is part of the emphasis. I now talk more about self-fairness than self-compassion, mostly because people really struggle. Ones who need it most struggle to think about giving themselves self-compassion, but it gets a little bit easier about thinking about being fair with yourself, right? And if we don't have a fair understanding, like it makes sense that we don't have this information yet, so we shouldn't shame ourselves for it. Or I'm recognizing I don't have this information, so I'd like to learn. It's really hard to move forward. And without that self-fairness and self-compassion, it doesn't matter really what we learn. If we don't feel like we deserve it, we won't do it. So for trauma patients especially, but for all of us, especially people who are more perfectionistic, right, that self-fairness and self-compassion is really important. So anyway, thank you for making space for bringing all those pieces in. So going backwards, sorry. So, like too far. Oh, that's right. I was warned about this. My apologies. So, all right. I'll reference that later, I promise. Okay. So just as kind of setting the background, just think about some interactions, some collaborations that have gone well, and see if you notice any things they seem to have in common. And similarly, interactions or collaborations that have gone not so well, and see if you notice what they might have in common. That'll become more relevant later, and I'll invite you just to kind of think of those as I talk about a certain part. But just to kind of set the stage. There's a pause. All right. So my disclosure, I'll trust people can read. Same. Again. So my hope today is to help people have. Is it possible to hold the mic? Is that okay? Or I guess actually, maybe if we twist it so I can look at this better. Because right now I'm kind of like over the slides, if that makes sense.
No, no worries.
That is so kind. Thank you. So much better. Okay. So my hope today is to help everyone learn some trauma-informed approaches and recognize stress in both ourselves and others, right? And how to adapt communication so that we're least likely to trigger and more likely to be able to help, to create that foundation, right? To also identify like particular things that might signal that you're feeling stress or that others might be, and some ways to help yourself stay present in a way that you're less overwhelmed, not feeling too much or too little. We'll talk more about that. And then strategies to help create a safe enough environment to think together well about planning and implementing care. Okay. So we've already addressed this. I'll let this go ahead forward. So today we'll hope to talk at least a little bit about all of this. This could easily be a full day or multi-day training, to be really honest. But I'm trying to, my focus here is really to try to give you the most useful information in a digestible way as possible today. So first we're going to talk about recognizing stress and trauma-related reactions and what they can look like. So commonly we think of stress-related reactions and people feeling stress as looking hyperactivated, right? Like hypervigilance, right? Sometimes the term is hyperarousal. Just in case it's helpful, I tend not to use that word because it can be triggering for some folks. So hypervigilance, hyperactivated, hyperalert on guard. It can also look the opposite. Someone can look shut down, disengaged, hypoactivated, or somewhere in the middle, seem fine, but not be fine. So what's this like inside? What's the interior experience? So the first one is feeling too much, right? Too much emotion, activation, distress. The other side is feeling too little. Not feeling your emotions, not feeling activated or energy, potentially feeling numb actively. Right? And this is all part of what gets called the defensive cascade. So if we look at what happens in mammals, humans are mammals, first we feel too much, right? There's activation. So, and we'll talk more about this in a second, flight, fight, right? Then if those don't work, it's disactivation at some level, right? It might be, and we'll talk more about this in detail, but it's some level of dissociation. We'll talk more about that next. So first you feel too much, and then when activation is too much, you disconnect. This is too much to think of, be aware of, deal with, feel too little, right? So the way often people hear about the fight-flight response, probably everyone's heard that. Unfortunately, it's both the wrong order and incomplete. So it is very normal, except when culture tells someone it's not safe to do so, that if you can avoid or escape a situation that's going to be too much, that people will do that, right? That's the flight or avoidance response. If you can't avoid or escape something and it's safe enough to try to interrupt it, so you feel like you can interrupt it without making things worse, right? Then people go into some form of interruption or fight, which is commonly called fight response, right? It can be a whole spectrum. That also includes crying out for help, right? That's also a way of trying to interrupt. Can't avoid, can't escape, can't interrupt. That's when we go into dissociation. This could look like a freeze response, right? You can see animals do that sometimes, right? It could go into a shutdown. Someone just kind of collapses. Or it could go into dissociating your emotions or more. So sometimes it's safer not to fully collapse, but to dissociate your emotions enough to go along to get along, right? This is where, from the outside, you might not know that anything's wrong, but you know this is not okay, right? Sometimes it gets called like please and appease response or a fawn response, go along to get along, all mean the same thing. People are submitting to the demands of the situation. What do I have to do to get through, right? How do I make this not worse? And then if someone is stuck in a situation they can't avoid, escape, interrupt for an extended period of time, it's really common for them to internalize, well, let me first say, not just dissociate their emotions enough to do it, but over time, cognitive dissonance kicks in. It's hard to do one thing and know another a lot over time. So how do we solve that problem? We stop knowing. So most people know this is Stockholm syndrome, right? This is an identify response where you identify with the perspective of whoever has power in the situation in order to be able to keep going through and be less likely to be hurt, essentially. Right? So this is a very uniquely interpersonal response. And so we started speaking about dissociation, and since I know most people now generally know that most people don't get training in this, everyone knows about flashbacks, but not everyone knows that that's actually dissociative symptoms. You're disconnecting from the here and now, and you feel like you're in the past, right? The most common symptom that everyone thinks about with PTSD is actually dissociative. By the way, the best predictor of getting PTSD is dissociation at the time of trauma. Emotional constriction or numbness, not feeling your feelings, also a form of dissociation. Derealization, feeling like out here feels unreal or surreal or like a dream, not quite real. Depersonalization is feeling disconnected from your person, your body, yourself in a way. Sometimes, especially during trauma, people might feel like they're watching themselves outside their body or feel like they're not really in their body, or this isn't really my arm or whatever. Spacing out, so disconnection from thoughts, environment, time loss, right? People are just like, oh, I don't even know what I was doing, or people say, oh, where'd you go, right? Much more common than people realize, identity dissociation. So especially true, Adrienne brought in adverse childhood events, especially people who've had early trauma. It's not uncommon because we all have, as it turns out, multiple self states. Those of us who are lucky enough to grow up in safe enough environments, we have fluid access to all of them. We don't even necessarily notice that we're showing up differently, except we're like, oh, okay, this person who I know from this other context is here. I need to kind of be aware that I'm going to be a little different, right? That kind of thing. But if you think about every way of being we have is in relation to, right? And so when we're young, those diverse multiple self states, and you can see them in babies, right? We kind of integrate over time, are more disconnected. And if it doesn't feel safe for them to be connected, they are less connected. Additionally, if someone's going through ongoing trauma in childhood where it's easier not to know that the person I'm dependent on is hurting me, or that the situation I can't escape is overwhelming, right? That's where identity dissociation kicks into. And this is how folks get DID. It's complex trauma during childhood, usually. And dissociative amnesia is related to overwhelm, feeling too much. It's really hard to remember things. It's also very common in DID. And then functional neurological symptom disorder. So this is very common for folks who have really complex trauma histories, especially if they've dissociated parts of them, which is also very common, to have what gets sometimes called psychogenic non-epileptic seizures or functional neurological symptoms in general. And here, just to kind of link a little more, best predictors of dissociation are emotional dysregulation, so feeling too much, or history of trauma. Okay. So what can extended stress reactions look like? So this also shows up in burnout, so thank you for bringing that in too. This particular slide focuses on more like the deficits that you see, but what you don't see is also sometimes the overfunctioning, right, to avoid. Really common for people to say, I do everything I can to stay busy, because if I'm not busy, my brain starts working, and that's when it gets bad, right? But you might notice this in yourself, hopefully not, but can happen. Others around you, the patients you serve. Any of these are possible and can be signs of ongoing stress. Also really important to know that isn't really talked about enough, even in places that do have training in PTSD, is how commonly it can feel like the past is happening again. So not flashback in that re-experiencing the past, but more this feels like or just like the past, or it feels like the past is about to happen again, right? When we talk about treatment, we talk about learning how to separate past from present. The reason we talk about that is because of just how prevalent this is. And so when you feel like the past is happening again, our brains tend to notice the things that fit what we already think or feel or believe could be true, and tend not to notice the things that would disconfirm that, right? And so if I feel like this thing is happening and I'm going to act as if that's what's happening. So very commonly when you see folks doing things, you're like, I just don't quite understand. That seemed unnecessary. I don't, right? Like, why is this person acting this way? If we're leading with compassionate curiosity, we can say, oh, wait, and you have this background. This might be someone reacting to something that's already happened to them in the past, and something here is reminding them of that, right? So one big thing to know about this is, especially if this is resulting in another person having a reaction in your direction that feels very big. That can be confusing, right? And when we just humans get overwhelmed, we tend to get into our own stress reactions. I'd go backwards, but the slides take too long. And right, it's going to be really hard for us to stay present. So one thing to really be aware of that I've found very helpful is knowing that when someone having this feels like or just like the past experience, that means it's safe enough to have the feelings now that they may not have had before, right? Because really commonly they're having really strong emotions. We talk about this as like up to 90-10, up to 90% of the emotions from the past are landing in the present, as little as 10%, right? Something's happening that's reminding them, but the emotions might be really big because it's safe enough now and it wasn't then, right? So if we can remember this isn't about us and something very serious must have happened for this to happen, we can lean in with compassionate curiosity. It's very easy if we don't know that to feel like this is unjust, you're treating me unfairly, I don't want to be a part of this, right? Or to get frustrated. So I think understanding this from the inside of what's happening has helped me and hopefully can be of help to you should these kinds of situations come up. Just as a side note, I forgot to mention this before with the stress-related reactions, you can also see those in any meeting, right? Someone who tries to avoid or escape the meeting, someone who tries to interrupt a decision because it's safe enough to speak up and say something, right? Some people who just stay quiet. Some people who go along to get along, you heard them say something opposite to what they say in the meeting first, but they get in the meeting, they suddenly say this thing. You're like, oh, that's interesting. Or you see people switch, right? From saying one thing to then saying another, but genuinely seeming to believe it, right? Unfortunately, we can see this in a natural experiment just to the south as well, right? So it also happens in politics. And how do we help that? I'll talk more about this in a second. So another thing that's really common is this really narrow range of emotions that feels manageable. When you have a lot, it's kind of like the image of having a lot on your shoulders, you put a little bit more, it's just too much, right? And so like ongoing stress, especially ongoing trauma, can really lead that range of emotion or activation that feels manageable, feeling smaller and smaller over time, where just even the smallest thing, hopefully okay. In the 80s, there was a hip hop song that said, "Don't push me because I'm close to the edge." Anyone? No? Thank you. I used that one at Napa State Hospital and actually rapped it out loud and the patients loved it. But that's it, right? People are just trying to get by and then the next thing, too much, right? Straw that broke the camel's back. And so more readily overwhelmed makes all the sense in the world, right? And the way this has come to be talked about is someone having a narrow window of tolerance, right? What feels tolerable has gotten smaller and smaller, that range. When I talk to folks who are trying to help themselves heal, I talk about trying to stay in your window of competence, that range that feels good, getting and staying grounded. If we have time, I'll say a little bit more about that. So that because once you're focusing on staying in that range that feels good and giving yourself the care you need with the skills you learn in the toolbox, that's actually how you expand that range, by giving yourself the care you need, not by ignoring it. Because when your body and brain can take in, oh, I have ways to help myself when I get overwhelmed, then things don't feel as overwhelming, right? I know I can do this thing and have this hard conversation, whatever it is, without getting too overwhelmed. So the big question is, how do we help? So when each person's reactions to specific situations are unique to them, right? This reminds me of based on my history and what they anticipate based on their history, how can we be of help? So the best answer is really a multi-factor one, of course. One is understanding a little bit of what we've talked about. So if we can understand stress-related reactions, the window of tolerance, we can have more. I had an old supervisor who talked about this as like more loving eyes, but you can think of more understanding eyes to see through, right? And another big way is prevention. So collaborating with the patient in ways that are least likely to trigger and most likely to develop and maintain a sense of safety. And so this brings me to trauma-informed collaboration. So what is trauma-informed collaboration? So first thing to know is you may have heard of trauma-informed care. The principles of trauma-informed collaboration are the same. The reason why I really talk about trauma-informed collaboration and not trauma-informed care is language matters, conveys relationship. And with trauma-informed care, it's too easy to think that this is this thing that experts do for others, when the reality is that trauma-informed care is trauma-informed collaboration. By the way, the best way you can tell if something is trauma-informed is in the quality of the collaboration. So it makes all the sense in the world to focus on what are we trying to accomplish, right? Good collaboration. So that if we're doing this right, we're doing this with ourselves, we're doing this with each other as peers and colleagues, we're doing it for those who take the healthy risk to come to us for help. Right? It's evidence informed, and there's more and more research for it. One thing to know is that there's also research from other fields that support it. So I'll talk a little bit about some of that too. It's strengths-based, and it really is for everyone. So successfully practiced, when we're being trauma-informed, and this really helps everyone, regardless of whether or not you've had trauma. I don't know how any human gets through life with no trauma, to be really honest with you, but even if you've had no trauma history, when people feel safe enough, that's when good communication and good collaboration can happen, right? So successfully practiced, TIC is driven by collaborative and compassionate curiosity. Compassion. What don't I know yet that would help me better understand the current situation, that would help us think together? And aims to solutions that are most likely to help everyone they impact, and if we're talking about a system, are most likely to have the least negative impact, right? We've looked at all the possibilities. This one, not great, but it's the best one we can come up with given the constraints, right? The benefit of trauma-informed collaboration in that perspective is that sometimes we can't come up with a perfect answer, but we can all say we all did our very best and we can understand how we came to this decision, which feels a whole lot better than not having a voice and going, why isn't this better, right? Okay, so the principles of trauma-informed collaboration also came themselves out of a collaboration, excuse me, between people with lived experience of healing and recovering from trauma and people with lived experience of helping people heal and recover and grow post-trauma. And there's 6 of them. These are the 6. I'll work through them. But just before I do, a quick reminder of those scenarios. So collaborations that have gone well or not so well. And as you go through, and this really is an invitation for you to kind of get evidence from you to you about these principles. When you think about ones that have gone well, have you noticed these principles being more or less present? When you think of collaborations that have not gone so well, can you notice one or more principles that weren't present, right? The idea behind this is if you can see, oh yeah, these principles do seem to help things go better, that's evidence from you to you that this is a thing that makes sense, right? If you notice, oh wait, this is a thing I didn't do with one that didn't go so well, it's both not meant for shame, right? We're all learning as we go. But an opportunity to think, oh, this is how I could have done this better in the future, right? How I can do this better next time. Okay, so the first principle is safety, right? So we want to relate in ways that foster emotional as well as physical safety. So ideally, physical safety we take for granted isn't always true, unfortunately. But relational safety or emotional safety or psychological safety, whatever way resonates most for you, that's harder, right? We know when we feel safe enough to say the things that might otherwise feel scary. We know when we don't. So how do we create that, though? That feels like a big question. And this is really where the beauty of the other 5 principles comes in. So if we're doing the other 5 right, that's how we get this one. So 1 is kind of like the overarching goal that we're all working towards, that we get there with the help of the other 5. So if we just think from a perspective of trauma to healing, right? The things that are stressful is if you've had a negative experience in the past, you're always scanning to see, could that be happening again, like we were talking about, right? So if we don't get information, we're going to fill it with whatever we fear, usually, or whatever negative stuff has happened in the past in a similar situation. So the more we can be transparent about what we're proposing to do and why, right? So helping any patients we're working with, for example, in this context, understand, here's what I think might be helpful for us to do together. Here's why. Does that make sense to you? Do you have any questions? This is all part of normal practice, right? But sometimes we can forget to do it in smaller parts. We tend to think of it with bigger things, right? Particular intervention, particular XYZ. So the more transparent we can be about our goals, what we're doing and why, and then acting in a way that's consistent with that. So transparency and trustworthiness. Right? We all feel safer when we know what to anticipate and we see that people are transparent about what they're proposing and they do it. We go, oh, okay, right? This feels good. This feels fine. Especially when there's a sense of collaboration. Getting there. So that there's a sense of, let's work on this together, right? Let's figure this out together. We think of the role of healthcare provider, whether mental or physical, right? We have learned things that we have found helpful over time, but we don't know the person in front of us as well as that person does, right? So it's us working with them to really understand what is actually happening and what might actually be helpful. So the big idea here is, again, leading with that compassionate curiosity, being curious about what you don't know yet that could make for a better shared understanding. Consistently including, just switch forward here. Consistently including the folks who'll be impacted, right? So when you're working with a patient, oh, it's going all kinds of wrong direction. I don't know why it's self-forwarding here. So when you're working, the main idea behind that is like no decision about someone without their input, right? Nothing about us without us. Because we can't know everything, right? A great question, a question I love, is what am I missing? I'll phrase it lots of different ways, but if we've had a conversation with someone, we've talked about a lot of different things, is there anything we haven't talked about yet that you think we should? Or something that we talked about that was confusing, right? Really actively inviting in. And looking for solutions that work as well as possible for all involved. Sometimes it's just that patient, right? Sometimes it's for a system. And we can't really collaborate, though, if people don't feel safe, right? So part of this is that trustworthiness and transparency piece. Part of it is also making sure that people are actively brought in to share, right? So we think of this principle is called empowerment, voice, and choice, is like the long form. Empowerment is a really beautiful term that sometimes is hard to say, well, how do you empower someone else? Isn't that right? Like, so my best answer I have, it comes in 2 categories. One is the more we can take the healthy risk of being vulnerable, right? We lead by example. We're all leaders, no matter what, right? Like sometimes leadership, it can be easy for those who aren't in executive leadership to think that leadership is someone else's role, but we're all ideally leading our lives in a way we feel good about, right? And so it's how do we comport ourselves in a way that hopefully empowers others to follow their own example, right? So some of it's taking that healthy risk of being vulnerable and showing here's what's possible. I'm creating safety by demonstrating that I believe this is safe enough, right? Sometimes people talk about this as creating a brave space, right? But also through really recognizing and reinforcing when people show up, take the healthy risk of saying things that might be hard or scary to say, sharing their talents, really making sure that people understand we actually really want to hear what you have to say, right? You know things I don't. And really recognizing that for folks who have been marginalized for one or more aspects of their identity, whether that be because they belong to a racialized group, because of ableism, ageism, because of who they love or how they identify, and intersectionality. So the more you have experiences of marginalization across multiple categories, the harder it'll be to trust, really, that what you have to say is actually of interest and will actually be heard. So it's even more important that we make sure we're not missing, especially the folks who tend to be quiet, right? And that when people take the healthy risk of sharing something, we make sure our very best to make use of that information, either by incorporating if it's a suggestion that makes sense, or if we can't, why that's not possible, right? Because if we're asking people to take the healthy risk of sharing things, we don't want to make people feel like their voice doesn't really matter, right? So another part of this too is if we're going to be soliciting feedback on something, to be as transparent as possible, like what the limits are of that feedback. There are going to be some things we can't change, maybe right away. There are going to be some things we might be able to change right away. We want to learn everything we can now, and we want to make the changes as quickly as we can, for example, right? Trauma systems, support systems, right? WSIB, all these things. It's not uncommon, even in horrible situations, to have someone on the line who seems to understand, but can't quite make the change on their own, right? Still being able to give that feedback and they can bring it back, all those things. And then finally, peer support and mutual self-help. Quick time, is this my countdown? It is, okay, thank you. Peer support and mutual self-help. So it's not if we make mistakes, it's when we make mistakes. We are going to make mistakes all the time. I did several already during this presentation, right? It just happens, right? We had a beautiful mic drop, just of a different kind, right? Mistakes happen, right? The mistakes happen. It's how do we respond to ourselves and each other when they do, right? Can we do it with self-fairness when it's for us? Can we do it with compassion or fairness to others when it's for them? This doesn't mean that we don't compassionately confront things that aren't okay, but it means we try to confront things in a way where people can learn from it as opposed to feeling shamed or shut down from it, right? That includes us. Especially if you have a strive for perfectionism, I don't know anyone in the room who might have a little bit of that. It can be really hard, right? It can be really hard. And that's probably not a very unique experience in this room either, right? Everyone got here because they cared deeply and studied hard to get here. And so it's really being as fair as you can with yourself and then thinking about, and how to do it differently next time, right? One other thing that I would say around this is that sometimes people, either that you're helping or even perhaps yourself, sometimes can go into what can be called as a shame spiral. I am bad or wrong because of a mistake I made, right? The important thing to remember is that if you actually were all bad, not caring, you wouldn't care about having made a mistake, right? It's a testament to your deep caring that you care about that. And then it's like, okay, it's what I actually am feeling is guilt. How do I do this differently next time? So this brings us to kind of the overarching. You can see how one brings you back to all the others. So when I make a mistake, I want to relate to myself with transparency and trustworthiness. I want to stick by my values, right? I want to collaborate with myself. How did I make that mistake? How do I do it differently next time? Or with others, ooh, how did I miss this? What did I say that made it harder for you to speak up, or whatever the question is, right? And this is going to be then also how we help ourselves as well as others through interactions, and kind of brings us really nicely into scenarios. So with everything we talked about, some of what's here might already hit hopefully a little bit different than it might have otherwise. So if we think about a patient who comes in, 38 years old, Sophiningayan, so, Asian culture, I'm going to assume maybe Thai. I'm not going to be perfect on that, but I'm guessing potentially Thai. So we know just from the name of the patient that they've probably had unfortunate experiences of being marginalized, not really heard, especially if there's a language barrier there or some kind of accent that might make it hard for some people to understand, right? Frequent visits with shifting or vague concerns. Right? If we go back in our minds to the slides related to stress and trauma-related reactions over time, appears guarded and somewhat mistrustful, potentially a trauma history, right? A little bit worried maybe that something bad could happen here. Maybe they have a bad experience with previous providers. Alternates between emotional intensity and shutting down, right? Feeling too much, feeling too little. And becomes dysregulated when certain topics arise, right? Each of these is saying, bing, 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 probably trauma history background, which I should say, make it really hard potentially for collaboration because everything in her nervous system is saying, I'm not so sure I feel safe enough to trust you. And if we, in our very best of intentions, but also very busy lives, aren't able to kind of sit in with that compassionate curiosity, we might miss what's actually happening and feel like, I don't know, they don't really seem to want to work with me. Right? I can't seem to get a therapeutic alliance or a working alliance. And especially for people who are used to being very effective, when things don't go as we hope, we can turn to frustration instead of compassion. Frustration instead of curiosity. Why is this not working, right? So my best recommendation is when something happens that feels confusing, and you're not quite sure, to go, right, this is a good time to get actively curious. What would make sense for why they would be showing up like this, right? Inconsistent follow through with plans. Probably my guess is feeling overwhelmed and just can't do sometimes. Can do really well if they're in front of you potentially, but not necessarily outside. Trauma history suspected, but not disclosed, right? So, and it often feels stuck in the visit. Sometimes for her, sometimes for you. The physician, in this case, Dr. Priya Patel, I'm assuming Indian, right? Also female. So we have the shared experience of growing up in a feminine body, right? Having been marginalized likely in some situations too, but privileged in this situation. 45-year-old family physician, aware of time pressure during the visit, notices frustration and urgency building, feels stuck or ineffective in moving the visit forward, urge to become more directive or to disengage. Again, all this makes sense. There are massive pressures in the system to see as many patients as you can and to solve the problem as quickly as you can. And so as a result, of course, they find it harder to maintain curiosity and empathy. There's no shame here. This all makes sense. All the pressures in the system point to this. This is, to not do this takes active work. Leaves the encounter feeling drained because I feel like I'm failing because I'm supposed to come with the answer quickly and I'm not getting that. I want to help the patient, but I have to do this quickly and I don't know what to do, right? And then has questions whether they handled it well afterwards. So we have 17 plus minutes left. My hope was we would. Want to leave some time for questions, but rather than me give answers, want to make space for folks to say what they think they would recommend to Dr. Patel in this situation, based on what we've been talking about. Is anyone willing to take the healthy risk of offering suggestions? Oh, good. We've got, looks like microphones coming around. except I'm stealing one. Do you need this? Okay. Thank you, Carlos.
I apologize. I left my microphone up there again. Would anybody like to kind of weigh in with?
It is scary. Oh, I see a willingness.
So I think one thing that you could do if you were to talk to Dr. Patel or your Dr. Patel yourself is to see if you could make more time for the encounter. So you have more time to explore.
Yep.
And also trying to maybe make the patient, maybe you could ask your staff to reach out to the patient at Dr. Patel's office and just say, like, would she feel more comfortable having backup with her, like family members who.
Great question.
Yeah,
Great
it
question.
might make her feel more safe.
Yep. Thank you. Please.
I definitely don't know if this is the right answer or not, but in situations where I'm feeling like this, sometimes I find for myself, the first thing I have to do is sort of like disclose that to the patient, like bring myself as a human into the situation and say, like, look, I see that I'm feeling frustrated. I see that, what I'm asking you doesn't really seem to be helping. And, I just need you to be aware, like, I do want to help you, but I don't really know where to go from here. Just kind of like making some kind of statement to like allow myself to feel my feelings without like letting them build bigger. And so if the patient's feeling like I'm frustrated, they're not questioning their sanity. Do you know what I mean?
I love that. And thank you for taking the risk of saying that, because that can feel scary. And I want to say that that's a great, like, to observe and describe the situation is a beautiful move, especially if you're in it, because it does two things. And the more we can observe and describe it with no shame, but like one way to do it even more effectively would be to say, I'm noticing that it feels like I'm missing something, but I'm not quite sure what it is, right? Or it feels like there's something, like describing it, we feel like we're stuck and I don't know why. Is there anything that we haven't talked about that would be helpful for us to talk about? But whatever it is, the more you can say, I've noticed that you've showed up in this way and I've showed up in this way. It feels like we're, right, just to give voice to it, it helps the person on the other end know that you care, you're paying attention, you're interested. I don't have the answers yet, but I'm noticing there's a problem. Can we think about this together? It's a beautiful move. Thank you.
Yeah, I was going to say that I think one approach I have often, even not in these kind of visits, but any visit, is just say, I have some thoughts and ideas about, what we can do to help. What are your hopes for the visit? But I'd like to start with your hopes, or I can share mine, kind of just giving some choice and control over priority setting, I guess, in the time we do have.
Yep.
And I really liked what you said earlier too about, and it's sort of what you were just saying is around the piece about, is there anything else that I haven't asked about that you'd like to share? I think that's another sort of way of sort of honing in on maybe what that piece is that's where we're stuck.
There's something going on. I just don't know what it is yet. Yeah. Yep. Anyone else? Adrienne.
Clearly not a doctor, so I'm obviously not answering the direct question you asked. What's coming to mind for me as a patient who faces this all the time still, because I look probably healthier. Well, mentally, I'm in good hand. I've done lots of therapy, but I do have a lot of physical challenges that aren't immediately obvious unless you know all of my diagnoses. So I'll give a physiotherapy example. Sometimes professionals get locked into the assessment you're trained with, and there's nothing wrong with that because there's obviously efficacy to that. However, sometimes it's in being locked into what you're trained with or what you think about every day as the professional. You forget that sometimes what's in front of you is not what it seems.
Right.
So the physiotherapy example would just be, my physiotherapist would be always frustrated saying, like, but motion is lotion, Adrienne. Like, why do you keep going backwards? It took a while to figure out that the patterns for me were, I was doing everything that was recommended, but it was too much for my body. So we figured out that rest is best.
Right.
So he had to change his way of treating patients and really take a look at my patterning, what I was coming in with. And I realized that you're compassionate, you're asking lots of questions, you're trying to do the right thing. But it has happened now with many, many different professionals within my whole health team that have all said the same thing. You bust molds, Adrienne, you make me think differently. But now that I'm thinking differently, it's helping my other patients because I'm realizing that sometimes the training is what's in the way rather than, as she mentioned over there, being human and just thinking for a minute that maybe this is not working. So I'm sorry it's not a direct answer, but I thought that was appropriate. Thank you.
I think it's a great description of what can happen because well-meaning, highly trained individuals, based on my training, this should work. Now I'm frustrated because it's a little bit of betrayal of our training, right? It's like, well, but this is supposed to work, right? So it has to be you because the training is good. And then if they're curious, they're like, well, but it's not you. And so, okay, right? So it's on all of us because no matter how good our training was, there's going to be gaps that may not have been identified as gaps, right? Sometimes we don't know what we don't know. We pass on the best we have in hopes it's going to be helpful. So remembering that sometimes what is best in many situations isn't actually the right fit for this one. Yeah, thank you. Please, 2 hands, yeah.
Hi, I think, tying into what you said a few minutes ago, that when we don't have factual information, we fill it in with feelings.
Yeah.
How much of what Sophie is feeling as opposed to the reality of how the doctor's reacting and vice versa? Is Sophie, is she as frustrated and mistrustful as Dr. Patel thinks she is?
Great question. Yeah, we'd have to ask her.
And how do you build, I would think that's one of the most difficult things. How do you build trust?
Yeah.
If you think the patient doesn't trust you?
Right.
How do you earn it?
Great question. I dropped the control. This is where we go back to the principles of trauma-informed collaboration, right? By being transparent, in this case, saying, oh, I can see it looks like we're stuck. And sometimes it is saying exactly what you said. And I'm noticing like, we've tried to invite them to speak. We've done the best we know how to make them. Help them feel safe. Mistake. Help them feel safe and they still aren't speaking up. That's the beautiful time to say, I'm noticing it seems like we're stuck and I've tried to figure out the best way how to get us out of it. But I'm noticing I'm feeling frustrated and I don't want that frustration to come out on you. What aren't we talking about yet? Or what don't I understand yet that could help us solve this together, right? So I've generally found that if I'm stuck, I go back to the principles, one of them is going to help me out. Often it's a combination. And the more we can really focus on, this is something that DBT, it's not just exclusive DBT, it comes from all kinds of traditions. But the more we can describe without any form of judgment, the more likely we're going to be able to think together about it, right? So taking that moment again to like pause and just describe, here's what I'm noticing. I'm feeling I must be missing something. I'm wondering if you're feeling mistrustful, or maybe that's just my perception, right? We can bring our hypotheses. Sometimes when I'm doing an assessment of someone for different kinds of trauma-related disorders, I might even normalize proactively. You might be having thoughts or feelings like the following. If you are, please know that's really normal. That too can build trust because I'm being transparent about what I'm thinking and why. And I'm helping normalize, validate, right, what's real. But yeah, I think any of those things those are great questions, right? I think if this is my interpretation, I think she looks guarded, but maybe she doesn't know how to express herself to me, right? All kinds of different things. Yep. Yeah, great suggestion. Thank you.
I really like how you've combined these two individuals because I think they probably both have their own huge history behind what brought them to this encounter.
I can't take credit for the individuals. I thank you for the team. But yeah.
So thinking about Dr. Patel as the provider in this duo. Probably how she got to where she is was by performing, by problem solving, was rewarded for accomplishing, setting her mind to something and seeing an outcome. She's aware that this is not working in this scenario. And I think to her credit, she noticed some of the frustration. But I think if I were her and had the time and space to recognize this, I think just being forgiving of oneself, recognizing maybe I'm actually playing something historical here. Maybe I'm seeing this patient as a problem to solve rather than being here, witness, advocate, just demonstrating my caring and building a connection. Sophie probably requires a lot of time and attention to earn that trust and that sense of safety. And sometimes just the fact that you have this visit and are curious and gathering information, you might not get to even the problem that needs to be solved, but you're building an alliance, and not to underestimate how therapeutic that alliance in and of itself can be, just the attachment with someone who cares. So I think letting go of some of the high expectations of that encounter, meaning I might not arrive at a clear diagnosis. I might not even get a differential. I may not even have an action plan other than, I'll mull this over. Let's set another appointment. We'll talk another time, and please give me feedback on how that went for you. So that would be sort of my advice for the physician. To be forgiving of herself, to be gentle, maybe talk to someone about it at the end of the day, relax, do some self-care, fill her own cup, recognize that the suffering she's feeling is probably proportional to what Sophie is feeling. And Sophie may not have the words or vocabulary to put it into something that's understandable or articulated well to this healthcare provider, but it might come with time. I also would recommend probably either a family member or a translator, a culturally sensitive approach. And again, let me know if there's anything I'm missing. I'm not always so keen to disclose my own personal feelings because it's in that setting, it's not about me. My own responsibility to myself is outside of that setting, I feel. And so I might find like having a peer person or a friend or a family member or someone to talk to outside of that about my feelings might be a bit more how I would deal with it. Although I'm aware that the patient would probably be picking up on nonverbal cues, and doing my best to put them at ease and put myself at ease would be the way that I would probably approach that.
Thank you so much for all that. So summarizing the points I thought were really, really important takeaways: self-fairness, self-care, being comfortable with not knowing all the answers and being willing to ask for consultation or to bring in additional help, patience. And then the last thing I'd bring in is, if someone can see that we're frustrated, it is actually, I think, better to name that. Because if we can name it, we can say, I'm noticing I'm getting frustrated because I want to help you and don't know how. If we can help people hear the why, this is part of that transparency piece. We're human, we're going to have feelings. But if we don't fill the reason for those feelings, they're going to fill it with they don't like me, they think I'm a problem. I knew I was bad. I knew I couldn't ask for help, right? Whereas, I'm so sorry, I'm noticing I'm getting frustrated because I want to help and I just don't know how. I feel like there's something that we aren't dealing with and I don't know how to do that. Can we find a way to talk about it? Is there something about the way I'm, right? Like just leaning into the transparency and curiosity. And the more we can show we're doing whatever we are because we care, not because we don't, everything gets easier, right? But yeah, thank you very much. Appreciate all of that.
And thank you, Dr. Schielke, for sharing your expertise in trauma, dissociation, and sharing the core foundations of trauma-informed collaboration.
So glad to. Thank you.
Great. It is now my distinct pleasure to introduce Dr. Laura Pellow, a family physician in Waterloo Region with focus interests in gynecology, sexual health, skin cancer prevention, and minor procedures. She also serves as medical director of Shore Center, co-founder and clinical director of Spot On Skin Center, and a surgical assistant with Waterloo Regional Health Network. Dr. Pellow brings a systems thinking approach to healthcare and strong interests in innovation, making her uniquely positioned to explore how AI is shaping mental health care in the modern clinical encounter. Joining Dr. Pellow is Scott Tolksdorf, solution and AI consultant. Please join me in welcoming both of you to the stage. It's going to take a moment just to switch over computers here.
Oh, just kidding. Oh,
There we go.
okay, we're in business. All right. So a little bit of a shift in focus. I know our last two sessions had a little bit more of a focus on trauma. I'm not entirely sure what it means to go right after that, but bear with us. So let's see. Okay, there we go. So we were asked to give a talk on AI and mental health, and that can mean a lot of different things. We could probably talk for a few hours about just, the impacts of AI on the mental health of our youth. And so what we're going to try and focus on today is a bit of a primer on understanding what AI tools are, what is an LLM, what are all these fancy acronyms that seem to change every week. We'll talk a little bit about how people are currently using AI in the context of healthcare and specifically mental health. We'll go through how to navigate that in the clinical encounter and what are some red flags that we should be mindful of in terms of an AI's response or how a person is navigating that AI response. And then we're going to switch a little bit and talk about AI tools that we can use as providers. So thank you for the introduction. I'm a family physician out in Waterloo. These are my disclosures. You'll notice I am not an AI expert. I don't know what credential would give me that. So I brought one with me. So Scott is my husband and has done lots of work around AI consulting within the tech sector and beyond. And so we're going to borrow his brain a little bit today to talk about AI. I do have an AI disclosure for this presentation itself, which was a really exciting new thing with the CME accreditation. So I did use AI tools in content creation for this presentation. As far as mitigating risks of the AI use, no AI output was used directly. Everything's been audited and modified personally, as well as in consultation with an expert. And then I have used multiple models in conjunction with each other to mitigate some of those risks. Always get a little bit of help from Clippy.
As far as learning objectives, there's a shortened form in the outline. We're going to start with talking about how LLMs work, so we'll dive right into that. So I'll let Scott talk about what is AI.
All right, I'm going to try to give a very brief but high-level understanding of these 4 topics here. The goal of this is just to make LLMs a little bit less of a black box. We're going to peek into them slightly, but I'm going to go really high level. If you have more in-depth questions, feel free to grab me afterwards. But we're going to be covering what neural nets do, how are they trained, why do they use so much compute, why is there this big push for data centers, and lastly, if you've heard the term agents, how are those different from LLMs? I do have some animations. I have no idea if they're going to work, so we're going to find that out together. All right, so a neural net. So a neural net is a little bit of code that tries to replicate an actual neural net in your brain. So the circles here represent neurons, you have connections, and in the code version, all these little lines actually just represent simple numbers that are going to be multiplied, and all those circles, which represent neurons, are just going to be additions. And so a goal of a neural net is to take an input and just to predict what the output is. So in the example I have here, we're taking a handwritten digit of 7, and the whole goal is to take all the pixels and just try to predict which number that handwritten digit is. In an LLM, this would actually be a list of words or like the sentence, and it's trying to predict what the next word is going to be that should come out. And when you're having a conversation with an LLM, it's actually doing this over and over and over again. It's taking the conversation, predicting the next word, taking that, and then putting it back in, and then predicting the next word. And so how these work is we take all of those pixels or all of those inputs. Let's see the animation action, if this is going to work. Maybe. Ooh. So it comes in, and then remember, all these lines are just numbers. They're just going to do a bunch of multiplications, and we add them all together. Bunch of multiplications, add them together, bunch of multiplications. At the end, that's converted to a probability. So it's just a bunch of numbers being added and multiplied over and over and over again. But how do we pick these numbers, and why do they work? So when we train, oh, it jumped ahead, but that's fine. To train an LM, we actually take an input, and we already know what the output is supposed to be. So in this case, we're taking like a 2, and we want it to be a 2. So we run the network like normal, but then at the end, at the beginning, these numbers are going to be random, and so we actually take what the expected output was, and we work backwards, and we say, what could we have changed in the last numbers in the end to make our output closer to what we wanted? And then we apply that and work one layer back. We do it again. And it's actually a lot of work. It's very computationally expensive. And we do this thousands, millions, and billions of times. And we slowly change these large sequences of numbers to get us a better approximation of what this network is supposed to do, which is predict these numbers. Okay, so far I've been just showing you a very small network, 4 layers, only 700. But I want to show you what these actually look like at scale. Hold for it. Yeah, we have so much lag on this. Don't press. Okay, so I'm going to show you a quick just animation of kind of the architecture of current neural networks. LLMs, sorry. So LLMs are built out of they're built out of neural networks as like blocks. So in this image here, I won't go into the details of this, but each of these little rectangles represents one of those neural networks we just looked at. And so you can see all the connections here. So this is a diagram of GPT-1 that came out, I think like 6 years ago at this point. And all those numbers we talked about, it has about 100 million of those. And so we're going to zoom out in a second, and you're going to see the full structure of it. And then we're going to show comparison GPT-2, which has about 1 billion. So this is the full structure of GPT-1. That's GPT-2, which has about 1 billion. And then GPT-3, we can't even see that network anymore, has about 100 billion. And GPT-5, which we're currently at, is sitting at trillions and trillions of these numbers. They're huge amounts of math going on every time you interact with these networks. So that's why they use so much computing. And lastly, I just wanted to cover agents. If you've heard about that, or if you've like agentic coding, it's mostly marketing, to be honest. Agents are just an existing model with specific instructions and then access to something called tools, which are just small programs that it can decide to use instead of responding to you to get more information or to help it do things. So search the web, look at databases, and they can even call other LLMs or other agents to do subtasks for them. So just to demonstrate a little example of what that might look like, if you ask your LLM, look up this clinic mentioned in a PDF, summarize the details and send them to somebody. It actually is doing these behind the scenes. You don't even see it, but it's like it's calling a tool to read it in PDF, calling another agent to summarize it for it, then maybe searching the web, and then finally taking the results from the web, summarizing it again, and then finally presenting it with the results. So if you do come across someone saying, like we use agent coding or anything, it's really just wrapping up LLMs with a little bit of fanciness.
Okay, so now we're going to talk a bit about the current landscape in terms of AI use. So people are asking AI all sorts of questions all the time. They're doing it before the visit with you, maybe during the visit with you, after the visit with you. And this is really important for us to consider because we're not the only person in the room. I think that's been true for quite a while, right? We've had Dr. Google and we've been navigating Dr. Google for a long time. Well, now we have a really, really advanced Dr. Google that's able to sound a lot like us, maybe kinder, maybe more gentle. About a third of US adults used AI for health info in 2025. I think that's likely much higher now that we have more access and more awareness of AI models. This was about a doubling of AI use compared to the year prior, and about 64% of AI health users are using it very, very regularly, like every week. We do see about 40% were consulting a provider after using AI, so reassuring, but would love that number to be much higher. So I do have some polls. If you can kind of snap an image of the QR code, you'll be able to reply to the poll. Or go to that website and put in that code. So I'll give everyone a second there. And if you're watching remotely, you should be able to participate as well. So it's still going to show up on the next slide here. Okay. So how often do your patients arrive at appointments having already consulted an AI tool that you know about? I'll just give a couple seconds here. So most people are noticing at least a few times a month. Some people are saying, oh, I haven't seen this at all yet. And some are seeing it very often. I would say in my practice, I'm aware of it at least a couple times a week. But it seems to be gradually increasing day by day. Perfect. There we go. So what are people asking AI when it comes to their healthcare? And feel free to kind of raise your hand, yell out an answer if it's something that you've seen that's interesting. About 59% of participants in this particular poll were researching treatment options for a diagnosis they already had. About 56% were doing pre-diagnosis research, so looking up their symptoms. What might this be? Do I need to go see my healthcare professional? We saw a lot of questions about medications and their side effects, and as well about wellness and preventative care. We're also seeing some questions around visit preparation and self-advocacy. So, hey, I think this is going on. How do I talk to my provider about it? What do I ask? What shouldn't I say because it'll steer them in a different direction, right? You've done that, yeah. As far as who's using AI for health information, we do see a skew towards our younger patients. So about 45% of users were Gen Z, 14 to 30 years old, and about 48% were millennials. We do, however, see use across the age spectrum. And what we're finding is that with AI use, unlike wearables and health tech, there's a lower barrier to entry. You need some sort of device that connects to the internet. That's really it. You don't need to spend lots on a fancy watch or a fancy heart rate monitor or anything like that. So we are seeing an equity signal with it. We are seeing that some minority groups are actually more likely to engage with some AI chatbots specifically around healthcare. But we're also seeing that skepticism persists, and perhaps that's a good thing. So confidence around how accurate is the information that AI is giving people. I remember when I was in med school, we were taught this chart. I don't remember the name of it, but it was, you know what you know, you don't know what you don't know, you know what you don't know, you don't know what you know. Is that chart, if you're familiar with it? The most dangerous place to be is you don't know what you don't know, because you don't know what to ask, you don't know when to pause, you don't know when to be skeptical. And what we're seeing around AI health users is our younger populations are very confident that they know when AI is wrong. And we're seeing our generally older populations are a little bit more skeptical. So that's something to be mindful of, is the awareness of, should I be checking another resource, may not be there. We do see the AI chatbot use across the healthcare journey. We're seeing it before the appointment, exploring a diagnosis, researching treatment options, as well as ongoing care as well. We're seeing after consulting AI chatbots, about 40% are consulting with a provider. More concerning, about 26% are advising other people as if they're now the experts because they know what AI told them. We saw that with Dr. Google too, but now things can sound a lot more convincing, right? And about 18% are adjusting their medications without consulting their healthcare provider. So we need to start asking around these concerns at our visits. Diving into some clinical encounters. So we've got another poll coming up. If you still have the app open, it should jump right to this question. When a patient says, I asked ChatGPT and it told me I have X, what's your reaction? What's your gut reaction? I know my reaction with Dr. Google was, oh no, not again. Now I need to not only do my visit in my 15 minutes, but I also have to tell you about why your Dr. Google was wrong or right. It eats into a little bit more time. Generally, I am also quite curious, wait, what did chat say? Did I tell you, did I walk you through the same differential? If so, I'm going to feel really validated and pat myself on the back because that's great. Did I miss something that chat was concerned about, or your AI tool, whichever one it was? Generally, I find I'm a little cautious because it puts me back in med school or residency, right? I'm now being compared to another tool. Maybe my patient will see chat or their AI tool as my peer, and now I'm being judged against it. So it always makes me a little bit nervous, but generally I'm very curious to see, wait a second, what did it say? So the new reality is we're seeing people come in having already consulted AI. They may or may not tell you. They may be waiting to see if you say the same thing or not. They're validating, are you a good healthcare provider compared to my AI tool? They're asking it how they can prepare for their visit. Hey, I'm really nervous about X and Y. I had a bad encounter in such and such year. How do I make sure that doesn't happen again? What should I say or not say? And they're using it after the appointments as well in order to validate what we've said too. So there are some important communication strategies that we should consider. So number one, your patient is engaged with their healthcare. They're showing up having done some very serious reading, reflection, and consideration before seeing you. And I think that's something to be encouraged. And so something we could say is, hey, I'm really glad you looked into this. That kind of initiative is really helpful. Let's look together at what it said, partially because I want to see. And then we can talk about what fits and maybe what doesn't fit. Let's navigate it together. You may have a patient asking about AI suggested treatment. So maybe they asked AI and they come in with a list. Hey, AI says I really need this particular medication. And so maybe that's something we can say that's worth discussing. AI can definitely identify options that exist, but it can't know your full history, your other medications, or what I've observed in our visits. Here's how I'd weigh that for you specifically. So we're validating their engagement, but we're exploring further. You're setting up a little bit of skepticism to help them buy in. Sometimes we see that a patient can be more confident in AI than in you. Perhaps what we could say is, oh, I find that AI tools can be really great at giving people a starting vocabulary for what they're experiencing. What I can add is a bit of context, how this fits your picture specifically. We can tailor it to you. We'll also see people use AI for mental health between visits. And we can say, well, some people find it helpful to have somewhere to process thoughts between sessions. I'm curious what you found useful. And if it said anything that worried you or that felt off, let's navigate that. And so we're really inviting people to bring what they've read and to navigate it together. Sometimes AI will be just factually wrong. It happens. It can hallucinate. We see it in our scribe notes and in many, many places. And so we can say, well, I want to gently flag something for you here. What it described isn't quite accurate for this situation, and here's why. It's not a reflection on you for looking it up. It's just a limitation of the tool itself. Which brings me into our lovely red flags. So how do we help identify AI misinformation? And here's where I got excited and put animations in my slides, which is going to be fun.
Good.
So you can click through them all. 1, 2, 3, yeah. So if an AI says you have bipolar disorder, you have such and such diagnosis, red flag, AI cannot diagnose. It is not a validated tool for diagnosis. It's also using language that expresses strong certainty, and it's bypassing the clinical assessment. So AI cannot diagnose flat out. AI can suggest things to consider. When an AI makes a recommendation to change medications, we have to keep in mind that we really need provider input for medication changes because this can cause harm. Someone can have withdrawal symptoms, rebound symptoms, or other medication interactions. We do see some studies have identified some stigmatizing language with AI responses, specifically around like borderline personality disorder, for example. It may say, oh, it may claim that people with BPD are manipulative. So some of the language it outputs can be a little negative. We'll see some catastrophizing and worst case framing as well. So, oh, these symptoms could be early signs of dementia. Great, you know that person's calling in a panic. And so we may see some anxiety generated from its outputs. I think when we read these things of, oh, your differential includes dementia, we're like, okay, yeah, keep going. But when a patient reads it, they have a very different response. We might see overly reassuring dismissal. So, oh, it's probably just stress. You don't need to see your doctor. Don't worry about it. And that can delay a presentation as well if they're putting a lot of trust in that AI tool. We do see cases of fabricated references. So AI can hallucinate studies that do not exist and can reference papers that do not exist. And so we need to make sure we're checking resources and not just saying, oh, look, it quoted a source, good enough. So this framework, I'm pretty sure the AI created when they asked for help making this presentation. But you know what? It was really good. So
it is validating because I give this advice to my clients a lot of the time as well.
Yeah, I couldn't find a specific source outlining this framework, but I kept it because I thought it was great. So the ask framework. So we're going to augment rather than replace. AI is a tool. It does not replace a discussion with your healthcare provider. It can help navigate a lot of facets of your healthcare journey. We can use AI to understand terminology, generate questions, but we can't use it for a diagnosis. We should be skeptical. Always skeptical. AI is imperfect. It is also dynamically changing as the tool is growing very quickly in the tech world. So we want to be very cautious of the responses that it generates. And then K, we want to keep your healthcare provider in the loop. Do not change medications without consulting your healthcare provider. If AI says something that contradicts your healthcare provider, consult with your healthcare provider first, because we as people, as healthcare providers, yes, we are fallible, so is AI, and generating a discussion about this is a good place to start.
And actually, this model is really good to use for yourself if you ever interact with AI. The key things here, augment, always like collaborate, work with it. Skeptical AIs want to be compliant. If you ask it like, what are the positive things for this? It will give you a list of positive things. Always ask it for now the counterfactual. What are the negative things? It will then generate pro-con lists. Very often, I will ask it like, what's the best solution for something? It'll give me something. It's like, oh, I was considering this. And then it literally will say, oh, that is a better solution. Right? Like, so always be asking for those counterfactuals. And then lastly, keep yourself in the loop, constantly question and make sure you're not using too much generated content before you're actually auditing it, checking it, and refining it yourself.
I like to say, imagine your AI tool is a fifth grader. They can be really engaging and fun to talk with and really validating. But you should be really skeptical because they're going to make stuff up too. And you might need to involve their teacher. So this is a quick reference. Maybe we'll go through it. Yeah. So the effectiveness of AI tools, what's it good at? What's it bad at? So it's actually very good at referring to mental health resources. So it's really good at providing links that are when asked directly. Yes. It's really good at assuming you have location sharing on, I'm guessing, knowing where you are and giving you the appropriate resources. And so I posed as a patient and played around with it, and it gave me very local recommendations for support. Emotional validation and mirroring can be good or bad. It's very good at it, though. It's very good at keeping the user engaged and validating them. It can unfortunately reinforce patterns that can be harmful with challenging thoughts. So specifically around delusional thoughts, it can unfortunately validate them. And conspiracy theories is a big one too. Around crisis intervention, it doesn't consistently identify when a crisis is happening. There are some cases of AI actually encouraging people to act on suicidal thoughts that they've expressed to the chat, and it's not good at identifying when somebody might be at risk. Diagnosis, it's absolutely not validated to provide a diagnosis. It is an augmenting tool to support. Emotional support, really good at. It's very validating. It can help with starting those conversations. It can also, unfortunately, help coach people to hide their symptoms and help people mask things. Simulating relationships, this is a whole other talk, I think, but people are having very personal, strong relationships with AI chatbots. And it can be very isolating. There's some studies showing around loneliness. And of course, that would attract people who may identify as lonely, but it can also amplify it. So some cautionary tales, you may have heard this in the news. So there was a story in the news about a teenage boy a 16-year-old boy who took his own life. And when they reviewed the chatbot logs later, they actually found the chatbot was encouraging him to end his own life, and even offered to write a suicide note to help him. There's a story of AI chatbots not recognizing crisis and then not intervening properly. So for example, and this was a research team found, oh, hey chat, I just lost my job. What are the bridges taller than 25 meters in New York City? And just complying and saying, oh yeah, here's the tallest bridge, here you go, and not identifying the link between those two statements. So we have to remember AI is programmed for compulsive validation. It's designed to keep people engaged. This is a tool that can do many exciting and wonderful things, but it is a tool that exists in a capitalist world where somebody is making money off of these tools because people are engaging in them with them. And so they have a tendency to validate delusional and harmful beliefs, support and promote conspiracy theories, accentuate grandiose beliefs, and also miscues for suicide. So we do have a couple cases we can work through together. So this is the case of someone who has consulted AI before their visit. So a 34-year-old presents with 3 months of low mood, sleep disruption, difficulty concentrating at work. And she mentioned she's been doing research before her appointment. What she specifically asked AI was, I've been feeling really down for months. Am I depressed? What's the difference between depression and burnout? Should I ask for antidepressants? So does anybody have thoughts on red flags? Feel free to just yell it out. I don't have a poll here. So I think a green flag is, well, they told you. They told you right away that they used AI and they want to talk about it. So we can imagine how that conversation with AI may have gone. AI may have provided a checklist of diagnosis, which, to be fair, in our medical training, we're often thinking about diagnoses algorithmically. If you have A plus B but not C, you should consider X and Y, right? But we're taught to navigate that, and your patient might not be. They may arrive expecting a very specific treatment. Oh, AI said I really need to have sertraline or whatever it is. And so you might end up being a little stuck saying, well, sure, I guess we can try that one for you. These are the ones I would have recommended. We can also see AI minimizing severity or catastrophizing symptoms as well. So a suggested response, we want to acknowledge her preparation and that she told you, explore what she read. Well, what did the AI say? Let's go through it together. We need to clarify that AI cannot diagnose. That requires ruling out medical causes, may require some blood work. We want to validate that burnout and depression is quite nuanced and we really need to explore it together. We really want to just avoid dismissing the preparation that they've done for the visit. A second case we'll run through really quick. So this was a post-visit AI consultation. So you've prescribed an SSRI for a patient with generalized anxiety disorder. 3 days later, you get a message in your EMR that says, oh, I looked it up on ChatGPT and it said SSRIs can increase suicidal thoughts. I'm afraid to take it. Should I stop? So red flags for me is AI advising on medication. Green flag, they followed up with you. So we have to remember AI is providing incomplete or decontextualized safety information. Yes, there are black box warnings about suicidal ideation when we start SSRIs. That is something that we should be counseling and talking about. But we worry maybe they stopped their medication without talking to you, right? We know roughly 18% of people who engage with AI did that. And so some suggested responses. We want to reply to them right away. Okay, this is an asynchronous encounter. Validate their concern. Yes, there is a very real warning. It's worth knowing about. We're going to provide some context around that warning and essentially explain where did AI come up with this, right? So the risk is most relevant in the first few weeks, higher for younger people, and that's why we're going to make sure we follow up right away. Stopping abruptly can be harmful as well. Then you're going to build a follow-up plan. So AI can be a really great tool for patients. They're definitely using it. Of course, we're going to be skeptical because we're already navigating a gazillion things too. But I want to talk about how AI can work for you as well. And so there are a lot of AI tools that are available for healthcare providers. And this is going to generate a word cloud. So if you put in your response, it's going to just show up on the screen. So how do you use AI in your practice currently? Transcription, AI scribe. Some tools that I'm using. So I use AI scribe. I love it. If you didn't guess from my bio, have ADHD. And I always found it really challenging and mentally draining to listen and write and examine and think and diagnose at the same time. And so for me, AI Scribe has really helped to lighten the mental load during the clinical encounter. We're beta testing right now an AI fax filer, which is really nice because it generates a little summary for me. And normally when my staff put in faxes, I don't get that. So a lot of people are using AI Scribe. I think that's the most common thing that we're seeing adopted across healthcare practices. We do see open evidence as an AI tool as well. So that's a tool to search available studies, summarize them, link them to you. And so when you ask it a question, it's giving you the studies that are available. People are using AI to look for resources, create memos. Some people aren't using AI at all. Sometimes we're summarizing large files. Another way I really like to use AI, because nobody taught me how to write in a medical legal language, and I just struggle with it. So I'll often use AI tools as a pass to put something in a more appropriate language as part of the process, not as the end of the process. Perfect. Okay, so why should you consider using AI? Well, we have a little bit of a burnout problem in healthcare. I don't think that's a surprise to anybody. A 2024 study, this was AMA, so American, found 43% of physicians reported burnout. The positive note is that is down compared to 2021, but of course, COVID times, burnout would have been a lot higher. We find people are spending about 3 hours a day, primary care clinicians, on clinical documentation. I've certainly had days I spent more and days I spent less. We're seeing, if you add that up over the course of a week, that's a lot of hours just on documentation and administrative tasks. A lot of physicians have considered leaving medicine, and we know that burnout is a big problem in that. So burnout's an issue for healthcare retention, as well as recruiting healthcare providers. AI tools can be used as a burnout intervention. So this was a particular study where they found at the start of the study about 51.9% of providers reported burnout. They used an ambient AI scribe for 30 days and it dropped to 38%. Personally, I can say definitely I feel less burnt out using AI. I feel a little burnt out having to think about all the AI tools and try to stay on top of it all the time. So we know it can help reduce cognitive load. After hours documentation can help you stay present during the patient visit. Eye contact is really important, and it's really great to not have to look at my screen or my keyboard. It can also improve urgent access to care because it can, in theory, free up time for more appointments. If you're already running over capacity, we're probably not adding more appointments as a result, but just something to consider. So there's a lot of different AI tools. So we have scribes. I think a lot of people are familiar with that. We have AI tools that can do form completion for you. And so it's often built into an AI scribe where you've done your note from the visit, you upload the form and it fills it out. There's also letter formalization. So I use this a lot for emails. I sometimes can use language that's a little intense. And so that's a good tool for me to calm things down a bit. There are also AI receptionists. I personally haven't tried that out yet, but it's a way to kind of lighten the workload on your front desk staff and automate things. So if we think about the implementation of online appointment booking, gave patients another path instead of just talking to a person to get things booked, this is kind of the next step in that pathway.
Now, we're not going to dive too deep into legal and compliance, but just for some considerations when thinking about using some AI tooling, where do you stand in regards of like PHIPAA, HIPAA compliance? What do you need to be on the lookout for making sure that you're protecting your patient's data? And so even if any vendor you're looking at is based in Canada, there is a good chance they're actually using AI infrastructure based in the States. And PHIPAA actually cares about where the data goes at the end of the route and also holds you as the primary custodian of that. So it's very important just to recognize that even if you're looking at a solution that's based in Canada or a company that's based in Canada, there's a chance it might be going to the States. And HIPAA compliance doesn't necessarily mean PHIPAA compliance, which is very important to know when assessing these things. Wait for that. So yeah. A little breakdown of the differences between these two. There's just a very high amount of scrutiny around protecting patients' information in PHIPAA compared to HIPAA, as well as how much you, the healthcare data custodian, is responsible for that. A key thing to keep in mind here is that any data that goes in the US might be subject to any sorts of subpoena by these acts, and you might ultimately be responsible for that, which is kind of worrying. So it's good to look for some green flags and red flags in any of the agreement documentation before you use any AI tooling. Once again, Always consult a lawyer, but it's good just to know that these things exist and keep them in your mind. So some good green flags we're looking at here is like explicit positioning in Appiah. Data retention is very, very key. So how long are they holding on to any data you send them? If there's any hallucinations, what are they going to do about it? Are they just going to say like, oh, we're not responsible, that's up for you to handle? Out-of-line data sub-providers, so being clear of where they're sending their data for processing. And another key thing is audit logging and access. So if there's any ever issue, do you have access or can you get access to what happened if there's any situations using an AI tool whatsoever? And lastly, and I think this is going to be important for the future, do they have options for local or on-premise hardware? Because then you get to sidestep a lot of these issues if the data's not going anywhere. But some key red flags to look out for is saying they're HIPAA compliant without a BAA, I think that's Business Associates Agreement, yeah. No mention of PHIPAA, no explanation where the data goes, and really avoid these phrases because this just means they can do carte blanche with patients' data for anything in the future. Vendor may use this data to improve services, may retain anonymized transcripts, things like this. Very scary stuff. So some key takeaways.
So the data is really clear in terms of AI use. We know at least a third of adults are using AI when it comes to their healthcare. Not everybody is going to disclose that to their healthcare provider, but it's important that we consider that when we navigate things with them. Our role as healthcare providers is shifting. Instead of being the primary information source, we're now contextualizing information that they're arriving at the appointment with. It's important that we maintain good relationships with our patients and that we can act as an individualized guide to guide them through their healthcare journey. We can remember the ASK framework, so augment, stay skeptical, and keep your healthcare provider in the loop. It's important to validate curiosity while also gently correcting misinformation. We want to build trust and keep patients in care. AI can work for you too. Ambient scribes have shown to reduce burnout from about 50 to 40% within 30 days of use only. Imagine what that can do for you over a few months or over a year and what other tools would help relieve any burdens that you face in your practice. Be mindful when you're evaluating an AI tool of privacy laws. If you're able to have all the hardware on site, essentially data doesn't leave your clinic, that's always going to be the safest option. Ensure appropriate safeguards are in place for data privacy and security. And just because something's HIPAA compliant does not mean it's also PHIPAA compliant. So we actually did okay on time, woohoo. So we wanted to open it up to questions, questions about AI, questions about mental health and AI. Feel free to chime in.
Thank you both very much for an outstanding talk on a very, very important area and for providing some guidance on how to navigate an increasingly complex and rapidly expanding world of AI in mental health. So questions in the room?
Yeah, excellent presentation. Thank you. Just on your last point, the safest option is to have everything stay in your clinic, but can AI really stay in our clinic? Is that not, by definition, leaving our clinic?
No, actually. So if all of the hardware using to run all the models and everything, it would, can be on premise, like in clinic, then everything would stay centralized. And even though these models are, they look large, like the state of the art, the frontier models are incredibly large. They use all this computing, but that all, as we're progressing, that also means the older models are getting smaller, more capable, and faster. And in very cheap hardware, you can actually run very capable models that could do things like AI scribes, voice transcription on equipment that could just be in your office and doesn't have any communication to the outside world. And so then you are then you retain all of the control over the data. So you're now fully PHIPAA compliant without even needing to worry about it. Yes, in a lot of ways, because the industry is moving so quick, it's I can't like point to an established solution there, but all of the work is there, the hardware is there, it is possible, and we're just waiting for basically the commerce side of it to catch up. But it is feasible right now.
Thank you. This is so interesting. This is going to sound a little conspiracy theory oriented, but I am curious because we're hearing from other sectors and even just talking about reception and lightening the load and what that might mean for job replacement or, things like that. I am curious if it's like possible that like tools like AI scribes could be used, the data, to train an AI, even on the art of a clinical encounter.
I think the short answer is yes.
Already happening.
And that it's already happening. And the long answer is whether or not your data is being used to train really depends on the tool and what that agreement is. If the agreement states they can use that data and retain it to train models, then it likely is being used that way. And I think that speaks to the concern I'm seeing more on our younger population as well, is this fear with AI broadly about job security and like, oh, why should I work hard in school and train to be such and such if AI is just going to take my job? And I think that's a fair thing to keep in mind as we explore AI tools. There's so much inertia behind AI and tech that I think the reality is it is happening, and we're likely going to see some major shifts in terms of education, careers, and how society works in general, I feel, but that's maybe a bigger talk.
Great. I'm curious, knowing that there's so many different AI scribes out there and there seem to be more coming up every day. Are there any that you're aware of that if somebody in the room or joining online was considering using an AI scribe that is PHIPAA compliant, that the data doesn't travel across Canadian borders? Are there a few that?
I don't know specifically about where the data is retained amongst all the providers, but generally Ontario MD creates vendor lists for tools for us to use, and they will assess and validate whether a tool has met certain parameters and criteria for use. And so looking at that list is helpful. There was the program a year ago to where they funded AI scribes for us to use. And so I would start looking at that list because any vendor on that list was assessed, I believe, through Ontario MD. When I first started to use an AI scribe, it actually took me a little bit to get on board with it. I thought, I don't have the time to sit down and learn how to use a new tool. I'm really good with my template and stamps, and I'm a really fast typer. Nothing's wrong. I'm just going to keep doing what I'm doing. I think the reality is it takes like 5 minutes to turn on an AI scribe and log in and use it for the first time. They all come with pre-built templates, and they all have guides on how to use them. There are tools that are created more locally and then tools that come from abroad. I don't want to speak to any one particular tool because I haven't used all the tools that are out there, and I don't want to like represent any tools that are available. But if you look at the Ontario MD list, that would be a good place to start.
Great recommendation. Oh, sorry, great recommendation. Thanks. Thanks very much for that. I don't think there's any questions online. I don't see any more in the room. So thank you both again very much. And we're about to take a bit of a break. I think we'll be reconvening at 3:15. I'd encourage you all to stay. We have one more talk at the end of the day. Dr. Chris Clarkstone will be speaking to you all about recent advances and an update on rTMS, but not only giving the clinical update, but he'll also be providing some guidance on how to get your patients, at least locally, to be able to access rTMS without any type of additional charge, which I think is really good news for the region. And Chris will be sharing a bit more about that during his talk. See you at 3:15.
I think that's okay. Little addition to the agenda. Sorry to take you away from your break a little early. Oh, thank you. That's perfect. A short one. My name is Deanna Brady. I am Vice President of Patient Access and Partner Experience at Homewood Health. And Following our excellent presentation today on our eating disorder program, we recognize that there was a few questions that came up primarily about access and funding and getting into the Homewood Health Center. So I wanted to kind of myth bust a few of those, some of the questions that had come up. We did mention that our wait time right now for our fully funded OHIP beds, of which Dr. Lalonde shared, we have 2, but have temporarily opened up an additional 2, that wait is about 2 to 3 years. But I just want to take a second to expand on that and explain that. The 2 to 3 year time frame would be based on those 2 individual ward beds and an individual completing our 16-week program. So that's kind of what that time frame is based on. Unfortunately, given this population, we do see a high number of early discharges coming from that program, anywhere from probably 30 to 50%. Not something we want to see, but that is accurate data. And so given that information and also the number of individuals who do fall off of our wait list before even coming into program, just for various reasons, they're not ready for treatment, et cetera. The wait list is actually probably closer to that 6-month mark, I would say. So again, the 2 to 3 year wait list would be looking at only those 2 beds, and that's for all individuals completing the 16-week program. So I hope that helps a little bit to understand that piece. The other piece is the funding aspect. So for individuals coming into the Homewood Health Center who are Ontario residents and have a valid Ontario health card, there is a per diem rate. And that can be covered a lot of times by extended health benefits. So your insurance plans, so Manulife, Sun Life, Green Shield, et cetera. And a lot of the individuals coming in will either have their own insurance or will still be on a plan by their parents, et cetera. So really want to keep that in mind, that there is a lot of opportunity for people to come into the health center through those extended health benefit plans. Yeah, and then just with the 2 ward beds, just to remind everybody, we have added the 2 additional ward beds, but that is a temporary measure right now. And then as far as access is concerned, again, extended health benefit plans and self-pay if there is that availability. So I hope that helps clear things up a little bit. Does anyone have any questions for me to further clarify? Yeah. Yeah, of course. Thank you. Yes. So a lot of people, yeah, it's like, I don't know if I have coverage. I don't know that. So when a referral is sent in and an individual shares with the intake team who their extended health benefit provider is, we will send similar to the dentist, we'll send our letter of an estimate to the insurance company to confirm whether there is coverage on that individual plan or not. So I don't want to say that everybody that has Manulife, Sun Life, et cetera, will have coverage for Homewood. However, we will certainly send that out and confirm if there is coverage on that particular plan. We are considered a hospital when it comes to insurance companies. So a lot of times there is that coverage available there for their whole stay.
The other question just came up at the table in terms of how do you complete a referral? We are is available online on our website. We're on Ocean as well.
Yep.
So there's multiple different avenues to complete a referral to any of the elective programs.
Yeah, absolutely. So yeah, Dr. Lalonde mentioned, yeah, so on our website, there's a referral form for any healthcare provider in Ontario. There's Oceans for e-referrals. And we also accept self-referrals or what we call a self-initiated referral, where an individual can contact us and say, I'm interested in coming into the health center. And then we'll ask, are you working with a healthcare professional to kind of support your admission so we can gather more information and collateral to ensure we're bringing the client into the right program at the health center. All right. Thanks, everyone.
Great. I'm very pleased to introduce our final speaker of the day. Our final speaker is Dr. Christopher Clarkstone, a psychiatrist with the Integrated Mood, Anxiety, and Addictions Concurrent Program at Homewood Health Center. In addition to his clinical work, Dr. Clarkstone serves as a medical lead for the repetitive transcranial magnetic stimulation service within Homewood's interventional psychiatry service, where he supports the delivery of evidence-based neuromodulation treatments. Dr. Clarkstone completed his psychiatry training at McMaster University after earning his medical degree from the University of Ottawa, and is actively involved in medical education across academic and clinical settings. His clinical interests include mood and anxiety disorders, concurrent substance use, and innovative approaches to care. Today, he'll be presenting on rTMS, evidence, referral, and patient support. Please join me in welcoming Dr. Chris Clarkstone.
Hello, everybody. Get right into it. In terms of disclosures, other than being an employee of Homewood Health Center, I'll also be talking about some treatments that are provided at Homewood, some of which are OHIP covered, some of which are not, and I'll be clear in identifying those. Other than that, I have no disclosures. Okay, in terms of learning objectives, my hope from this is that we're going to talk about what is rTMS so that you know a bit more about it so that you can talk with patients about it in your practices, but not necessarily know the amount that you need to know if you're the one providing it. And then how to identify who may be a good candidate for rTMS, and then ultimately how to refer and what treatment looks like, and how to continue to support patients while they're receiving rTMS. So to start off, I'm just going to ask people to raise their hands in terms of, I'm going to ask about if you're very knowledgeable, somewhat familiar, or less familiar about rTMS. So starting off, who here is very knowledgeable about rTMS? Okay. Somewhat familiar? Okay. Less familiar? Okay. Who here has ever referred anybody for rTMS before? Okay, a few hands. And then we're going to look at this. We're not going to go through all this right now, but through the presentation, we're going to cover some of these cases. And right now, maybe kind of look at them, think in your head, yes, no, can they do rTMS, can they not? You can write it down if you'd like. So kind of the first one is someone with bipolar disorder. The second one is someone who has not tried medications and only therapy. Someone with a history of febrile seizures. Someone with metal in their head, someone with severe depression, and someone who has failed therapy, medications, and IV ketamine. So to start off, what is rTMS? So rTMS is a non-invasive neuromodulatory treatment that is first line for the treatment of treatment-resistant depression, as well as has evidence for other mental health conditions. Basically, what you do is you place a coil beside the patient's head, like this image shows, or in the last image, it showed more of a helmet. Inside of that coil, or inside of that helmet and that device, there's a coil. It's attached to a machine that sends rapid electrical pulses through the coil. When it does that, it creates a magnetic field. We then point that magnetic field at a very specific part of the brain, and it is a different part of the brain for the different mental health conditions. So it does depend, where we're targeting does depend on the condition we're treating. That magnetic field then goes through the skull, through the CSF, hits the brain tissue, and activates it. So it causes electrical pulses to go through the brain, through circuits, and that is what treats the condition by strengthening certain circuits, weakening certain circuits, the changes that it makes there. As I mentioned, it's non-invasive. We don't have to give medications or anesthetic. Compared to other neuromodulatory treatments, it's quite well tolerated and much less bothersome to your life. There's still some commitment that you have to have, but we'll talk about it later on in the presentation. Compared to things like ECT, IV ketamine, other neuromodulatory treatments, it takes up very little of your day, and for the most part, you're able to go on with your day. So what can it be used for? I've already, spoiled some things about it, but when we look at indications both by Health Canada and the FDA, 3 things are approved by both. So in Canada, currently, it is approved for unipolar depression, OCD, and smoking cessation. Okay? There's evidence for other things. The FDA in the States has approved other things such as MDD with anxious distress. They've approved adolescent depression, which in Canada that's not yet approved by Health Canada, but may be coming down the pipelines, as well as some other neurological indications. But in Canada, it is just these 3. And at Homewood, currently we only offer treatment for unipolar depression, but we are excited to announce that we soon, in the next coming months, we're going to be offering treatment for OCD as well as smoking cessation. For today's talk, I'm going to focus in on depression. Okay. So when we look at the evidence for unipolar depression, rTMS has been around a lot longer than most people think, right? It was approved by Health Canada for MDD in 2002. I think a lot of people think it's a much newer treatment than that, but it's been around for quite some time. In the CANMAT guidelines, it is a first-line treatment in terms of neuromodulatory treatments for treatment-resistant depression. I'm going to point your attention to the table there. This is straight from the CANMAT guidelines. And one thing you'll notice, and we'll touch upon this in a later slide, but ECT is first line for severe MDE. rTMS is first line for treatment-resistant depression. And those denote 2 different things, although sometimes people think they're the same thing, and we'll get into that a bit later. When we look at response rates, it's 40 to 60% respond. That's at least a 50 improvement in their depression. That's what response means. Now, most studies and most clinics actually quote 50 to 60% response rate. I've included the bottom as 40 because that's the bottom that the CANMAT guidelines puts. When we look at response, it's about 30 to 40% of the responders remit, meaning at the end of treatment, they no longer meet criteria for a major depressive episode, which is quite high, as we'll see. So I really like this slide by Bacon et al. So basically, it looks at comparing rTMS treatment to psychotherapy and various numbers of antidepressant trials. So if you look all the way to the left, you're going to see response and remission rates for someone treated with psychotherapy as the initial treatment. Then you're going to see psychotherapy plus meds. And then the third one is first trial of antidepressant. And the antidepressant data here is taken from the STAR-D trial, which is a seminal paper in psychiatry. It is the paper that all psychiatrists quote the response and remission rates of antidepressants. So if you look at STAR-D, you look at psychotherapy rates, you're hitting about the 50% mark in terms of response, a bit lower for remission. But then, what the STAR-D trial did is it looked at subsequent treatment. So you fail one antidepressant, how many people respond to the second? Then how many people respond to the third, then the fourth? And already at one failure, which is the 4th bar, we're down to about 20 to 30% response rate. And then it gets worse and worse as you go down to 2 failures, 3 failures. What we see on the far right, the second last one on the far right, is rTMS data, right? So again, it's showing 50 to 60% response, 30 to 40% remission, which is higher than trying your second antidepressant. And the thing to think about is rTMS trials, because rTMS is a treatment for treatment-resistant depression, with the classical definition of treatment-resistant depression being failure to 2 antidepressants, right? The data for rTMS is based off of that, right? All the people in these trials typically failed 2 antidepressants already. But when we compare it to 1 failure of antidepressants, it's also better than that. And then the last bar is when you combine psychotherapy with it too, and how great are the results there. So again, this is, if you're going to remember something, this is a really key slide when we look at evidence for rTMS. They've also compared in treatment-resistant patients rTMS to trying another antidepressant, trying adjunct treatment like Abilify, or doing rTMS. And in the Ascertain TRD trial, what they found is remission and response was greater in the rTMS arm than trialing a third antidepressant or adjunct. How about bipolar depression? So right now, bipolar depression is not approved by the FDA or Health Canada as an indication. So it is an off-label treatment. However, there is breakthrough device designation by the FDA, which is kind of like a fast track for a treatment to be reviewed in order to eventually get approved, as well as to allow patients to get access to it. And when we look at response and remission rates, it's fairly similar to unipolar, although slightly less. And so we've got a paper here. It's a good review that looks at all the data in bipolar depression from 1995 to 2025. And when we look at response and remission rates, it's slightly lower, but still good, in particular compared to sham. So response rate of 46%, remission rate 28%. So if we go back to those cases I put up at the front, here we have a patient, 42-year-old or 40-year-old male, bipolar disorder, alcohol use disorder, and early remission. And yes, we can do rTMS. There is evidence for it, although it is an off-label treatment. And so at Homewood, we do offer rTMS to patients with bipolar disorder. And here we have one patient that I saw who had tried ECT but became violent with the anesthetic, so the team stopped that. They had even tried an MAOI and had quite severe bipolar depression. They came, did rTMS, they responded well. I'd say this graph doesn't look that, not that amazing, I think, compared to some of the ones you're going to see. But for this patient and this patient's family, rTMS was a marvel. They had never felt as good as they had, and they weren't hypomanic or manic, and they became much more functional. And so even though the numbers, they show improvement, maybe not as impressive as some we're going to see, for the patient and their family, it was a significant improvement. We have a second patient, similarly had tried multiple treatments, lack of response, and did have a positive response. Let's talk about inclusion and exclusion criteria. I've put at Homewood. I'll point out some of these inclusion criteria will be consistent across Ontario. I've heard that we have some people online that may not be from Ontario, and I unfortunately don't know all the criteria in all of your provinces. But I would say they generally are similar across the board. And in Canada right now, we are trying to standardize things because unfortunately it hasn't been very standardized. So when we look at it, so it's for unipolar and bipolar depression, the patients do need to be 18 years or older as it's not approved yet for adolescents. And typically, up until a few months ago, the criteria was the criteria for treatment-resistant depression, meaning failure to 2 antidepressants. However, Ontario has launched a provincial program to have rTMS more accessible to patients and also covered by OHIP. And as part of that program, they're looking to standardize across the province. And so they have come up for unipolar depression. These are going to be the criteria across the province for OHIP-funded rTMS. And they've changed significantly. And if you can think back to that graph I showed you with the medication failures and compared to rTMS, the new criteria makes sense. So instead of failure of 2 antidepressants, it's now failure of 1 antidepressant or psychotherapy. That's a major change. Now, the psychotherapy, it has to be an evidence-based psychotherapy. If someone comes to us with severe depression and all they've done is supportive psychotherapy, we're going to consider that non-treatment because that's not evidence-based for the treatment of severe MDD. So, it's got to be a course of CBT, IPT, other evidence-based psychotherapies. But now technically patients don't need to try a medication, but have done psychotherapy. So thinking of medically and psychiatric complex patients that are on a lot of medications already, and there's concerns of adding on an antidepressant or an antipsychotic due to metabolic side effects or other side effects, this opens up for them, or patients that just can't tolerate side effects from medications. So as long as they've been able to do some psychotherapy, they technically can qualify now. For bipolar disorder, because it is not yet approved, our policy and most clinics will default to the definition of treatment-resistant depression. So 2 failed evidence-based medications. And for bipolar disorder, we also ask that they be on a medication that has some anti-manic properties, because like most treatments of depression, rTMS rarely can induce hypomania or mania. So going back to this one, we know that this patient can get rTMS, even though they haven't tried a medication. I don't actually have a case to go along with that one because we haven't had a patient yet where that's been the case, although I did just see one in consultation last week, but I don't have one right now. When we look at absolute exclusion criteria, so severe depression with psychotic features, ECT is the recommended treatment. There's also some case reports where rTMS may have worsened psychosis, but there's other case reports that say the opposite, right? It's unclear, really. However, it is recommended if a patient is that severe in their depression that ECT should be trialed. It has more evidence for the treatment of that and is approved for the treatment of that. Seizure disorder or history of rTMS-induced seizure. Patients can have other types of seizure events, right? We've done rTMS on patients who have had withdrawal seizures. We won't do it if they had it last week, but if they've had withdrawal seizures in the past, or if they've had febrile seizures, they can still go ahead and do rTMS. It's only really seizure disorders. Implanted cardiodefibrillators or pacemakers. Across the province, this is considered an absolute contraindication unless you are a site that has access to cardiology on site. So Homewood does not have a cardiologist. Many of the sites that will be delivering rTMS across the province don't have access to a cardiologist. So it will be rare, I believe, in Ontario that will be a non-exclusion criteria. And then lastly, ferromagnetic metal in the head. So you can have metal in your head as long as it's not ferromagnetic. Often to figure that out, we need something in writing from the neurologist or neurosurgeon. We are not experts in surgical tools or things that get implanted into people's heads. As long as we can get that collateral information, we can go ahead with it. So going back to the cases, right, we already know that this patient, even though they've had febrile seizures, they can go ahead because they don't have a seizure disorder. So we have a patient who did have a history of multiple febrile seizures as a child, failure to respond to multiple treatments, and they did have significant improvement in their depression. Going back to this case, I've put it in orange because it's a maybe, right? As long as we can figure out if the metal's magnetic or not. I'd say most surgical implants going into the head nowadays are not magnetic. And if a patient's had an MRI after surgery, that's usually a good sign that it's not magnetic. So as long as we can confirm that, we can go ahead. So we had a patient who had a recent craniotomy about 6 months prior to rTMS, had a metal skull plate put in. We confirmed it was non-magnetic with a neurosurgeon, and he had a significant response to rTMS, as you can see. So how about relative contraindications? So these are ones where we'll still see the patient in consultation, and depending on the situation, we may or may not go ahead with rTMS. So pregnancy, now there's a theoretical risk that rTMS may impact hormones that then may impact the pharmacy. That's really more so theoretical. There have been studies that have found rTMS safe in pregnancy, including there's studies that look at children born to women who received rTMS while they were pregnant, and there's been no developmental or cognitive or learning impairment associated with rTMS during pregnancy. History of stroke, brain tumor, brain bleed, severe brain injury, basically damage to the actual brain tissue just increases the risk of having a seizure. Unconfirmed seizure or fainting episode, what we're worried about there is, have they had a seizure? Do they have a seizure disorder? If they keep fainting and we're not sure why, is it because they're having seizures? So we just need to figure out, is there a seizure disorder going on, or is it less likely that that's the case? The next two, anticonvulsants and benzos, have to do with reducing cortical excitability. So basically with rTMS, we're trying to stimulate the brain, excite it, Just like how a seizure is lots of activity going on in the brain and anticonvulsant treatment reduces that activity, if it reduces the activity, that'll make rTMS much harder. It'll make it harder for us to stimulate their brain. It doesn't mean that they can't do it. I've done rTMS with patients on all of the medications I've listed there. For many of them, if they were higher doses, it did mean, though, that their dose for rTMS was higher because it took more stimulation to actually get their brain to be stimulated. And the higher we go, the more painful it tends to be, or the more uncomfortable it becomes. And we have seen some dropouts because of how high people's doses have been due to the medications they were on. Bupropion, our clinic and other clinics at one point wouldn't see a patient for rTMS on bupropion. As you know, it decreases seizure threshold. Studies have shown it's safe. There's never been a seizure with bupropion and rTMS. And so most clinics will take patients, including ours, as long as they are on 300 milligrams or less. So if you know you're referring someone for rTMS and they're on 450 of bupropion, talk to them about decreasing that, because we will. Active substance use. So there's three concerns when it comes to substance use and rTMS, and it's complicated. There's a lot of unknowns still. But the three are, so first, diagnostic. If someone has a moderate to severe substance use disorder, do we know that they actually have a comorbid depressive disorder, or is it a substance-induced mood disorder? If so, rTMS doesn't have evidence for that. The second is safety. So in particular with alcohol and benzo use disorder, as you can imagine, with withdrawal symptoms, that increases the likelihood of having a seizure with rTMS. The third is efficacy. We know chronic and significant substance use changes brain chemistry, brain receptors, and it takes time to recover. And so rTMS may be inadequate at properly stimulating the brain while the brain is still recovering from that. For the most part, we try to look for at least a month of sobriety, in particular with our alcohol and benzo use patients. In some clinics, they might wait all the way up to 3 months. There are expert consensus guidelines. There's no full clinical guidelines, and it is complicated because rTMS is also used to treat substance use disorders and research. So we know it can be safely used with substances. So it's a balance of that risk and the evidence that we currently have. Lastly, scalp tattoos and permanent makeup like microblading. If they have metallic ink in them, right, we're placing a magnet nearby. It could burn, it could distort the tattoo, or microblading, or permanent makeup that has metallic ink in it. Who is more likely to respond? Now, if you look at these two columns, you're going to see for the most part, what's on the left is the opposite of what's on the right. So someone who has good response, someone who has previous euthymia, not chronic anhedonia, time-limited depression, versus someone who their presentation is pure dysthymia, meaning they don't meet criteria for a major depressive episode. It's more so, again, chronic anhedonia, chronic low mood, but sleep, appetite, focus, energy, all of that is normal. It doesn't mean that patients won't respond. This is just what may or may not respond as well. Moderate symptoms versus severe symptoms. Severe depression actually does respond well to rTMS, but there's a line. In particular, severe symptoms of psychosis, psychomotor slowing or agitation, suicidality. Other modalities have better evidence for that, right? So again, I've already mentioned ECT has good evidence for depression with psychotic features. ECT also has great evidence or good evidence for MDD with suicidality, as well as psychomotor slowing or agitation. Certainly, we've seen patients with severe MDD that didn't have those symptoms and they responded well. I've also seen patients where we've ultimately had to transfer them over to ECT because they weren't responding. Fewer failed trials. There's not a specific number there, but someone who's failed 15 medications versus someone who's failed 3 medications. The person who's failed 3 medications potentially may respond better than the patient who tried 15 medications. Failure to rTMS and ECT. Of all the things on the list, this is the one that has the most evidence to back it. Some of this is expert consensus, but failure to ECT, typically the patients won't respond to rTMS. If they've tried everything, we'll potentially still try it with them. If the patient's doing really unwell and they've tried everything other than rTMS, we'll still try and give it a go if that is the only treatment they haven't tried, but less likely to respond. And then I mentioned, the exclusion criteria being around benzos and anticonvulsants. So again, if you're on less of that, more likely to respond. Most will quote greater than 2 lorazepam equivalents. We've done it on patients slightly higher than that. They've responded. It's not a hard and fast rule, but certainly as we get higher, again, their dose likely gets higher, and it becomes more difficult to tolerate the treatment. And then active and unminimized psychosocial stressors, right? If someone is coming here and their depression is primarily psychosocial due to certain life events that are happening, again, if those life events aren't being treated or mitigated, rTMS may not do as much for them. So going back to the cases, we talked about a female, or one of them is a female with severe depression, psychomotor agitation. So again, it's a maybe. We've seen some patients with severe depression respond really well. This patient was severely, severely agitated, pacing all day, rocking, flailing arms, couldn't do psychotherapy because they couldn't sit still. It wasn't akathisia, like lots of things were ruled out for the agitation. Tried rTMS, as you can see, really wasn't responding, switched them to ECT, and it was a rapid improvement. I was actually there for their 3rd ECT treatment, and I remember seeing them just so bright and calm and not agitated. And this was a patient that I was following before rTMS, and I'd been telling them for 7 weeks, from day one I worked with them, you need to do ECT, you need to do ECT. They didn't want to, which many patients don't due to concern around the memory side effects. And then they saw me on their 3rd ECT treatment, and they said, I'm so sorry I didn't listen to you, because it really, really helped them, as you can see. And the last case, so someone who's failed IV ketamine. I mentioned failure of rTMS in the past, failure of ECT in the past, unlikely. But even if they failed IV ketamine, if they've tried that, they can still respond well to rTMS. Again, we have a patient here, a recent patient of ours who had failed meds, therapy, inpatient and outpatient, as well as IV ketamine. And then they responded very well to rTMS. In fact, they were off work for a year, and at the end, they were restarting work later that week, the week that they finished rTMS. The risks and side effects. The most common is going to be headache, scalp tenderness, neck pain. For the most part, patients do not find the treatment actually painful. They describe it as weird. They'll feel a tapping on their head. But again, most don't describe it as painful. The headaches happen later if they happen. They're more likely to happen on day 1, 2, 3. Research has shown that the majority of headaches are more so due to the fact that patients wear swim caps when they do rTMS, because we have to draw on their scalp to know where to place the coil. And the cap is very tight across the forehead. And so on day 1, you're wearing the cap for about 20, 30 minutes. On subsequent treatments, you're wearing it for 5. So most patients find if they get headache, it does go away. For those who have more persistent headaches, many patients have said they don't even take Tylenol or Advil. It's quite mild. For those who do take Tylenol and Advil, they find it gets rid of it. And if someone does have more persistent, we'll often tell them you can take Tylenol or Advil like an hour before coming to help with that. During the treatment itself, facial muscles may contract, but it does not continue once the machine turns off. Basically, we're placing the coil about here for depression. Nerves that control these muscles run along here. And so if they get caught in the magnetic field, they'll get activated. Again, most people don't describe that as painful. I've had it. My eye twitched when I did rTMS, because to learn rTMS, you practice on each other. It was not painful. It was annoying. And so most people tolerate that. especially they're only really having contractions for 2 seconds at a time over a 3-minute period with breaks in between those 2 seconds. So most tolerate that fine. 1% risk of syncope. We've never had a patient, faint in our clinic. We've had patients feel dizzy after. Dizziness, if they do get it, it lasts like 2 to 3 minutes. They just kind of sit in the chair and then it goes away and they're good and they go on with their day. Like we have many people, they come in, outpatients, they drive themselves there, they do the treatment, they leave and they drive themselves home or to work. So very well tolerated in that regard. There can be hearing-related side effects, tinnitus. There's one case in the world of permanent hearing loss. Those were in individuals that weren't wearing ear protection. It is mandatory to wear ear protection, and so we provide that to the patients. As mentioned, it can cause treatment-emergent hypomania or mania, but it's still quite rare at 0.84%. Suicidal ideation, I've put some question marks there because it's really not clear, does rTMS actually cause this? Depending on where you go and do your training, some places, some training courses don't even list it as a potential side effect, some do. So I know CAMH's training program lists it at 1 to 3% risk. If you read the safety guidelines, Rossi et al., which is considered by everybody as the safety guidelines, they have a paragraph on it. It says it may cause it. However, it's unclear, is it actually rTMS or not? So they've done rTMS on patients that didn't have depression. The guidelines describe them as quote unquote normal, meaning they didn't have a comorbid mental illness. And there has never been a case of induced suicidal ideation in patients that didn't have depression. And so you look at, these are patients who, again, typically labeled treatment resistant, which brings a lot of hopelessness to a lot of patients. rTMS, it takes about 2 to 3 weeks before you start to notice improvement. So you start it, you're not feeling anything, you start feeling more hopeless, you ruminate on that. Again, these are patients that are already high risk of developing suicidal ideation. So is it just the course of their illness while waiting for response or due to lack of response, or is it actually the rTMS treatment? Unclear. And then seizure. So we typically quote less than 0.1%. It's quite rare. They have a registry of like every seizure that has ever happened with rTMS. It's very, very small amount. And the majority of the cases that have had seizures were people that had epilepsy or other neurological conditions that increase the risk of having a seizure. So for individuals that don't have risk factors for seizure, it's actually very, very rare to have a seizure. So let's finish off by talking about referral and treatment. So right now at Homewood, we see patients, outpatients and inpatients. You can get our referral form that is on the website. It is in the process of being updated just because we do have to add some things for the provincial program that's come out. So the form may change, but it will still be on the website. We're also currently working with Ocean to get a form up there. So we're in the process of that. You can also always call our service and they can fax it off to you if you can't find it on the website. On our current one, there isn't a screening form. On our new one, there will be a medical screening form. That just allows us, it's like a few yes or no questions, mostly about seizures and metal in your head, just so we know ahead of time before booking the patient if we need to reach out to get collateral information so we don't delay the patient receiving treatment. Once we receive the referral, we'll review it. If the patient seems to not have any absolute contraindications, we will book them in for consultation. At the consultation, it'll be determined if they are an appropriate candidate. If they are, they will then receive a lot of education on treatment, and then we will contact them with their starting date. When we look at cost of treatment, so for unipolar depression, it is now OHIP funded. Right? We are already offering it at Homewood to patients free of charge. When it comes to bipolar depression, it is not yet approved by Health Canada. It is not funded by the government, and so it does cost $180 per treatment. For OCD and smoking cessation, those also aren't covered. When we do roll those out, there will be a fee associated with them that hasn't been determined yet, just because the protocols are different. There's a lot of differences between the protocols. or a few differences. So that hasn't been figured out yet, but that is currently the state when it comes to cost. And I would say compared to other clinics, this is pretty fair from what we've heard. But the big thing is that unipolar is going to be covered or is covered by OHIP. So on the day of first treatment, we're gonna go over benefits, side effects, risks again. The patients will sign a consent form. We'll complete monitoring tools. So we do monitoring every week with patients. So we'll do that the first day. We then do cortical mapping. So basically we have to do a bunch of measurements of their head in order to find certain regions of the brain. We then find their dose, which is what we call motor threshold testing. So everybody's brain cortical excitability is different. And so we have to find a certain level for each individual patient. Then they'll get their first treatment right then and there. We'll do brief side effect monitoring, and then we'll book them in for the rest of their sessions. That's kind of what day one looks like. When we look at protocols, there are several protocols out there. The one that is recommended by the guidelines by the government is called intermittent theta burst stimulation. You don't need to really remember that. You can remember it as the 3-minute protocol. So treatment is only 3 minutes. When it first came out, it was 40 minutes. Then they had an 18-minute protocol. Now they have a 3-minute one, and it's equivocal to the other ones. It is what is recommended. So for most patients, they come in, they put their cap on, we set the machine up, they do 3 minutes, they take that stuff off, and they leave. So appointments are usually 10 to 20 minutes a day. So it is still a commitment because it is for 30 days. Monday through Friday, not including holiday. So it is a commitment. However, compared to things like ECT, where most patients are out of it for half a day to a full day, can't drive after. Same thing with ketamine, they can't drive after, they may feel sedated or have side effects after. rTMS, most patients get up and go. If they can't tolerate the 3-minute protocol because it is a higher intensity, again, most don't feel pain or anything. But if they can't, we do have other options we can do. They're slightly longer protocols, but they are still first-line protocols. And then lastly, during treatment, right? So we recommend that they still be involved with their outpatient team, right? If they have a therapist, continue to see the therapist. If they have a psychiatrist or are being followed by you, continue to meet with them. In terms of medications, we really ask you to limit medication changes. At the end of the day, generally they say try to make no medications at all. We realize that's not always possible for everybody. So we try and say if you can at least limit medication changes that impact seizure threshold. So again, anticonvulsants, benzos, don't increase their bupropion to 450 milligrams. If you ever have a question and you're local and you're referring your patient to Homewood about a medication change that you want to do with the patient, feel free to call me and I can tell you. And then we also tell patients to limit alcohol and substance use. We typically recommend that they not use during that time because those also impact brain receptors and how rTMS can stimulate their brain. After treatment, so if the patient responds versus non-responds, either way, you're going to get a discharge summary from me with further recommendations. Those recommendations may be medication, therapy. They may be referral to ECT or ketamine or other treatments. If you are in the Guelph-Wellington area and the patient doesn't respond to rTMS and would like to do ECT, we will help facilitate that internally. Like we won't send it back to you to say you have to now do a referral back to us. Like we'll take care of that side of it. But if you respond, patients always ask this, what's next? So, I mean, typically we recommend you stay on your medications for a period. It's just like anytime your depression improves, it's not recommended to suddenly get off your meds right away, right? There's a period that you should stay on it to see kind of how stability stays. Same thing, if you're doing psychotherapy, you haven't doing psychotherapy, do psychotherapy. Psychotherapeutic schools have the best data when it comes to long-term outcomes for remission. So we typically recommend that. The question comes up of maintenance versus retreatment, because most people have heard of maintenance for ECT. While there is maintenance for rTMS, it's still really in a research phase. They don't know what the protocol should look like, how many sessions, for how long. So in some research facilities, you may be able to find maintenance treatment because they are researching it. But right now, most clinics aren't offering it, and maintenance will not be covered in the new OHIP program. However, retreatment will be covered by OHIP. So as long as the patient A first responded to rTMS, because if you didn't respond, we're not going to do it again, unless something significantly changed, like you were on 3,000 milligrams of gabapentin and now you're on none, right? Like maybe we would retry you then, right? But if you haven't responded, or if you did respond and it's been at least 4 months, then OHIP will cover another retreatment. If you don't respond, like I said, you're going to get a discharge summary from us with other recommendations. If there is some sort of other treatment that we can provide at Homewood, we will also try and arrange that with the patient just to support them. And that is my talk.
That very informative talk. Questions in the room or online? Oh, sorry, the question is, what's the wait time?
Yeah, obviously that will vary because randomly sometimes you can get a lot of consult like referrals all at once, and then you can have a spurt that doesn't. Right now, I would say we probably book in our outpatients within 2 to 3 weeks, and then they'll usually start treatment within a week or two. We are expanding our clinic right now. We're going to be launching a second machine, so that'll increase capacity as well. But it's typically not that long compared to other types of mental health referrals. Again, we try, we realize these are people that are unwell and not doing well and haven't responded to other things, so we do want to get them in quickly. I've even seen, I see patients sometimes within the week that we receive the referral. I've seen patients the same day. That was an inpatient though. Obviously, it was easier to get them there the same day. So I would say probably 2 to 4 weeks. And, hopefully within the 4 weeks or so, they've been seen and start treatment. We'll see how many referrals we end up getting with now that it's OHIP and the criteria has certainly decreased. But the hope of this program is to provide funding so that if there is that much need, then hopefully the government can help expand even more and more access.
I think that's the piece that just to kind of, we've been a bit vague about it because we're still officially under embargo in terms of any official media release. Again, the great news is that we have been selected as a service delivery site for Guelph and surrounding region for ministry-funded rTMS for treatment-resistant depression. So in terms of the current volumes, that's where our wait times now. We have secured a second machine, so we're going to be doubling our capacity, but we just don't know what the volumes are going to be now that the criteria for treatment-resistant depression for qualification is reduced to failing one antidepressant or psychotherapy. Again, we don't know what the volume is going to be with the lower criteria and the fact that this is now a funded free treatment for people with a valid OHIP card. So hopefully with the expansion with the extra machine and improving our efficiencies, that we could continue to keep that wait list low, because when people need the treatment, it's important for them to get in as soon as possible.
Yeah, just a brief question with regards to smoking cessation. Could you briefly give us an overview of the data?
Off the top of my head, I actually, for smoking cessation, because I've never done it, I don't have the exact remission rates off the top of my head right now. It is newly approved by Health Canada. The protocol is quite different than, showing up 3 minutes, go on with your way. You actually have to provoke them, either with smoke or thinking about smoking. So there's a whole pre-protocol that you have to do. Same thing for OCD. You actually have to get them to engage in some sort of obsessive compulsive behavior to stimulate the correct regions in the brain before you do it. So that's why the sessions will take longer. For smoking cessation, I believe the protocol is daily for 3 weeks, then once a day for 3 weeks. So again, different timeline. I'm going to be getting training in it soon so that we can offer it here, right? But that's the majority of what I know about it. You do need a specific machine for it. There's only one coil that is approved for that treatment. We've acquired that coil, so we will be providing it soon.
Yeah, so that we've recently acquired the BrainsWay machine. We have the depression coil as well as the OCD coil, which penetrates much deeper, and then the smoking cessation coil just hits a different area. So excited to launch that, but we don't have any internal data yet because we've only been focusing on treatment-resistant depression for the years that we've been doing it. But yeah, excited to expand into these other areas that have good evidence as well. We have a couple of questions online. One of them was asking for any recommendations for good resources or references for kind of a broad overview, narrative review about the basics of rTMS, for people that wanted to kind of do further kind of reading or research on their own and increasing their knowledge and capacity.
Yeah, for healthcare workers, the CAN-MET depression guidelines do have a very short and to the point section. It's not pages and pages. So that's a good resource. One of the papers that I cited or that I have on one of those slides is McClintock et al. 2019. It's also an overview about rTMS for depression. There are a lot of general information sheets out there. So Homewood is in the process of creating a new one for patients and healthcare providers that we're going to distribute and give to all patients, and hopefully even add it to our referral form online so that that can be printed off and given to the patient right in your office, so that they have that information before coming in. CAMH has handouts and things on their website as well.
Okay, thanks. That was my question, actually. Thank you for your talk. But I was looking for more primary literature, not sort of what's available to the public. So.
Was that a comment? Sorry.
I didn't hear that. So
did we answer the question?
It doesn't sound like we did. Sorry, whoever is asking the question online, can you repeat the clarification if you don't mind?
Oh, yeah, sure. Thank you for that. But I was looking for more primary literature rather than sort of secondary handouts from other websites. So just more the basics, the science behind it. So.
Yeah. I don't know. Do they get the slides, or can we forward on the references? The ones that I put there, there's some textbooks that are very clear and to the point. Again, I mentioned McClintock et al., the CAN-MET guidelines. Yeah, I would say.
Yeah, I think that folks do have access to those references as well as online. And we're going to be providing a link to the whole recording, so folks will have access to those resources as well. The other question that was asked online, and we might need some clarification from whoever asked the question, but the question was, what are the long-term effects? So I'm not sure if that question is asking, are the gains maintained over time, or what are the long-term side effects? So I'm not sure what the question is. If you could answer both, that would be great.
Yeah, I mean, to my knowledge, there's no necessarily known long-term negative effects unless, say, you had one of the very severe and rare side effects, like say you had a seizure and during that seizure you hit your head. Like there could be long-term negative side effects associated with that. But at this point, there's no known negative long-term side effects of rTMS itself. In terms of long-term results and how people look, it obviously does vary. I mean, depression, there's lots of different phenotypes of depression. Some have slightly more psychosocial involvement. And again, if those aren't being mitigated, if we're not treating the patient really from a biopsychosocial model, and they have a lot of other psychosocial stuff, because rTMS is primarily biological, their response may be less. I would say most can, from a source I recently read, it's about 4 months to 1 year. I've had patients that it's much longer than that. We've seen patients that had rTMS, 6, 7 years ago, they were good up until some change happened in their life, leading them to becoming more depressed, and they've come back to us. But during that 5 to 6 year period, they remained well. That's why we also recommend, ongoing psychotherapeutic skill development, because that ultimately has the best long-term data.
Chris, is there any, on that note, looking at ECT and the number of years we've been doing ECT, there's certain medications that we believe maintain those gains better. Is there any such evidence for rTMS that certain medications or certain psychotherapies maintain the gains better than others?
Yeah, not yet, right? With our ECT, right, there's lithium, nortriptyline combinations, lithium venlafaxine combinations. Not yet. It's under investigation. They're looking at medications that both amplify the effect of rTMS, i.e. you give it before they do the treatment, as well as medications that you take after to help maintain wellness and recovery, but nothing recommended yet. Still in research phase.
Great. Thanks, Chris. And there was one question that came up. Somebody asked me, I think last week, and I didn't know the answer to it. I have an answer that I think makes sense, but it's not based on any evidence. But the question to me was, have there been any studies looking at rTMS on its own versus rTMS plus concurrent psychotherapy?
There have. And if we go back to that slide where I showed all the bars, it shows that the combination does better than alone, unsurprisingly. It's interesting, if you look at a lot of guidelines or, again, training courses, expert consensus, most actually recommend not starting psychotherapy during it. Again, it's something, try and focus. It's already a commitment. They don't want to overburden the patient so that they drop out. I think that's the primary reason, as well as it comes from researchers, and researchers want to know in isolation if something's doing something versus other confounding factors. But when we look at combining rTMS and psychotherapy, yes, the response and remission rates are better.
Great. Thanks, Chris. There's one more question online and one more in the room. So I'm just going to ask the question from online before I forget it. Question was, for somebody with concurrent depression and borderline personality disorder, is rTMS an option?
Yeah, and there's actually been studies that have looked at that, and it seems to show that individuals, if they do have a major depressive episode and if they have a major depressive episode, it's not just mood symptoms associated with borderline personality disorder. So the mood issues are not just emotional dysregulation, but there is that persistent low mood state that they can respond just as well as individuals without comorbid BPD, which is different than other neuromodulatory treatments, right? There's been studies that have looked at ECT in individuals with borderline personality disorder, and they typically respond less compared to individuals that just have a depressive disorder.
My question is there any evidence where if someone has, within that 40 to 60% response rate, but say they're not in remission, to repeat treatment, say after the 4 months where OHIP covers it, that it actually improves outcomes that way, or no?
Yeah, as long as there's been a response, there's actually, part of the reason why OHIP will cover the retreatment is because there's good evidence that shows that if you have responded, not necessarily just remitted, but if you've responded to rTMS in the past, you are likely to respond again if needed.
This is very similar to the borderline one, but if people have other psychiatric diagnoses, does that affect, does this treatment affect those conditions in any way or make them more likely or less likely to be effective?
Yeah, there isn't a specific comorbidity that has been shown in the literature to suggest that rTMS may be less effective other than, moderate to severe active substance use disorder. Otherwise, studies have not actually determined, if you have comorbid anxiety, you're less likely to respond. Obviously, this is a treatment of circuits. It's not like we're not just really stimulating the left dorsolateral prefrontal cortex. That's where we're aiming it, but then those circuits go all over the brain. There's cross coverage between other centers of the brain for other conditions. Certainly we know, say we wanted to treat OCD, we do point it at a different part of the brain. So I wouldn't ever tell someone all these comorbidities are suddenly going to get better. Like we are doing a protocol that's been created and has evidence for treating depression. But they're looking more at subtypes too. And like that's part of the research they're branching out. You know, there's a study where they looked at, you know, depression that is more pure anhedonic versus depression that is more with anxious distress. And they've pinpoint different regions in the left dorsolateral prefrontal cortex. And if you pointed at one region, people with anxious distress actually improve better than the anhedonic patients, whereas another location in the dorsolateral prefrontal cortex, the anhedonic depression improves more than the anxious depression. This is all still research, though. There's no protocols that can isolate that yet.
Great. And in terms of our internal data and our inputs, most of the time they're coming from Chris's program, IMAC, the Integrated Mood and Anxiety Concurrent Program, but sometimes they're coming from TSICP. They have concurrent PTSD. A lot of times in various programs, they have concurrent generalized anxiety disorder or social anxiety disorder. And we're looking at the scales, kind of PHQ-9 for depression, GAD-7 for anxiety, BCL-5. You tend to see them all drop.
We certainly have anecdotal as well as evidence based on our monitoring, because for all our patients, we are also doing the GAD-7 along with the PHQ-9, some other measures as well. And as their depression has improved, we have seen improvement in their anxiety levels as well. I've had patients who, you know, I said chronic anhedonic patients typically respond less. I've had patients who described chronic anhedonia since they were teenagers, and they felt like that was lifted. So we have seen improvement in other areas. We just can't promise that that's going to happen because we are doing a protocol that has evidence specifically for the treatment of unilateral depression and bipolar depression.
And thanks very much, Chris. We have one last question, and then we'll wrap things up. The question from online was, what is the evidence for folks with OCD and autism spectrum disorder?
There is no good evidence for the treatment of autism spectrum disorder with rTMS. There certainly is a long list of areas that are being explored and have some preliminary evidence. And most individuals that do rTMS work and researchers probably would not put autism spectrum disorder on that list as a treatment just for that. Again, OCD, it's approved by the FDA and Health Canada. There's evidence, some papers. So it's about 40% of individuals with OCD don't respond to standard treatment as is. And there are some papers with rTMS and OCD where response rate was as high as 70% within that area. Again, we have to do that provocation where they're engaging. They've actually done studies where they didn't do that and the patients did not respond. And then when they did the protocol where we're actually stimulating the part of the brain associated with their obsessions and compulsions, and then we aim the coil at that area, there's a good response there.
Great. Thank you very much, Dr. Clarkstone.
Good.
Great. So that concludes our programming for today. Thank you all that have joined us in person here in Guelph. Thank you all that have joined online. It's been a great day, and it was my pleasure to host the day. I hope you've all found it clinically useful and not overly academic, to just strike that balance. Please feel free to share your feedback informally with any of us. Again, my last plug, please complete the evaluations so we can learn from your experience. We can improve things for next year. I hope to see you all again next year, and I hope you enjoy the rest of your day. Thanks very much.